Because of the 2 females, we got late.
Sir,
Live.
now we are going to live. 5,
Wait,
4,
wait. Yeah.
5, 4, 3, 2, 1. Start.
Yeah, very good morning, everybody, and thank you for joining us today on this webinar, which is going to be for few hours and primarily will be operated by Dr. Satish Jain. My name is Ambrish Sahai, and on behalf of Sun Pharma, I welcome each delegate, each viewer. During these unprecedented times when we all are surrounded with uncertainties, I hope and pray that all of you are safe and are doing well. I believe that with faith and optimism, we shall overcome the scenario of COVID worldwide. We will be very soon coming out of these issues. We are indeed delightful to have our eminent speaker, Dr. Satish Jain, who's going to discuss the topic on facial nerve today. Together with Dr. Jain, we have eminent speaker, Dr. Tissa, Dr. Makritzes, from then Dr. Paramita Shaha, and we have Dr. Madhuri from India. Dr. Paramita is going to be our moderator for the day. Without further ado, I would like to hand over this session to Dr. Rajeev Pachauri, sir, to start and kickstart the proceedings. So with this, over to you, Dr. Rajeev Pachauri.
Good morning, dear friends, all around. 1 second, my phone is yeah. So we are again with this is our 8th series of this Explore the Legends with Dr. Satish Jain. Today the topic is facial love. I think the most untouched part of the ENT, because we all know very little about the facial love. We know as a little bit of the anatomy, etc. But I think today we will discuss A to Z of this facial love. And 1 second, slides here is just going on. We will just discuss about the facial love, and we all know about the facial love from where it is arises and where we terminate, but so many things has to be discussed, and I would like to request our panelist, Dr. Madhuri Mehta, and our foreign friends, they should discuss as much as about this part, and I would like to thank Sun Pharma also for sharing this 1 second. Slideshow. So actually, we all know about the facial love very little bit. I think this much we know. This is and we should go in detail. Facial love should know well about. And this is a cadaver and light demonstration by Dr. Satish Jain. I would like to thank Sun Pharma for this today's this academic feast. And let's go to Dr. Satish. Paramita, anything from your side? Dr. Madhuri has also joined from ISAR.
The team welcome you all for the most awaited webinar, as I've getting back facial nerve, which is very important topic for all our ENT surgeons. It is really not easy to conduct a dissection as well as a live surgical demonstration on the very same day, which we are so thankful for this event to make this thing possible today for us, so that we can learn in and out about facial nerve. And we have Dr. Rajeev Pachauri, sir, of course, and Dr. Madhuri Mehta, who has been my teacher always. We have all international faculties with us. Professor Tessa, Dr. Ralph, we can have good discussion on facial nerve and anastomosis in and out. So to all the audiences, the question answer session is open. You can ask any questions, and I'll make sure each one of your doubts are cleared, and we'll have a good discussion today on facial nerve. I think we'll move on to Dr. Satish Jain, sir.
Yeah, before Satish, I will say a few words. Paramita, if you permit.
Good morning. Good morning.
Morning. Hi, I'm Ashish Bhumkar here. Facial nerve surgery, I think, is the surgery for the youngsters and the future of India and the world. There is, if you think about it, there is no brand name surgeon all over the world. This is one surgery which I think people who are about 5 years into practice should be picking up. So please talk to your friends and get them online, because this is going to be a life-changing experience for a lot of careers, especially the youngsters. Yeah, this is very important. We will have Ralph joining in at about 11:30 or 12, and Tisa, she's in Boston. She's a mother of 3 kids. She's actually, I call her the queen of the facial nerve. The queen of 7 is what I call her, and it's a joke between us. But truly, she's the president of the world's only facial nerve group or a society. It's called as the Charles Bell Society, and she's fantastic. I've been to her and I've seen her several times. A brilliant surgeon and a brilliant academician. She's, after all, a Harvard brain. She will join us a little bit later, and she'll speak about, between me, Satish, and her, we decided, she will speak on the free gracilis, the harvesting, and the coaptation as it happens. That is my specific area of interest, because that's the preferred surgery for congenital facial palsy. With my microtia and hemifacial microsomia, we get a lot of congenital facial palsy, and that's the preferred procedure, which gives you a spontaneous smile. And as we go through the day, as we go from the temporal bone out, we will speak about the value of spontaneous smile. The facial nerve surgery is not about an electric teaching a muscle and the muscle twitching or the muscle having an action. There is more to a smile than just the muscles moving. And this is where actually, between the average and the ordinary, the extraordinary facial surgery dedicate their life to, that is what they aspire for. So today's course is about that. First, Satish, with his grand style, will explain to us and show us the entire course from the origin right down to the last destination. And I think Sandeep is calling me. So we'll go ahead with Satish. And in between, I'll keep making some relevant comments. Yeah. Okay, Satish, over to you.
Okay, Ashish, thank you. Am I audible?
Yeah.
Yes, sir. Audible.
Okay, so good morning, everyone, for this
Good morning.
very good morning of this Sunday. And today is a big day for us. Like Ashish said, on this topic, we have some special guests to enlighten us, like what she said about Professor Tessa Hedlock, who is, like Ashish says, the queen of 7. Believe me, she is heading the Department of Facial Nerve Surgery at the prestigious Harvard Institute, where there is a specialized Department of Facial Nerve Surgery. And she has an immense experience of over 25 years exclusively working on facial nerve, with more than 150 publications on it. Imagine how much the experience she is having. We met her for the first time a few years back with Ashish and Madhuri at Spain, and she mesmerized with her work, and we were totally glued to that. So we had our plans to invite her sometime, and this was the opportunity where she is going to enlighten us with some of her technique. Then we have Professor Ralph Magritte with us today, who is going to join us soon. Ralph is again a ENT guy with a special interest in facial plastic surgery, and is presently heading the Department of ENT and Facial Plastic at the University Hospital in Berlin. So Ralph, we had an opportunity to interact with him last year at Gauri Belsare's workshop in Pune, where he did some live surgeries and some presentation. Was very, very impressive. So we hope to see him soon. Then we have our own today, what I call her, Jhansi ki Rani, Dr. Madhuri Mehta with us.
Thank you, Satish.
You all know Madhuri doesn't need introduction. She's so popular amongst ENTs in India for her work, and she's amongst one
Right
of the...
now, I'm on her yogurt picture.
Pardon?
She's
Oh my God, really?
You're on the other side.
Ashish, she is Jhansi ki Rani.
and youth is out.
Oh.
So she is one of the busiest female ENT surgeon in our country, and believe me, the amount of work she is doing every day. She is heading the department at the prestigious Jindal Institute in Hisar, and not only that, she is the medical student superintendent as well at that particular hospital. Regarding her academic work, she has already published two very interesting books on osteoplasty and cavityless mastectomy, and she is coming up with her book dedicated to facial nerve, the Atlas of Facial Nerve Surgery, very soon. And she has an immense experience of an interest in the facial nerve work. So what, she is here to enlighten us with her knowledge and experience today. Thank you, madam, for being with us. We'll be having some more guests today. We all know Movani
Satish,
sir.
good morning.
Hello?
Hello, Satish. Can I say a few words about you?
No,
Hello?
not needed.
Yes, Satish.
That is not topic of interest.
You know, I feel honored, I feel privileged to be a part of this mega carnival, and this topic, this star topic, facial nerve, could only be handled by a star like you. When I start looking for adjectives for you, you know, Satish, I fall short of words. I call you magician, I call you king, I call you master, I call you maverick. Still, on that, you're such a good and humble, great human being. It is really my honor and privilege to be there here with you, sharing the screen with you. I'll try my best to contribute what I have. So it is going to be great, going through the journey of facial nerve with a star master like Satish Jain. So please go ahead.
Thank you.
And a star cricketer as well. Madam, as a star cricketer as well.
Yes, star. Oh, really? That part we, forgot to include. So all adjectives still fall short of what Satish Jain is to our country. I will share with you one message I got from a Pakistani doctor. You know what he wrote when I had a conference in my place and Satish was here. One Pakistani ENT surgeon wrote that we used to think India has got Taj Mahal. We used to think India has got Amitabh Bachchan. We used to think India is lucky to have Lata Mangeshkar. Now we say India is lucky to be having Satish Jain, which is a darling of the whole country and the world. And that is the ultimate compliment to you, Satish.
Brilliant. Very deservingly so. And Satish,
Thank you, I don't think I deserve that much.
Satish, anyway, with your permission, can we open this today's day with a beautiful smile from Paramita? Because you want to see the muscles of facial.
You can see the expression.
This
the expression of joy. The expression of joy, Ashish, and she belongs to the city of joy as well.
Satish sir, this is Mahendra Varman. Your audio is not as good as it used to be. I mean, somewhere then some technical problem.
Can something be done, please?
Rajeev Pachauri with his DLIs. Every time he endorses what Satish is doing, or if he's mesmerized, his lower lip just goes, the DLI and the mentalis. Muscles in action.
Thank you, guys. And before we start, I would like to acknowledge Sun Pharma for their unconditional support to such academic activities. We are really grateful to that. And our master, Dr. Rajeev Pachauri, who has been the master behind this event, and Paramita as well, she has been the pillar and doing a lot of hard work behind the scene. Thank you all. And today's plan, let me outline you first what we are going to do today. As we all know, the day is dedicated to facial nerve. The first thing, I will enlighten you with the anatomy of the facial nerve, right from the origin, from the brainstem, to the destination, to the facial muscles. This is important to understand anatomy so that we can execute our surgical procedures accordingly. And at every point of course of facial nerve, we'll enumerate what pathologies can affect facial nerve and what best can be done to that to get rid of that problem. So right from the cerebellopontine angle to the muscles of facial expression, we'll be showing a lot of procedures to deal with injuries to the facial nerve. In the labyrinthine segment, we'll go with the middle fossa approach. In the translab CP angle, we'll go with the translabyrinthine approach. Then in the mastoid, we'll go with the transtemporal approach. Then we'll go out in the parotid, and we'll show variety of procedures can be done on facial nerve, right from anastomosis to nerve grafting to nerve rotations to reanimation using muscles and other lots of procedures on the rehabilitation of the eye as well as the angle of mouth, which has a great impact on the psychosocial, overall well-being of the patient. So this is going to be a overview of the complete procedures which one can think of doing on a facial now, and we'll discuss critically what procedure can be suited best in what condition. It's not every single procedure is required for every facial nerve injury. According to the time, the age of the patient, according to the circumstances, deformity, we have to choose a particular procedure out of the basket. Okay? So feel free to interact, ask question. Paramita is there to forward here. And I request our the guests, Madhuri madam, the Ralph and Teshar joining, and Ashish to interrupt me any time to make your comments, your suggestions. So what I have done until now, because this was shown earlier, I exposed the post-auricular region. Since my day is going to begin with the translabyrinthine approach. Translabyrinthine approach, as the name implies, it goes through the labyrinth. So we have to go all the way through the labyrinth to the CP angle. This approach is devised to address the CP angle lesion at the cost of hearing. So we are not discussing the indications of this approach here. We are using this approach to see the course of facial now. At the same time, we'll discuss how this approach can be executed as well. So that will cover our another aspect, because last time in the basic temporal bone dissection, we didn't go beyond the basics, and we have to now come to each and every approach individually. So today, while doing the facial nerve anatomy, I will show two approaches, the translab and the middle fossa as well along with that. So in this approach, we have to know the limits of our approach, the indications, and what all we are going to sacrifice and what are the advantages and disadvantages. So first of all, the lateral part is very simple. Like we all know, the limits of the mastoidectomy. The superior limit being the tegmen plate, anterior limit being the extra-aortic canal, and posterior limit being the sigmoid sinus. That's like a cortical mastoidectomy to begin with for the translab approach as well. Labyrinth anatomy we have seen in the previous dissection, so we are not going to go so in depth for the anatomy of the labyrinth, assuming that we all know that. But yes, while going through the labyrinth, I will tell exactly where exactly we are working. So in a translabyrinthine approach, we are not supposed to transect the ear canal at all. Ear canal is our anterior limit, and the anterior limit to our approach is the vertical segment of the facial nerve. This is a narrow mastoid. See that? How narrow the axis is. And once we go into the CP angle, I will take you through the intracranial tour with a 0-degree telescope of all posterior fossa structures. So that will supplement to our anatomical understanding to what we have done so far. See the color change? So this part, we should know how to do it. I will enumerate the, the landmark. We will show the details of the translab approach when we do a case like vestibular schwannoma, acoustic neuroma, very soon in our few of the next webinars. But here, once you think of doing that, your limit should be very clear. The superior limit being the tegmen plate. The dura of the middle cranial fossa is our superior limit. I hope the picture is good.
Yes,
Yeah,
yes.
it's okay.
And the voice is okay now?
Yes, yes.
Yeah.
So this part I am doing quickly. We discussed in detail last time. So just to save time, I will quickly accentuate these cells. Ashish, that problem is probably not today. When you speak, the picture is not going to go. You can test.
Okay. Yeah, I can see that. Yeah.
You can see that?
Good. So very important, what is happening here is, look at the soft tissue, the way it has been retracted way out of the surgical field. So the mastoid has to offer itself on a platter to the surgeon. That is one of the secrets of doing a good mastoidectomy. The second is about width before depth. That is the decoded version between me, Satish and Ashim of exposure. Always width before you go deep, and watch how he's doing. And that also is the secret of a good cochlear implant surgery. A lot of the times people struggle to do the posterior tympanotomy because they have not defined the sigmoid or the sinus plate well. This is the area where he is operating. If you clear this, going obliquely into the posterior tympanotomy is easier. So width before depth, because he's finished this in 5 minutes, which people will generally take 40 minutes. But watch how the side of his burr is what he's using. He's never using the tip. These are also few fine points that people have to pick up. And when it comes to an important structure, his strokes are always parallel to the structure.
Ashish, the only thing, yes, you're absolutely right. The thing to remember is don't work under bony ledges. So it is always better to widen the cavity. Width is more important first, and then we go into the depth. And you're absolutely right. The width should be really good
depth,
so that we don't work under bony ledges.
Correct. Yeah.
So that is the basics. You know, everything is important. What you said.
And that same principle goes down when he does the labyrinthectomy. It is the same thing. So he will not land in trouble. That's the principle of surgery.
See now, this last time what I reiterated, this zygomatic line is a good landmark because the Tegman plate is few millimeters above that. So still if you stay in the zygomatic line, your Tegman is not damaged. That's the beauty. So landmark with safety. And this is my Tegman plate which I am exposing here.
And defining, to me, an otologist is defined by the way he or she defines the sinodural angle. So that is something which tells you when you watch people dissecting or doing surgeries, how well you define the sinodural angle sort of speaks about your otology training or acumen.
And Ashish,
yeah,
the sinodural angle actually is a medial anatomy.
Yeah.
You know, what you see the lateral part of the dura and sinus is not sinodural angle.
Yes, correct.
Medially, in the roof of the petrous bone, where the Tegman plate is there, runs the superior petrosal sinus.
Okay.
Here, in this plane, anterior to posterior.
Okay.
So that sinus joins the transverse sinus, and that is the beginning of the sigmoid sinus. So that where the sinus joins the sinus is the sinodural angle actually.
And what is this lateral part called? Is there a name for this?
Pardon?
What is this lateral part where you are drilling? Is there an anatomical
these are
name
all
for
exentration of the cells.
cells? Okay.
See this now medially where I am coming to exactly to show you where the superior petrosal sinus joins the transverse sinus. See this? Here.
Yeah.
It comes behind to join this. And where this sinus joins the transverse sinus is the beginning of what we call as the sigmoid sinus. So this is by definition, you can see the sinodural angle. Okay?
Yeah.
See this? That is. So we have to be careful in translab approach not to damage the superior petrosal sinus. Now this approach for the vestibular schwannoma, we use it very commonly. We'll discuss in detail while we do the vestibular schwannoma case. But in that situation, the size of the approach, the access it gives depends upon the anatomy of the temporal bone. That's why sometimes it is one of the contraindications when you have a less cellularity, when the temporal bone space is narrow. When the temporal bone is not pneumatized very much, it gives a narrow access to the CP angle, and some people consider it one of the relative contraindication to the CP angle lesions. For that matter, out of all CP angle lesions, the meningioma, the cholesteatoma, whatever, this approach is mostly indicated.
Ashish.
This approach is indicated for
Ashish,
lesions
could the voice
where the
of
hearing is
Satish
already
be
gone.
more clear, don't you think?
Could the voice could get little better, yeah.
Yes.
Because
There
I
is
think
there is slight echo
we have
and
to.
over the
I
time.
think we have to mute ourselves. I think that's the mistake.
Okay.
Yeah, that is the best thing.
In
Do you have another mic?
Okay.
So something's wrong with the mic.
I don't know.
No,
Can you give
that
another
mic
mic?
is not related to this one.
Rest all voices are coming clear. Satish is a bit, like coming from a
My
depth.
voice is not clear, madam. What is the problem?
Yes, slightly better needed, Satish, because we want to hear you nicely.
Or can
So the
something be
voice
done,
is
please?
slightly
It's echoing, sir, a little bit.
echo is there.
See, my area of interest is going to be between the dura all around, between the vertical segment of the facial nerve anteriorly, the sigmoid sinus behind, that is going to be the posterior limit, and the superior petrosal sinus above. In between this, all this bone, including the labyrinth, has to go by and large for a translabyrinthine approach. So this approach is indicated as it inherently removes the hearing of the patient, sacrifices the hearing for all lesions of the CP angle where the hearing is already gone. Because then it gives the most direct approach to the CP angle, you will see very soon. So when the hearing is gone, no doubt the translab is the approach of choice.
Yes.
In acoustic neuroma, will discuss how it is important to use this approach most of the time. In spite of the so-called illusion of a serviceable hearing, it is most of the time the hearing is gone even in the acoustic. And the parameter of that audiometry is not adequate to address whether hearing is gone or not. So that is not the point to discuss now. Our goal is facial now, and in order to expose the facial now, I just wanted to show you the glimpse of the translab approach. Can you see the lateral canal?
Yes, sir.
Yes.
In the depth of the antrum.
So here, Satish.
Yeah.
Hello. Satish, would you tell how is the relationship of facial nerve with lateral semicircular canal and how to go about with posterior tympanotomy? Important landmarks.
Yes, madam. It is important. So lateral canal is a very, very important landmark which is almost always visible. The moment you open the antrum, in the floor you find the lateral canal. And facial nerve has a different relationship with the different segments of the different semicircular canal. Different segments of the facial nerve, you can say, have relationship with different semicircular canals. So lateral canal here is related to the second genu of the facial nerve, and facial nerve runs in the circumference of the lateral canal anteromedially. In the lap of the lateral canal anteromedially, which I am going to show you, and then it goes down as a vertical segment. In translabyrinthine approach, this vertical segment of the facial nerve is the anterolateral limit of the approach. This is not a very big mastoid, I tell you. This is a, you can say, not a very heavily pneumatized mastoid. But anyway.
So the three semicircular canals, Satish, you were talking. So if we consider superior semicircular canal is related to labyrinthine portion, lateral semicircular canal is related to second genu, and posterior semicircular canal is related to the vertical part. So the relationship, could you tell, with the lateral and posterior semicircular canal?
Now see the important landmark here as far as the facial nerve is concerned.
Satish
After
sir.
the lateral canal.
Satish sir.
Yes.
Yeah.
Can you clear the lens little bit or this?
Okay.
Or can you focus?
Clean the lens. Clean the lens. Yes, yes. एक जना आके यूं पकड़ लो उधर से. Okay. Thank you. So the another landmark what I have seen here is the short process of the incus. Like what Dr. Madhuri mentioned about the lateral canal here. This is the lateral canal.
Yes.
And this is the short process of the incus, which is housing here into the, through a ligament in the fossa incudis here.
Yes.
And the facial nerve, if you draw a line parallel to it, facial nerve runs immediately medial to it. So it runs in the medial circumference of the canal, anteromedial circumference of the canal, as well as medial to the short process of the incus. That's how we take these two landmarks into consideration when we plan our posterior tympanotomy.
Yes.
So if we see the same, no, I didn't change the burr from beginning. I am using the largest possible burr, and since this is a conical burr, it gives me advantage of using even in the depth without hampering the visualization. So just for the sake of demo, I am showing you the vertical canal now here, which is going to be our very, very important landmark today. Yes. Now see, if I draw a vertical line, a horizontal line from here, this point of the short process of the incus, my facial nerve is always going to remain medial. Okay? One can never damage the facial nerve. If you follow this short process of the incus, which is the best landmark, natural landmark given by the God, not created one.
At this level, what is the importance of sinodural?
Pardon? Pardon, boss?
Anger means role of caudal ridge at this level and sinodural angle. So means caudal and facial angle.
Caudofacial angle.
Yeah, at this level.
Yeah, as I go down, I showed in the temporal bone last time when we created the posterior tympanotomy.
We saw over there.
I showed that as the chorda tympani arises from the facial nerve in the lower part and ascends toward the middle ear, it forms an angle. And see the vertical course of the facial nerve.
Yeah.
See how deep it is.
Yes, it is becoming lateral and becomes lateral to the posterior semester.
See the direction. Still I am using the cutting burr, and this is the direction, and see how deep it is to the incus. Now what I am doing, I am drilling my vestibule. That is the lateral canal. Can you see?
Yes.
Yeah, we can.
Because we are doing translab, so I am drilling. Could you see the lateral canal?
Yes.
Yeah.
Superior, my limit is going to be the tegmen, the middle fossa plate here, and there at that level you will find the superior canal. We have seen that in the temporal bone dissection earlier.
Yes, you showed beautifully in that.
Yeah. While doing a translab, we must keep the anterior ends of these canals intact so as to prevent injury to the facial nerve labyrinthine segment.
Yes.
See, that is
that is
superior
an important
canal.
relationship.
And very soon we will be seeing the posterior canal. Now, see the vertical segment of the facial nerve going.
Yeah.
See the angle.
Can you point out after, hello, Satish?
Yeah.
Can you point out the facial nerve pathway there?
Facial nerve?
Facial nerve vertical part, can you show with an instrument?
This is all facial nerve vertical part.
Yes.
This is
There's
all
a little
visible
blood
now.
coming out of the sheath here.
Can you see the change in color?
Yes,
nice.
reddish,
This is all facial nerve vertical part.
Yes.
This is a narrow mastoid, I told you.
Yes.
Yeah, narrow mastoid, right?
Narrow mastoid, yes.
See the pre-sigmoid plate. This is the sigmoid sinus here. And this is pre-sigmoid plate, bony plate, overlying the cerebellopontine angle. Because my goal is not to discuss in detail the translab approach. This is just part of it. Our focus is very clear on facial nerve. So this approach is here, I purposely mentioned so that we can see this approach as well as it is needed to reach to the level of the facial nerve. Give me the periosteum.
Dr. Asim Desai also joined us today.
Yes, boss, welcome.
Dr. Asim was. Unmute yourself. Unmute
Hi,
yourself.
buddy. Hi.
Hey, everybody.
Hi, champ. Hi.
Guys.
Welcome, boss. Welcome.
Hi, Madhuri. Thank you, boss. Thank you.
Another guru joined. We welcome him. And we'll see him in action, you know. Our next webinar on the stapes is probably next Sunday. We have planned. And you'll see these maestros in the live action with their knowledge. Thank you, boss, for joining us.
Thank you, boss.
And we
Good
need
to
your
see you.
valuable input as well.
Yeah.
See now, this is pre-sigmoid dura, you know.
Yeah.
I'm just going quick here. Live surgery is a different ball game. We'll show the translab approach and how you have to protect all these important landmarks. But here I will go quickly as we have to do a lot of work on the facial nerve. So here my goal to go through the labyrinth is to reach the CP angle.
So you're trying to reach up to the CP angle from there you will be tracing the facial nerve.
Yes, that's the plan.
See now why I was saying this facial nerve is going to be, vertical segment is going to be the anterolateral limit. As we have to go deeper and remove every possible bone, right from the tegmen superiorly to the jugular bulb inferiorly and the sigmoid sinus behind to give a complete translabyrinthine axis. And see everywhere my anterior limit is this facial now. See the second genu. Okay. So to orient everybody who has joined now, this is anterior, the canal, this is the axonotic canal there. This is posterior, the sigmoid sinus here. This is superior, the tegmen plate over there, and this is inferior. In a contracted mastoid, we have not seen the jugular bulb so far. So this is not a, unfortunately, not a very pneumatized mastoid. For teaching purpose, pneumatized mastoid is always an advantage. So you can see the wide axis, better anatomy. This is the posterior canal I am drilling. See the posterior canal?
Yes.
See all three canals, and now we have to go through this labyrinth. We showed in the temporal bone the intra-auditory meatus, medial to the cochlea and vestibule.
Yes.
And if we go through this labyrinth involves the cochlea and vestibule. If I go medial to the vestibule, very soon we will be right on the intra-auditory canal. And this is the most direct access to the facial nerve in the intra-auditory canal. And this is indicated for the lesions where the hearing is already gone. So for the vestibular schwannomas where the hearing is already gone, this remains the ideal approach. This is vestibule.
Yes, beautifully seen.
See how much thick bone need to be drilled. So in a live, translabyrinthine approach, when you do for a vestibular schwannoma, it takes time to drill away this entire bone to widen your axis. Here my aim is not to widen the axis to remove any tumor. I will widen only that much that will be required to show you the facial nerve. Okay?
Okay.
So all the hard bone, dense bone has to be drilled out. So the other way to see it is no hard feelings. That's what translab is about.
This is the hardest bone in the body.
Yeah. So no hard feelings. That's the that's the technique.
Tagline.
Yeah. So Romita and Rajesh, I'm sorry, we're going to be making all this kind of noise.
No, sir. It is part of the.
Okay.
See, that is the crus commune. See how much of the drilling is required.
Yes.
In the translab, you have to go almost more than 3 centimeters down from the cortex to reach the CP angle. And very soon, in next 5-10 minutes, I will be right on the CP angle.
And in
As I am
this
going
drilling,
to-
you have to be careful about the shaft not touching the facial nerve. This is where he said you have to keep a ledge of the bone.
Yeah, and the moment I enter it, I will show you the inside anatomy with the endoscope.
Oh, lovely.
Okay, great,
I
great.
will take you through the posterior cranial fossa tube.
Okay.
See, there are many lesions or many procedures now being performed in the posterior cranial fossa for the neurootologist, like microvascular decompression, which is a very, very
Yeah.
important subject. And in that, since the hearing is intact, so we don't go by the translab approach. What we go through behind the sigmoid sinus, that is retrosigmoid. We can make a
Retrosigmoid.
small 1.5 centimeter craniotomy here behind the sigmoid sinus, here in this region. This bone at the angle of, see, this is sigmoid sinus going and then the transverse sinus like this, horizontally here. So at the angle between the sigmoid and transverse sinus, if you make a small opening, remove this bone, welcome boss, then you go directly onto the cerebellum, and if you retract the cerebellum anteriorly, you go to the CP angle. So that is retrosigmoid. What we are doing is pre-sigmoid through the labyrinth.
Yes, yes.
So these are dependent upon the course of the sigmoid sinus. So in those hearing preservation approaches, when you go for microvascular decompression, that's the most direct approach. Go behind the sigmoid sinus, between the angle and the sigmoid and transverse sinus, remove this bone, go to the dura, open the dura, retract the cerebellum, and then enter into the CP angle. The advantage in the translab is you go directly to the CP angle. Your cerebellum remains behind. You don't need to retract the cerebellum, don't need to give complications of retracting the cerebellum as well.
So the retrosigmoid is a favorite of neurosurgeons.
Yes,
huh?
and
They
believe
don't
me,
want
that is
to
a very
enter the
fast
mess.
approach as well. Very versatile
Yes.
approach. Very versatile approach. Any posterior cranial fossa lesion can be approached very fast. Had I been doing a retrosigmoid now, I would have been right into the CP angle 15 minutes before.
Till now. Yes.
Oh, yes, because what I had to do was to remove this bone segment, open the dura and go directly. Here you have to drill
Yes.
away the entire labyrinth and it takes time. That is one of the disadvantages of this approach because it is time consuming. It takes away directly the hearing, but it is the most direct approach to the CP angle. Number one, it doesn't involve cerebellar retraction. Number two, it gives the most direct and the primary access to the intra-auditory meatus, because in this approach,
Yes.
the first thing I am going to open is the intra-auditory meatus, which is going to be here. In retrosigmoid, when you remove the tumors from behind, the intra-auditory meatus is anterior to the tumor, beyond the visualization. So you open the intra-auditory meatus from behind, that is medial part, and tumors reaching to the lateral part of the intra-auditory meatus cannot be removed, or if you try to remove, that will involve sacrificing the hearing. So that is the basic difference between these two approaches. We'll discuss in the translab case in detail about the selection of surgical approach, what approach to be used in which situation, that is most important. And for every surgeon, lateral skull base surgeon, he should be well versed with all the three approaches: the retrosigmoid, the translab and the middle fossa. Two of them I am showing today.
Okay.
See now my inferior limit I am showing. Can you see the glimpse?
Yeah, yeah.
Yes.
Can you see the blue glimpse of the jugular bulb?
Jugular bulb,
I
yes.
told you this is a very narrow access to the CP angle. Can you see that?
Yeah, yeah, very narrow, very narrow.
That is the glimpse of the jugular bulb. See? Narrow access, high jugular bulb. Can you see now better?
Yes, yes. Perfectly clear.
Yeah. So now you have a very narrow access. The posterior limit is here. The anterior limit is facial. The inferior limit is jugular. Obviously, superior limit you can further go and decompress the middle fossa dura completely.
Sir,
What is
Dr.
the-
Satish Parmarkar is watching. He's
Yeah.
asking, can you comment about the importance of preservation of ampulla of the superior semicircular canal and
Yes,
safeguard?
yes, so that when you follow the labyrinthine segment of the facial nerve from the intra-auditory meatus, it prevents you from injuring the labyrinthine segment. Now here question has come from Dr. Pankaj, who is a neurosurgeon here, that this is a relative contraindication for this approach where there is a narrow axis. Yes, but still, if it is an acoustic neuroma, still I'll go with this approach. Whatever this axis may be 2 square centimeter and tumor inside may be 15 square centimeter, I still go with this approach. I can maximize this exposure by decompression all around. Number one.
Yes, yes.
Number
yes,
one,
yes.
I will decompress the sigmoid sinus behind to improve the exposure. I will push the jugular bulb below to improve the exposure. And I will decompress the middle fossa dura up to improve the exposure, number one. Number two, that is indicated only for the vestibular schwannoma, not for other CP angle tumors. The reason is, in vestibular schwannoma, the treatment is, it is not invading kind of a tumor. The treatment is intratumoral debulking. And then mobilize the tumor which is beyond your visibility. You know, your axis is narrow and tumor is beyond the axis. So what you can do? Intratumoral debulking and mobilize the tumor which is beyond the axis and bring that into the field. Bring that into the field, again do intratumoral debulking, stay outside the arachnoid plane and you can remove even a bigger size tumor. In this year in Morwani sir's course, there was a patient where I demonstrated on live in vestibular schwannoma with a 27 square centimeter diameter. And my approach was only 4.5 square centimeter. We could remove the entire tumor, I demonstrated there, through the small opening by mobilizing the rest of the tumor into it. So it is relative contraindication, not a absolute contraindication, I would say.
For a schwannoma, he's emphasizing again and again.
Again, schwannoma, yeah.
Only for schwannoma.
That can be debulked, yes.
If suppose it is a meningioma, I will go with retrosigmoid. No doubt about it. Now see the glimpse of the intra-auditory canal posterior surface. Can you see?
Yes.
In a translabyrinthine approach, you are supposed to expose the intra-auditory canal at least by 270 degree by making two troughs, by removal of the bone above and below the canal. See what I am trying to say?
Yes, you're creating tunnel above and below the canal.
Let me show you what I am trying to say. See this? This is the posterior surface of the intra-auditory canal. Can you see?
Yeah.
This is my lower limit, the jugular bulb. The upper is going to be here, the middle fossa dura. So to improve my exposure of this canal more, I have to remove this bone above and below to make at least a trough, semilunar trough exposing minimum 270 degrees of the canal. In enlarged approaches to the translabyrinthine approaches like what Mario Sana has described, you can remove even 320, 360 degree all around to reach the petrous apex from right over here. If I remove the bone 360 all around, I will be right at the petrous apex. So, depending upon how anterior your lesion is going, sometimes your tumor, what you are removing, is going far anterior, then obviously you have to remove more and more bone circumferential to this canal. Another question, the last time was asked about the cochlear aqueduct.
Yes.
Which you missed.
We couldn't show on the temporal bone. We missed that time, forgot to tell you. So cochlear aqueduct is an important anatomy here. Why so? Cochlear aqueduct is an aqueduct connecting the scala tympani, the perilymph of the scala tympani, to the subarachnoid space. And it runs laterally from here, the scala tympani where the round window is, medially to the subarachnoid space, and it ends just above the jugular fossa, just above the jugular bulb where the glossopharyngeal nerve comes from the posterior cranial fossa. So here at this point of time today, I will show you the cochlear aqueduct immediately inferior to which is the glossopharyngeal nerve, so that's a landmark. and I will show all the nerves from the posterior canal fossa, how they are ascending into the jugular foramen. So, what does it mean? Why it is important? Inferior to the intra-auditory canal, my inferior limit of this translabyrinthine dissection is cochlear aqueduct. Because a millimeter below that, if I go, is the glossopharyngeal nerve I can easily damage. So cochlear aqueduct is an amazing landmark in the translab. At the same time, once you open the cochlear aqueduct before, it relieves some of the cerebrospinal fluid to reduce the pressure inside. So that is a, a deliberate way of reducing the cerebrospinal fluid pressure inside. When before opening the dura, you open the cochlear aqueduct. I hope it is taken very clear.
Yes, very clear. And it's amazing that you remembered what you had forgotten to show.
What, Ashish?
It's amazing to know that you remember what you had forgotten to show.
And Dr. Masoom from Afghanistan, he wants to know how we can protect the posterior semicircular canal while doing the translabyrinthine, you can say decompression or translab approach.
Posterior semicircular canal has to go in the translab approach, otherwise we cannot execute the translab.
Yeah, and when we are doing translab decompression, at that time, can we save it?
Pardon?
No.
No. Translab is translab. Yeah.
Yeah, we cannot. We have to sacrifice the posterior semicircular.
Yeah, otherwise you cannot access.
You only have to preserve a thin shelf of
See,
bone.
once you are doing this approach, you have to have a maximum access,
Yes.
Now see what I am going to. See carefully. This is jugular bulb. Suppose if it is high and I am in a live surgical situation where I have a big tumor and I have to improve my access, what will I do? I showed earlier in many of the live surgeries, I can push my sigmoid sinus behind. I can use a bipolar cautery or the periosteum to press it down. For jugular bulb, you cannot use a cautery because jugular bulb doesn't have a periosteum layer like, sigmoid sinus, very thin. So what you can do, expose this, remove the thin bone over it like this, thin bone, and make this serous like this.
Yeah.
Elevate it from the bone and push your Surgicel and bone wax. Push your Surgicel and bone wax more and more to push it down. See, moment you push it down, see the more and more bone is exposed.
Yes.
I can remove this bone to enlarge my exposure. So this is how you can, even in the situation of an difficult access, and this has been very well shown by Professor Mario Sana many a times, where I learned this art from him, and this is amazing. A lot of neurosurgeons otherwise would criticize that this is a narrow access, and believe me, any given size of a vestibular schwannoma, any given size can be removed from any given opening of the translabyrinthine axis. As simple as that.
Okay.
So the tumor size is not a factor a decisive factor in choosing the approach. See, if you go to a landmark publication from Robert Jackler from Stanford University, I have gone through that almost 25 times. Selecting a surgical approach to vestibular schwannoma, to acoustic neuroma, amazing. He took into consideration almost 50 criteria to choose a surgical approach for vestibular schwannoma. And he clearly states in the first part, the first criteria was the tumor size. Any tumor, any size tumor can be removed through any size translabyrinthine axis. So tumor size is no longer a criteria to choose the surgical approach.
Satish, Rob is going to be with us on one of the webinars. We just had to work out Rob Jackler is going to be there, faculty.
Pardon?
Sometime soon. Robert Jackler is also going to be a faculty.
You can bring him, being your good friend, Ashish.
Yeah. So no, he's agreed already, but we have to see the time and
so Jackler is a good friend of Ashish, and I request Ashish here to bring that giant. He is amazing. See, what I am doing? I am creating an inferior trough, inferior to the. This is our intra-auditory canal. Can you see?
Yes,
this is jugular bulb, and I am creating this inferior trough to increase the inferior axis. You can see very well.
Yes.
Yeah.
And what is my limit there inferiorly? See the jugular bulb, and now I am reaching the cochlear aqueduct very soon. There is going to be the cochlear aqueduct, and that is the medial end of the cochlear aqueduct.
Zoom in,
See,
please. Yeah.
just above the jugular fossa. That is my, I am reaching that bone at the medial end of the cochlear aqueduct. You still see the venous blood in the
Jugular.
sigmoid sinus. Like you saw that day, the venous blood in the pterygoid venous plexus and everywhere where the veins are. This is the same cadaver,
Okay.
The same one which we did the endoscopic dissection that day. Can you see the cochlear aqueduct?
Yes.
Hello?
Yes, can be seen very well.
That is cochlear aqueduct, and you can drain the CSF through it. If I drill 1 millimeter below it, I will find the glossopharyngeal now. So now I will not go beyond that level below. See that?
Yes, sir.
That is my level. Somebody asked that day the cochlear aqueduct, you can see that.
Yeah, you.
I am
It
removing
looks that your
the
burr.
quickly.
It looks that your burr has endoscope attached to it. You know everything is.
Yeah, I will, boss. I will. As I go deeper, see, I am quickly removing this bone. In the live surgery, this last part of the bone has to go with a diamond.
Yes.
So not to damage the dura and the contents inside. But here I am just saving time. This part, see my inferior trough to make it 270 degree. Can you see that?
Yes.
For the introauditory canal and superiorly as well.
Yes.
Satish, sometimes in the cochlear aqueduct, there is a small vein that directly connects to the internal jugular vein. Is that occasionally a source of bleeding?
There is a vein which runs parallel to the cochlear aqueduct to the cochlea. Is an inferior cochlear vein.
Yes. Is that because it opens directly into the internal jugular vein? Is it a source of significant bleeding?
And that drains the inner ear blood.
Yeah.
For everyone, Ashish and Ashim have been, associated with the Yugofish Foundation for long, and they have been as a faculty part of so many Yugofish courses earlier, lateral skull-based courses.
Sir, Karmarkar is asking, Dr. Sandeep Karmarkar, irrespective of preoperative hearing status, above what size will you choose the translab approach, as the chances of preserving serviceable hearing reduces with increasing tumor size? And are there any pre-op indications for hearing preservation chances post-operatively?
Yes, for if you want to discuss about choosing this approach and the hearing preservation, I told you we'll discuss in the vestibular schwannoma, but here I tell you, the parameter of hearing is not audiometry, which mostly the neurosurgeon take into consideration.
Speech discrimination.
So if the hearing is good,
discrimination, that's the most important part.
Yes, speech discrimination
anything
score.
less than 50% speech discrimination, never mind what your audiometry is.
Yeah, whatever the audiometry, forget about it. That is not a true depiction of a serviceable hearing. See, I am removing with a cutting burr, damaging little bit of the part of the dura here. I don't mind here because I have to go quickly.
Satish, keep spilling your wisdom about the facial nerve. This course is about the facial nerve, so start talking about
Yeah, we should not deviate.
There are so many questions regarding the acoustic neuroma, meningioma.
No, we are going to do another one, no, Rajesh. We are going to do a special one.
Yeah, Ashish, your point is valid, but since we are doing this translab, we are getting an additional opportunity to discuss that approach as well.
Sandeep is a very, very good friend and a very fertile thinker. But let's no, Satish, tell us about the facial what we don't know. Tell us about it.
Yeah. See now,
Satish, hello.
I've opened through this narrow axis.
Yes, we can see that.
The cerebellopontine angle, though I have not removed the bone completely. And can you see the nerves here?
Yes.
Yes.
These are the nerves in the CP angle, and I need a, nibbler, which is I am not finding here. Can you give me any nibbler?
Tell us about the Bill's bar as well.
Yeah. So, see, this intra-acoustic meatus is carrying the 4 nerves to the inner ear. At the lateral end of the intercanal, at the medial end of the meatus, all nerves are together almost, separating the facial nerve from the vestibular cochlear nerve. Below the porus, the vestibulocochlear is a single nerve, facial is separate, and the nervous intermedius joins the facial in the canal, intra-auditory canal.
But as a separate entity.
Yes, that is the sensory part of the facial nerve, sensory and secretomotor. And in the canal laterally, this vestibulocochlear differentiate into 2 vestibular nerve and the cochlear nerve separately. So these 4 nerves at the lateral end of the canal, they are oriented to the different direction of their destination. And at the lateral end of the canal, they are divided through a bony ridges, I would say, a horizontal ridge separating the inferior group of nerves from the superior one, that is falciform crest or horizontal crest, and the vertical crest separating the vertical nerves, the posterior and anterior from each other. The posterior is the superior vestibular and the anterior is the facial. So I just open up the CP angle quickly. Crudely, I would say this is crude.
So, Satish?
Yes.
Just wanted to share this thing that the layers over facial nerve in CP angle is only pia mater in the CP angle, but dura and arachnoid cover it in the interauditory canal, and dura and arachnoid stop at the fundus of the interauditory canal where the facial nerve becomes the labyrinthine portion.
Pardon, can you repeat, madam?
In CP angle, the layer covering the facial nerve is only pia mater. When it enters the interauditory canal, it is covered with arachnoid and dura also.
Yes.
And when it comes out of the interauditory canal, internal this dura and arachnoid stop there, and they make a constriction ring around that when it enters the labyrinthine portion, which is called bottleneck.
And beyond the second genu, beyond the first genu, it is covered by periosteum. Until the first genu, it is not covered by periosteum.
Very important thing that this thing is not there. In labyrinthine portion also, there is no epineurium even. So those layers start joining when it enters after the labyrinthine portion.
In the fallopian.
Ashish, now I'm using the endoscope to show you something inside.
Yes.
See, I am not wasting time in the approach here because we have to focus on the facial now. That is brain stem. Can you see below?
No.
No.
We can only see Sandeep Naidu in a blurred way.
Okay.
No, that's not
now
Sandeep.
we are attaching the endoscope. Sorry. Light. Thoda bola.
Yeah, okay. Now we are in. You want some music background? No.
Yeah. Is the picture good?
Okay, lovely, beautiful.
So this is the nerve coming from the,
beautiful
intra-auditory meatus. I am at the CP angle, and some other nerves. First of all, I'll show you what I can see through this endoscope. Number 1, this is superior, this is inferior, okay?
Yes, thank you.
Okay.
Yeah.
See superiorly, what is this thick nerve? This is trigeminal nerve.
Yeah.
Can you see very clear?
Beautifully seen.
And this nerve is involved in a pathology here, for which we do a microvascular decompression. See, this is the vein behind. Just above and behind this, that is Dandy's vein.
Dandy's vein.
It may also lead to compression, which require a microvascular decompression. The most important thing which mandates a decompression here, giving the trigeminal neuralgia, is the close vicinity of this nerve to the superior cerebellar artery above.
To the superior cerebellar artery.
Yes.
Okay.
And you know, you have the right angle there. Superior cerebellar artery, the loop of that many a time compress this nerve to give a trigeminal neuralgia, which needs to be separated. And what you need to do, you go by retrosigmoid approach, reach that region, separate the arachnoid, separate the vessel from the nerve, and put a, a Teflon sheet. And the guy who is pioneered this approach and has done the maximum cases is Jax Magnan we had last time.
Yeah.
Now see the another nerve anteriorly.
Yes.
What is that? Abducent.
Abducent, yeah.
This is the cisternal course, and see where it is entering into a dural canal. That is Dorelow's canal. That is not the bone. What you are seeing there is not the bony canal. It is not entering the bony canal there. It is passing through the venous lake, the lake formed by the inferior and superior petrosal sinuses, and then the area above that is breached by petrolingual ligament. So forming a Dorelow's canal that is running to a venous lake, and from here after going through this canal, it goes behind the paraclival carotid artery to enter the cavernous sinus. That we saw last time through the endoscopic approach. So this is the region of the petrous apex.
This was too heavy. Can you repeat this one more time,
please? Okay. This nerve is, this is the cisternal segment of the nerve.
Yeah.
And this is ascending through an opening C above there.
Yes, we
that
can
is
see
a dura. It enters a dural canal, known as Dorelow's canal. And what is there in that canal? There is a venous confluence of superior, inferior petrosal sinus and basilar sinus. So this nerve runs through a venous lake, and that is bounded superiorly by a ligament from the petrous apex to the lingula of sphenoid. That is petrolingual ligament, through which petrosphenoid ligament, through which this nerve runs into the cavernous sinus behind the paraclival carotid artery.
Okay. Lovely. Thank you so much.
So this is the only cranial nerve which is the longest intracranial course. See this?
Yes.
This arises from at the level of the junction of the two vertebral arteries forming the basilar artery. Vertebro-basilar junction.
Vertebro-basilar junction.
And it has a long intracranial course. So what happens? If there is high intracranial pressure, this nerve is stretched against the bony surface. And this is the first nerve to get paralyzed in situation of benign intracranial hypertension.
Okay. Thank you. Brilliant.
Good point.
Okay.
Good point.
Now, this is the sixth nerve and this is the fifth nerve. Now, above the fifth nerve is the tentorium. Tentorium is what? Covering the posterior fossa from superiorly, and here in the free margin of tentorium, if I dissect, if I dissect, you will find the trochlear nerve, the fourth nerve, a very thin nerve running in the free margin of tentorium. If I find here, I can show you. Yeah, that is. Yeah, that is above. Give me a section. Yeah. Actually, I didn't drill the much, and this bone is coming in the way. See this?
Yes.
And I don't have here the Kerrison punch in the laboratory. Yeah. So, एक मोड़ के देना यूँ. इसको right angle को मोड़ के दे. Yeah, I will show you. लंबा मोड़. No. Now I will separate this arachnoid layer. आगे सट. The thin arachnoid layer here to show you the fourth nerve. If possible, Gary, see this. Can you see the fourth cranial nerve there?
Yes. In the depth we can see.
A small nerve in the depth. Can you?
Yeah, we can see. Absolutely clear.
And the vessel behind this nerve, see this. That is the superior cerebellar artery.
most common compressing the nerve.
See where my instrument is. That is superior cerebellar artery.
Yes,
Yeah, yeah.
visible, Satish.
And above that is the fourth nerve, trochlear nerve running in the, this is tentorium. This is tentorium above, running in the free margin of tentorium. So, what I mean to say through this tour, the fourth, fifth and the sixth now. This is our seventh, eighth nerve complex. Probably I have divided one of the nerves and see how it is arising from the brainstem. Can you see this origin?
Yes, yes.
Now, this is the vessel. Can you see at the origin here? See this vessel? Many a time this vessel forms a loop here on the origin of this now. Can you see this vessel?
Yes,
Yeah, yeah.
Ica.
This is arising from the basilar, that is Ica.
Basilar.
So in cases of hemifacial spasm, because of this vessel, again you have to do the same thing, microvascular decompression by putting in, sandwiching the Teflon between this and the nerve root entry of this nerve. Can you see this?
Yes.
Another importance from our neurotology surgery side is for the brainstem implant. You know, what we do when the situation where the cochlear nerve is not there, or the cochlea is not having any fluid or ossified and no possibility of cochlear implant, we implant in the, we do the brainstem implant, and then the implant stimulates the cochlear nucleus.
Yes, yes.
Oh, the periosteum. Now, where is the cochlear nucleus? See this vestibulocochlear nerve, where it is arising from, if I push this cerebellum little bit behind, I will find the choroid plexus here. This is the flocculus of the cerebellum which I am pushing. Suction karna. I will find the choroid plexus here, and that is the fourth ventricle. In the lumen of the fourth ventricle, see this, I am separating here. Suction kar. इधर पीछे मेरी तरफ.
पतला वाला लो section.
Yeah, section is too big to damage all the nerves. See, you are damaging every nerve. Ninth nerve is damaged. The seventh, eighth gone. See with the suction. Could you see?
Yeah.
Oh, tight waka maar diya. See, this nerve is gone. With the suction.
Neurectomy. Okay.
Now, what is there below? These are lower cranial nerves. Can you see that?
Yes.
This is a combo of 9th, 10th, 11th cranial nerves. You can separate them. Here. See that?
Yeah. Beautiful.
And what is there? Which vessel is this? This is vertebral artery.
Yes.
And what vessel is separate? The twigging around the vertebral artery?
Yes.
Going anterior to that, that is hypoglossal nerve. And that is entering through a separate canal, that is hypoglossal canal. Can you see that?
Hypoglossal canal.
Yes, we can see. Beautifully see.
See, these are the 9th, 10th, 11th here. And that anteriorly twigging around the vertebral artery is the hypoglossal, which is entering the occipital condyle there. Can you give me 45 degree? I will show you with the 45 degree scope. Okay? I hope it is clear.
Yeah, beautiful.
Ashish?
It is clear, sir.
Got the gauge.
Sir,
What's the name?
Dr. Pauri Belsare from Pune is asking what is the applied importance of the Dorlos canal?
Dorlos canal is important when you remove the tumors from the petrous apex. Petrous apex, when you access the
Also in
Michel's cave.
petrocyte. Hello?
Yeah.
Also in petrositis.
See now, these are the 9th, 10th, 11th nerves. This is the 11th, spinal accessory. This is the 10th and 9th. And they are running toward the jugular bulb. Can you see that?
Yes.
This is 45 degree now. Okay? This is 45 degree scope to show you these nerves. Can you see?
Yes.
Now beyond, see the separate canal for the hypoglossal.
Yeah, beautiful.
So the hypoglossal nerve runs through a separate canal in the occipital condyle. That huge bone is occipital condyle. See this? This is occipital condyle, and this nerve runs through the depth of the occipital condyle, and this comes out of a separate hypoglossal canal that runs medial to the jugular bulb. Rest of the three nerves comes out of the jugular bulb, and the hypoglossal comes out through a separate canal medial to the jugular bulb. Is that clear?
Yeah.
Now, this is vertebral artery. And see this vessel arising from the vertebral artery below in close proximity to the lower cranial nerves. See this. This is pica.
Yeah. Right.
This is posterior inferior cerebellar artery that is in close proximity to the lower cranial nerves, and this is vertebral artery. And the two side vertebral artery here join to form the basilar where this Dorello's canal is, the sixth nerve is starting. This is fifth now and that is fourth now. Very clear now. See in the tentorial margin, the fourth nerve.
Yeah. You can.
So this is the sort of intracranial tour I wanted to show you with the endoscope. And this is our intra-auditory meatus. Unfortunately, this one nerve is broken here. And these are the nerves in the intra-auditory meatus lateral end. See this? The medial end is broken. Can you see that?
Yeah.
Is that very clear or not?
Yes.
Can you
So
see
the
Bill's
facial-
bar over here in this?
Pardon?
Once
Can
the
you see the-
bar and the transverse crest, transverse crest.
Yeah, I will show here, lateral end. So the facial nerve, when it rises from the brainstem here, behind that is a, the nervous intermediates, they join together in the canal. The cell bodies of the nervous intermediates are in the geniculate ganglion. And these are the central process here, the peripheral processes in the GSPN. Okay? So now, yes. Yeah, for those interested to know about the Dorello's canal, this nerve is very important when you do a transclival approach from anteriorly. You have to be careful not to damage this. You have to monitor this nerve. Okay?
Yes, sir.
So now come back with the microscope again.
Sir, where do you exactly put the brainstem implant Dr. Gauri Pachauri is asking?
Okay, let me show you.
And sir, Dr. H. Vijendra sir from Bangalore is watching your demonstration and he is saying it's excellent. So,
Oh, thank you, sir. It's a blessing. Sir is watching us. He's a legend. And he himself has done a lot of work on the facial nerve, we all know. See, when I am going to the root entry zone, see, here, if I press this cerebellum behind, more and more behind, here, that is the region of the fourth ventricle.
Yes.
Can you see the opening of the fourth ventricle there?
Yeah.
That is the fourth ventricle. See this? And in the floor of the fourth ventricle are the cochlear nuclei. And there you have to put a implant. That implant is a plate. It is not a cochlear implant like electrode array. You have to put the entire plate in a position to this ventral and dorsal cochlear nuclei here and fix with the fibrin glue. And you can do a cochlear nerve monitoring that time to confirm that it is stimulating the cochlear nerve. So that is the
This
reason.
one is foramen of Laska. This one
Foramen of Lashka and Magendie are, Lashka is lateral, Magendie is medial foramen of the fourth ventricle. So
Yes.
you access here the lateral foramen, that is the foramen of Lashka, and in the floor of that is the fourth, are the cochlear nuclei.
Satish,
Now coming
Satish,
to the lateral
must-
end of the intra-auditory meatus. Yes, madam.
they must be going through retrosigmoid approach, na? Not through
No,
this
no, no.
approach.
No.
this
For
is-
everyone to do the brainstem
Brainstem.
implant, translab is the only approach.
only a
Okay.
Yes, that is the
Okay.
direct approach. If you go by the retrosigmoid, too much of cerebellar retraction will not allow you to see
Okay,
the lateral ventricle. So
Okay.
the only approach which is you can get exposure with is the translab. Now see, this is our facial now. Hello?
Yes.
This was broken
Yes.
with the
Hello.
suction there. This is our facial now, and here it is going through this laterally, continuing as a
introduction.
labyrinthine segment. See that? Now this
Yes.
bar of, this horizontal bar of bone, see laterally here. separating the inferior nerve here from the superior nerve. This is the transverse crest. Okay?
Please focus it, please. Please focus.
Crista falciformis.
Yes. And
Not
see,
okay.
this is my superior vestibular nerve which is broken here. See this?
Yeah.
This crest of bone separating the superior vestibular from the facial here, that is the Bill's bar. Can you see this? The Bill's bar is a vertical bar like this, and the cresta is a horizontal bar separating two inferior nerves, the cochlear and the inferior vestibular, from two superior nerves. So this is my facial nerve here. This is the Bill's bar, and here was the superior vestibular nerve. See that? That is going into toward the superior canal and the anterior canal. So now, if I follow this nerve above, that will be the labyrinthine segment of the facial nerve. Can you see there? If I remove this bone, that is a narrow canal transmitting the labyrinthine segment of the facial nerve. Labyrinthine segment is a very important area, involved in a lot of pathologies. Now, coming to the pathologies at the CP angle. Many a times in the posterior fossa procedure, like for acoustic neuroma, preservation of the facial nerve is a huge task. For, I believe, tumors above 2 centimeter in size, preservation of facial nerve becomes a huge task, because this tumor, which is arising here in the CP angle, and as it grows, it pushes the facial nerve anteriorly and superiorly. It keeps on pushing the facial nerve anteriorly and superiorly, and the facial nerve gets completely flattened out as the tumor grows. Completely like a ribbon. The moment you remove the tumor from there, the nerve gets devascularized. It becomes a very thin nerve, and many a time, in spite of a anatomical continuity you have maintained, the nerve becomes non-functional. Because of that manipulation, and this nerve thins out like a ribbon. So, this is very important to explain those patients undergoing vestibular schwannoma surgery. Any tumor about 2 or 2.5 centimeter in size, there will be impact on the facial nerve. Now, depending upon your experience, there are certain maneuvers I will tell you in the translab process how you can still save the facial nerve. So, the advantage in the translab is, the moment you begin the dissection, you focus on the lateral end of the intra-auditory meatus. In lateral end, this tumor arises mostly from the vestibular nerve, inferior vestibular nerve. Sometimes from superior, those are behind. So once you start dissecting the tumor from above, you can see the facial nerve in the beginning. In the first part of your surgery, when you open the intra-auditory meatus, you see the facial nerve right there anteriorly. So that is number one beauty of the translabyrinthine approach. Secondly, once you have seen the nerve, you keep on doing the intratumoral debulking so as to remove the traction as you mobilize the tumor on the facial nerve. And then following the course of the facial nerve, which is pushed anteriorly, as you debulk the tumor, the facial nerve comes back in the position. And then you can see the lower end of the tumor, lower end of the facial nerve coming from the brainstem. Once most of the tumor is out of the debulking, you can start seeing the lower end, and then you can gently separate from the tumor capsule. That is the most important step, where the facial nerve gets, injured. And even if you preserve the anatomical continuity, because of that traction, because of the devascularization and molecular changes at that level in the neurons in the facial nerve, the facial nerve dysfunction is inevitable. So in small tumors, facial nerve you can preserve very well. Larger, it becomes more and more unlikely, and that kind of, you have to explain to the patient. Now, coming to the various approaches, the advantage and disadvantages regarding the facial nerve. If you are coming from that retrosigmoid approach, suppose from behind. If you are coming from behind, this is the tumor. Your facial nerve is anterior to the tumor and surgeon is behind the tumor. This is the tumor, the facial nerve is anterior to the tumor, and the surgeon starts from behind the tumor, absolutely blinded by the facial nerve. So number one, the chances of preservation, the upfront identification of the facial nerve is not there. Like you see upfront, you identify in the translab approach, number one. So the preservation overall of the facial nerve is less in the retrosigmoid approach. Number two, in the experienced hands of the neurosurgeon, they keep on debulking and find the lower end, the medial end of the nerve from the brainstem. And then separating the tumor from behind, they reach to the intra-auditory meatus. Now again the question comes, if the tumor is going far laterally in the intra-auditory meatus, you cannot remove either if it is going far laterally, or if you try to remove far laterally from the intra-auditory meatus, you will end up injuring the inner ear. And then the purpose of doing a retrosigmoid in terms of saving the hearing is defeated.
It's lost.
So,
Satish,
what you can do in that situation? If the tumor is going laterally in the intra-auditory meatus, you drill the intra-auditory meatus from behind. Now, drilling the intra-auditory meatus in the open cranial cavity, number one, is again is providing something like bone dust to the CSF, which have its own implications. Number two, you just reach the intra-auditory meatus, remove the bone, and make a slit on the posterior dura to decompress the tumor. That's it. Rather than trying to remove far laterally with the endoscope and other things. A lot of people are trying with the endoscope, but that is ultimately end up injuring the hearing. Yes, madam.
so you mean to say that lateral approach is safe because there is a bony canal and it shows us the proper placement of facial nerve, whereas the medial approach is a bit unsafe because there is no covering layer and more chances of injuring the facial nerve when we go from medial to lateral.
Yeah, that is retrosigmoid.
Retrosigmoid,
Right.
yes, because there are no bony layers and only pyometer is there.
Yes.
And there is a fact I read about it that the facial nerve can tolerate the stretching by a tumor, but damage by iatrogenic or touching it directly.
Yeah, this
will
part
cause
of the
more
facial
loss
nerve,
than-
this part of the facial nerve is like, you know, chui mui,
very
touch wood.
delicate.
There is no periosteal covering. Only
bony
the
covering.
pyometer is there. Even the slightest stretch can lead to dysfunction of the facial nerve.
Yes.
Number one.
Yes.
Now we are coming for the first day in today for the first point, how to manage the facial nerve. This what
Yes.
I have shown until now is the approach, is the anatomy in that region. That's it. It has nothing to do with the facial nerve course. So the first question now, in case the facial nerve is damaged at the CP angle, what can be done? And number two, in case the facial nerve is not damaged, but still anatomy is intact, the continuity is intact, but it is non-functional, what to do and when to do. And number three, what approach can provide you anastomosis of the facial nerve at this level? Before going to that,
Yes.
let me put up one point very clear to everyone. Today, the facial nerve is unique in terms of giving a spontaneous facial expression by means of
Yes.
supplying 43 muscles on the face. And that synchronization and spontaneity provided by the facial nerve from both sides gives us a beautiful smile. You know,
Yes.
that sense of expression of the facial expression cannot be provided by any other thing else than facial nerve. So, when it comes to facial nerve reconstruction, the number one thing, the best results are gained when you have a discontinuity and you repair the discontinuity by anastomosis. Still you keep the innervation coming from the facial nucleus intact, because that only will give spontaneous smile. So once there is interruption in the facial nerve, the ideal first treatment is restoring the discontinuity by anastomosis. Number one. That gives the supreme result. Number two, when there is a defect, gap between the two ends of the facial nerve, still the best results are gained by putting a nerve graft in between and suturing from both ends. So this will give two anastomosis. This will allow loss of axons more than one anastomosis. It will invite more fibrosis, but again it will
Yes.
be supreme to all other rest of the treatment except the single anastomosis. So this is number two treatment when you put a nerve graft.
Yes.
Now the third situation, when you don't have a proximal segment of the facial nerve available. Got my point?
Yes.
Like in the temporal bone, the tumor has invaded the facial nerve, removed completely, and you don't have a proximal nerve left. Now, to restore the facial function, you have to bring in other nerve Got my point?
Yes.
Yes.
You don't
yes.
have proximal
Motor nerve.
segment, and whatever nerve you bring in, that discharge is not going to come from facial nucleus.
Nucleus, yes.
So
Yes.
it cannot give the natural spontaneous smile.
Because the facial nucleus, correct me, is under the influence of the amygdala and the limbic. The spontaneity
Yes.
comes
So
from
the
there, right?
motor cortex is controlling the facial nucleus to give spontaneous smile.
Yes.
And in that third situation I am enumerating, after the anastomosis and the cable graft, those give the spontaneous smile because still the fire is coming from the facial nucleus.
Nucleus, yes.
When you don't have a proximal facial nerve end, and you have to bring in other nerve for anastomosis to give facial expression, that will be from other nerve and it will never be spontaneous as given by the facial nerve itself.
Beautiful.
So that is
wonderful.
They will be giving voluntary action, but involuntary emotional actions and the emotion-induced facial movement won't be there. They say that there are additional synaptic junctions for them in hypothalamus, basal ganglion, and midbrain. So there are additional which only can come through the facial nucleus only. So you're right that it will not be there once we do a replacement with the motor nerve.
Yeah. Now the third situation is when you don't have
Satish,
a
I think
proximal.
your mic is going away. Your audibility is
Yeah,
really...
yeah, Ashish, now? Now?
So now it is good. Now it
Okay.
is good.
So third situation, mind it very clear what I'm saying.
Yeah.
Again, those want to listen to again the first situation, the best result is primary anastomosis, keeping the facial nerve firing intact. If there is a gap, because the tension anastomosis is never a good anastomosis, it doesn't give a good result. So if there is a tension in the suturing, better to bring in a graft, another nerve graft, and allow the nerve, the proximal nerve, to grow into the tubules to the distal nerve, so as to give without tension suturing, and that still gives best results, inferior to the one, you know, the direct continuity, direct anastomosis, inferior to it, but still it keeps the spontaneous innervation intact.
Yes.
And we welcome Professor Ralph Magritte now. I can see him on the screen. Ralph,
Yeah, he's there. He's there.
can you hear me, Ralph? Hi.
Good morning.
Welcome.
Good morning, Timberland.
Thank you for being with us. And on behalf of everyone watching this webinar, right now over 7,000 people connected through YouTube and the link. And on behalf of everyone, I welcome Ralph to this webinar. For everyone, as I mentioned in the beginning, Ralph is a committed facial plastic surgeon. He is our own ENT surgeon, and presently is heading the department of the University of Berlin of facial plastic surgery.
He is the chief there.
Chief there, and we had an opportunity earlier, thanks to Gori Belsare for inviting him last year to Pune, to had an opportunity to see him in action last year. Thank you, Ralph, and we need your valuable comments. You know, what I was mentioning here, to rehabilitate the facial interruption, facial nerve interruption, the best results are gained by direct anastomosis for proximal to distal end, keeping the firing of the facial nucleus intact. That keeps the spontaneous innervation intact, and we still get a spontaneous smile. If we have no chance of having a primary anastomosis because of the gap in the nerve, a part of the nerve is destroyed, we can bring in another nerve as a cable graft, and still the spontaneous smile remains intact, though it is inferior to single innervation than the double innervation with the cable graft. Now we welcome Morwani sir. Morwani sir, welcome.
Good morning.
Good morning,
I've been
sir.
watching you for a long time.
So
I've been
Morwani
watching you for a long
sir,
time.
you know, Morwani sir is like father figure to us, and is you know, I'm not wrong if I call him as a father of facial nerve surgery in our country, who has been doing for last 40 years and teaching us and done number of procedures and tackled different situations. So the third situation now is when you don't have a proximal end of the facial nerve intact. Ashish, are you there?
Yes, I'm there.
So
Yeah.
in that situation, when you don't have a proximal nerve intact, facial nerve, to rehabilitate the facial muscles, you have to bring in other nerve.
Yes.
And there are a lot of options. I will show all the anastomosis Earlier, the hypoglossal nerve used to be the primary, the nerve of choice, which for me has been obsolete for many years. I will tell you the reasons. And then the other nerve is the mesenteric nerve, a branch of fifth nerve, branch of mandibular nerve, a very strong motor nerve supplying the very strong mesenteric nerve, mesenteric muscle is now our muscle of nerve of choice. I will show as I go to the face, reach to the level of the face, how mesenteric nerve is so important and gives the earliest possible excursion on the facial nerve and closest to the spontaneous smile as well. The hypoglossal nerve, hypoglossal has lot of disadvantages. Hypoglossal doesn't have a fascicular orientation of nerve fibers like facial nerve, for that matter. Anatomically, morphologically, hypoglossal doesn't have a fascicular orientation of nerve fibers.
Okay.
How the facial nerve is fascicular oriented? All the axons, if you see the anatomy of the facial nerve, the lot of axons of the facial nerve are together in fascicles. A lot of fascicles are together bounded by endoneurium.
Yes.
A lot of fascicles with endoneurium are bounded together by perineurium. A lot of fascicles together by endoneurium and perineurium, all that together bounded, surrounded by epineurium, and that is surrounded by periosteum. That is how the facial nerve structure is. In hypoglossal, there is no fascicular arrangement. So when you reconstruct with the hypoglossal, it is a good strong motor nerve. The disadvantages are, it takes away the innervation of the tongue. That additional morbidity is sometimes not acceptable. For that, there are a variety of hypoglossal procedures described. Hemi-hypoglossal, end to side, I will show all and discuss that in detail there. So, in order to avoid that, the mesenteric nerve, for last 7 years, I have been doing, and if you go to the literature, is the nerve of choice now for many regions. I will show that facial-mesenteric anastomosis today on the cadaver, and we have 4 live surgical cases after the cadaver today for facial nerve, and one of them is facial-mesenteric anastomosis.
So the fascicular arrangement of the mesenteric is close to the, similar to the facial?
Yes, there are so many advantages. That is number 1. Number 2, the close vicinity of the facial nerve to the hypoglossal nerve on the face. I will show when I show the facial-mesenteric anastomosis, the trunk of the facial nerve and the mesenteric nerve are very close to each other. You don't need any interposition graft or anything. The innervation and the movement of the facial muscles are so fast. When you do a facial-mesenteric anastomosis, you can start getting result in 3 months' time, which otherwise in a long anastomosis with the hypoglossal nerve, you don't get majority of the time in less than 1 year time, you know. So that is another advantage. Number 3, it is a strong nerve with number of myelinated nerve fibers required for the facial innervation. The cortical representation of the mesenteric nerve overlaps the cortical representation of the facial nerve. So, in the post-operative period when the patient gains the function, you know, reaching to the spontaneous smile is closest by the mesenteric nerve as compared to the hypoglossal nerve. Now, for that, lot of physiotherapy is needed. You know, physiotherapy is a very strong role in facial nerve rehabilitation. And you remember, Ashish, how the Professor Tessa Hadlock emphasized in, you know, last time in Madrid, Spain, about the physiotherapy and all those things and the facial paralysis. So, why I'm saying so, when you do a facial-hypoglossal anastomosis and when you start getting results, the patient has to be subjected for the intense physiotherapy program because he has to learn the facial movement by means of movements of the tongue. You know, if you see anybody having undergone the facial-hypoglossal anastomosis and learning rehabilitation of the facial movement, the first time if you see that patient, you will find him, this man is a psycho. What is he doing? What nonsense he is doing? Every time he has to mobilize his tongue to mobilize the face, you know. So that is so difficult, the rehabilitation protocol is, and it cannot come to the level of spontaneous smile any point of time. In mesenteric, with this strong innervation, so close proximity, with a good overlapping of the cortical representation of the 5th and the 7th nerve, and this involvement of the mesenteric nerve in the smile itself. You know, when we smile, our mesenteric nerve is also involved. So
Yes.
the learning the smile post facio-mesenteric anastomosis is much, much easier than hypoglossal. So my point was, the third point what I emphasize, when you don't have a proximal end, you have to bring in other nerve. And that nerve of choice is, for us now, is mesenteric nerve, which I will show. Now in the fourth situation, in the third situation, when you get the nerve, what you all dependent on, this nerve will innervate, and the innervation will go on to the neuromuscular junction. The motor end plates which are intact will stimulate the facial muscles.
Correct.
Yes.
Now what happens? Here the duration of paralysis has a significant impact. What is generally believed, mostly up to 2 to 2.5 years of time of denervation, still the motor nerve and plates are significantly intact. Up to 2 years, 2 years is the borderline by and large. It may be 2.5 years, sometimes 3 years also. By and large. After that, the facial muscles start undergoing atrophy because of the denervation. Now, I will tell you exceptions also. So what happens if a patient with me who has had facial paralysis for 3 years, and now I bring in a nerve, I may innervate the nerve through bringing a new nerve, but what will ultimately happen, what it will stimulate when there are the end plates are not active. So in that situation, in long-standing paralysis, now you have to bring in along with the nerve the muscle as well.
Muscle. Correct.
So how you can determine in long-standing paralysis, if you are trying to rehabilitate the facial nerve, get MRI done and compare the muscle mass on both sides of the face. If the muscle mass is significantly atrophied, there is no point in bringing the nerve alone. Okay? In that situation, now you have to bring in the nerve along with the muscle as well. And then when you bring in the nerve and the muscle, you have to bring in the vascularity as well. So that is for long-standing paralysis. There are lots of, the free muscle flaps along with the nerve and the vessels which are now transplanted. The gracilis is the most favorite. There are so many. I will enumerate all. The gracilis will be shown by Professor Tessa Hedlock from there through a video. She will explain the each and every point of gracilis. She is going to show, rest I will show. So gracilis is our number one muscle in those situations. For long-standing paralysis, you have to bring in muscle. Now,
can you make
Movani sir has a series of few patients.
Your
wherein,
mic, Satish.
hello? Yes.
Yeah, now it's okay.
Yes. Exception to this is what we believe, when the muscle is denervated, the nerve undergoes atrophy. But there are certain exceptions. If the patient is not a good candidate, elderly patient, not a good candidate for a free vascular anastomosis and free muscle flap, he tried in few patients, still the nerve anastomosis, and found some function returning back, good function returning. So what he inferred, in certain patients, even in the long-standing paralysis, even there is no harm in doing a nerve anastomosis. If you cannot do a free muscle transplant, still you can do a nerve anastomosis and expect some function to come. So this is the basis of today's facial nerve workshop. I will show at each and every point of time what procedure is best for particular situation. Why I mention at this point of time, the first situation we have now, during a vestibular schwannoma resection at the CP angle, if we injure the facial nerve, if the anatomical continuity is lost, that is a different situation. The nerve monitor using at the time of vestibular schwannoma resection, I would say, is mandatory. It is mandatory in Western countries to have a nerve monitor. So what nerve monitor additionally will give you, first of all, during a vestibular schwannoma resection, if you are using a nerve monitor, it can help you localizing the first nerve in the beginning. Suppose you are doing translab, as I showed, you open the intra-auditory meatus, you will find the facial nerve there with the help of nerve monitor. Secondly, during the surgery, when you are putting too much of traction on the nerve, your nerve monitor will warn you that you are injuring the nerve. That wants you to stop that maneuver. Thirdly, at the end of the surgery, when you keep the nerve intact, you have left the nerve intact, and if your nerve monitor is showing good function, that is an indirect sign that the nerve function is also left intact. Because the biggest difficulty is when you leave the nerve intact but no function, and that is the most difficult situation. So now there are two situations. One is you destroyed the nerve, and what you can do in that situation? Anastomosis. What you can do? You saw the vertical segment of the facial nerve. Let me show you again. Can you put the microscopic picture? And that is the advantage when you are doing a translap procedure. When you are doing a translap procedure and you have injured the facial nerve during the vestibular schwannoma surgery, what you can do? See, suppose my lower end or the nerve or the end of the brain stem is here, suppose. See that? Are you getting the picture?
Yes, yes.
This is the brain stem end of the nerve if you have. And rest of the nerve is injured. What you can do? This is the nerve in the vertical segment. See this? You can bring out this nerve from the vertical segment here, and with a sural nerve, you can harvest a sural nerve and anastomose this sural nerve from lateral end to the mastoid segment to the medial end to the brainstem, and you can anastomose and cover in a temporalis fascia sheath or any fascia sheath along with fibrin glue, and it works well. That is at the same time of surgery. Sir?
Can I say something?
Yes, sir.
See, when you are transposing the nerve from the stylomastoid foramen, the complete vertical course, horizontal portion, level length, you need not have an additional graft. The length becomes too much. It comes automatically.
Yes.
You know what I mean?
Yes, yes. That is additional length.
You are rerouting the nerve.
Yes.
From stylomastoid foramen, it will come up to the brainstem.
Yes.
You need not have an additional graft. When you are two suture lines.
Yes, yes. That you don't need to do.
Then we do one suture line.
Yes, we need to only one suture line.
The GSP and then.
So, what you can do at the same time of surgery, if your nerve is injured, you can do this, anastomosis using a sural nerve. A sural nerve has the advantage of having a long segment, whatever segment you want, it is available. It is so easy to harvest. I will show you how easily in a few minutes you can harvest the sural nerve. And the one end laterally to the mastoid segment, medially to the brainstem segment, wrap in a fascia, put a tissue glue, and it works well. At the same time of surgery of vestibular schwannoma resection. Now, this can be done only when you are doing by the translab approach, because your mastoid segment is in your vision, like you see today. If you are doing with a retrosigmoid approach, your mastoid segment is nowhere in the scene, and then you cannot do the same stage anastomosis. So that is an added benefit of translab approach for the facial nerve in case you need anastomosis. Number one. Now the second situation is, at the end of the surgery, you left the nerve intact, but your monitor is silent. Monitor is silent, still you can't rely 100% on the monitor, and you won't do anything. Once the nerve is anatomically intact, there is no indication to transact and anastomose that. What you have to do is come out. Post-op, you see the movement. If it is still level 6 paralysis, House Brackman level 6, wait. So ideally,
For how long, Satish?
yeah, according to the literature, you have to wait at least 6 months. That is enough time to give to see any chance of, recovery. At the time of 6 months, check with the EMG if the EMG is still silent. If there are voluntary potentials coming on the EMG, you don't have to do anything.
Okay.
At the end of 6 months, if the EMG is silent, don't waste time. Don't waste time and bring another now, do a faciomessetric anastomosis, as simple as that.
I want to interfere again.
Pardon?
Even I used to say 6 months is, Satish, can I say a sentence? What Satish told you is what literature is to write sometime back, 6 months. Now people are talking about 9 months. I used to wait maximum for 6 months, to be very frank with you. But now some cases are doing even better after 9 months. What number of cases, I don't know. So there's no harm in waiting for 9 months also.
But I tell you, sir.
No, recovers by itself. The result will be better than whatever grafting you do. Do facial mesenteric, however do facial hypoglossal.
Yes, but see, this decision is still individualized. Lot of literature recommend 9 months, 12, 1 year. The reason is, it depends upon the surgeon himself who resected the tumor, how confident he was. He didn't damage severely, number one. Number two, the help of EMG. EMG is the best tool for prognostication. If that point of time, if the EMG is completely silent at 6 months, there is no point in waiting. It is not going to come. Because more you wait, more you are doing denervation, more you are preventing the chances of recovery, good recovery. So there is no point in wasting time. So 6 months to 1 year is a sort of period. But our philosophy, as I told you, is 6 months EMG and then go ahead. If it is good, wait. It will come if the EMG is coming. Because EMG predicts the clinical recovery. It goes before the clinical recovery. Clinically, you may not see any signs of recovery of the facial nerve, but you can predict weeks before on EMG that it is coming now. So that is the advantage of EMG. So
Does Ralph have to make a comment? Ralph,
yes?
You want to make a comment on this?
Sorry. No, I'm completely fine with it.
Fine. Okay.
Satish is right. No further comments.
No, okay.
Thank you. So this was the first situation of the day today. What to do when the nerve goes at the CP angle. Anybody has any question or suggestion, you are welcome. Then we move on to the other part. Now, the second thing here, I would like to mention other lesions about the, besides the acoustic neuroma. There are certain lesions in the CP angle and, in the intra-auditory meatus, which are diagnosed as a surprise finding intraoperatively many a times. And that is one of them is facial nerve neuroma. Facial nerve neuroma and the acoustic neuroma have similar imaging features. Though if you are very critical and good at imaging, still you can have a suspicion if you have a facial neuroma. The reason is the facial nerve neuromas are more smoother and they grow by expansion, and even the intra-auditory meatus, even the labyrinthine part of the facial nerve is expanded, which is unlikely in acoustic neuroma. That's how you can have a suspicion.
This is the labyrinthine part of the...
Second important thing, Satish.
Yes.
When you small neuromas, volume-wise, and patient is presenting symptom as a facial palsy, it is facial neuroma. Acoustic neuroma of 2-3 centimeters will not give facial palsy.
Amazing point.
Small neuroma, internal auditory meatus,
yes,
are just filling in the CP angle, and patient's dominant symptom is facial palsy. Then is a presumption is a facial neuroma. It's not acoustic.
Yeah, that's a bottom line. What sir has said. You know why he has said? Whatever size acoustic neuroma you will get, maybe 4 centimeter, 5 centimeter, it is unlikely to have those patients are having facial nerve palsy, because it expands and the nerve expands on the periphery, and it doesn't give facial nerve palsy whatever size acoustic neuroma is. But in contrary to that, facial nerve neuromas, in spite of having a small size, can lead to facial palsy. So all those patients where you are assuming an acoustic neuroma and presenting with a facial palsy, you have to be suspicious that it may be something else, number one. And I give you a classical example. We did a case at Ashish Bhumkar's place. You remember Ashish? An intracanalicular lesion. And see the interesting story. That young lady had a complete facial palsy, grade 6, complete hearing loss, profound hearing loss, unilateral, with a small sub-centimeter lesion in the intra-auditory meatus. Now, imagine number one. Remember Ashish?
Yeah.
Number one, a small acoustic neuroma of that size cannot lead to a grade 6 paralysis and a profound hearing loss. Number one. It can. Sometimes even the small acoustic neuromas may present with sudden hearing loss. That can happen. But a grade 6 palsy with a small acoustic neuroma is unlikely. Now, imaging of the intra-auditory meatus of a small lesion of any pathology is almost same. You cannot discriminate such a small lesion by means of imaging there, whether it is a schwannoma, facial nerve schwannoma, acoustic neuroma, hemangioma, whatever. We went to the literature and found 10 cases reported so far. And same thing that turned out to be was a hemangioma of the facial nerve. A very small hemangioma, in contrast to the schwannomas, is invading. It invades the facial nerve. So that is small sub-centimeter hemangioma, which was not expanding the canal even, invaded the facial nerve, cochlear nerve, presented with a grade 6 palsy and profound hearing loss. And yet on imaging you cannot discriminate. So like what Morvani sir said, has said, symptomatology is important. Patient presenting with a facial palsy, and if you are assuming acoustic neuroma, you have to think twice.
And secondly, Satish, as far as hemangiomas are concerned, they are most commonly at the genu area.
Yes.
They tend to come towards the labyrinthine portion and internal auditory meatus.
Yes, the most common at the first genu. They are most common at the first genu.
There is a characteristic appearance in MRI of hemangiomas.
Yeah, but small hemangiomas you cannot get those characteristics. In a larger one, you can get calcification and all that.
It's like a half grain.
Yes.
It's like it starts a small half grain.
Only in the larger ones.
Yeah.
In the larger ones, on hemangiomas on MRI or CT scan, you will find calcification and contrast enhancement and a variegated appearance, classical of hemangioma. Because of calcification, those patients develop. That is classical, but in the small ones, you cannot get those symptoms. Now coming to the different segment, that is labyrinthine segment now. Now this part of the labyrinthine segment of the facial nerve, we all know, is the narrowest part. Narrowest, and this is a culprit in many of the pathology, in the commonest we see in our practice, is the Bell's palsy. You know, and there are a lot of controversies surrounding the Bell's palsy management. I tell you, the reason is, sometimes things are not very clear, I tell you very clear, but yes, still we have to follow the evidence-based medicine. And second thing is a dogmatic approach by certain people, that fixed approach that you have to do this, you have to do this. It cannot work like that. The Bell's palsy, we know, the reason is viral, leading to edema of the facial nerve in a narrow bony canal, compressing the nerve, blocking the neuronal conduction and leading to Bell's palsy all of a sudden. And most of the time it has been proven, like Hugo Fish, so many years, 40 years back, he proved that it is the narrowest part of the labyrinthine segment which is the culprit for giving Bell's palsy. Okay? Now,
0.68 millimeters?
0.68 at the labyrinthine segment.
0.7 millimeters.
Labyrinthine segment emerges from the intra-auditory canal. That is the narrowest one. Now that part of the labyrinthine segment is compromised by various things. Number one, this part of the labyrinthine segment doesn't have as vascularity of the facial nerve as other segments. The segment of the facial nerve beyond the geniculate ganglion, and geniculate ganglion is supplied by descending petrosal artery and the stylomastoid part. That is richly vascularized. Similarly, intra-auditory canal, it is vascularized by the intra-auditory artery. But this transitional zone is at risk of vascularity compromise as well. So what happens in the Bell's palsy, this area, once the edema happens to occur, the nerve conduction stops and the patient develops all of a sudden facial paralysis. With this proximal paralysis, all the other features are adjoining along with the paralysis, like the GSPN is involved, the stapedius is involved, chorda tympani is affected, because all are distal. So all majority of these patients, when you elicit the history, they will present with a history of all these symptoms like taste, the hyperacusis, you know, the lacrimal symptoms, all those symptoms you may get on those patients. The submandibular flow, all salivary secretion, everything. So now the management of this condition, this is so controversial, and I will here take this opportunity to clear some facts about this. Number one, the primary treatment of Bell's palsy actually is nothing. It recovers on its own majority of the time. Yes, steroids do help. It doesn't mean that steroid is everything. There are so many studies done. On one arm you don't do anything, on one arm you give steroids. Advantage is definitely there with the patient with the steroids. as they have a more better chances of recovery, faster recovery, as well as less chances of, the residual issues like synkinesis and other problems, as compared to non-steroids. Okay? So the first treatment is steroids. Then the other treatment like Sternat's protocol or modified Sternat's protocol, if you see, with steroids, antiviral, so many things, to improve the blood flow, dextran and everything. You can give, if you want to. If you don't want, I don't find any difference, any significant difference. The biggest question is, what happens to those patients who have not recovered? And could we do something to those patients to improve their recovery? On one hand, you have 100 patients and you have not done anything. Out of them, 80 recovered, 15 to 17 have some partial deficits, and 3 to 5 have significant deficits and synkinesis in a natural course. On the other hand, can your some intervention help them improve better than this data? Yes. Yes. And we have to understand this electrophysiology of the nerve for that. We have to understand the role of electrodiagnostic test, and we have to understand the role of surgery in those situations.
How much importance do you give to the electroneuronography?
Yes, that is very important test, boss, I tell you. Electroneuronography and electronystagmomyography both, I tell you. So what I said, we need
describe it.
Yeah. So in order to understand what I'm trying to say, first we need to understand what is electrophysiology going on in facial palsy, in Bell's palsy. What is the role of electrophysiological test? And in what percentage and which patient is the role of surgery? By and large, as I mentioned, in a natural course of recovery, 70 to 80% recover almost completely without doing anything on the steroids only. So what do you infer out of that? Majority of the patients recover on their own. Why to do anything? And certain people have a dogmatic approach not to do anything. Yes. And they are right up to 80% of the time. Okay? But the poor patient is suffering 15 to 20% of the time because of that dogmatic approach of not doing anything. Now, what can we do? So first, to understand the electrophysiology, what happens when the nerve is compressed? The first grade injury is when the cytoplasmic flow in the axons is stopped because of the compression. That is neuropraxia. If that kind of the injury is there, it will recover as the swelling disappears over time. It doesn't lead to any residual injury to the axons. The second grade injury is axonematis. Axonematis is what? Second grade, when the particular axons are injured. And that you have to pick up by electroneuronography. Electroneuronography is what? Electroneuronography tests how many percentage of the axons in the facial nerve are not responding or are responding, as compared to the opposite side. Okay? Third grade injury is, besides axonematis, there is neuronotematis, means a significant chunk of neurons are injured. Now, by means of any electrodiagnostic test, you cannot differentiate between neuronotematis and axonotematis. Grade 2 and grade 3 you cannot distinguish. That is a lacuna. That's why I am saying there are two types which you cannot discriminate. Now what happens? You don't do anything to the patient and the patient has a grade 2 injury, axonotematis. It recovers most of the time with little residual. After the 80% who recovers completely, 15% fall in that category of axonotematis, where it recovers over the period of time with little residual synkinesis or deficit. Up to 5% are grade 3 injury neuronotemasis, which you cannot pick up by any test. And you cannot differentiate by electrodiagnostic test between grade 2 and grade 3. So if you leave that, that is a disaster to those 5% poor patients. So the role of electrodiagnostic test is invaluable in facial palsy. And why? What happens when the facial nerve is injured? The moment the nerve is injured, the distal segment undergoes Wallerian degeneration. And it takes almost 72 hours for the Wallerian degeneration in the distal end to complete. In that period of time, if you test the neurological test, it will be false. Okay? After 72 hours, or sometimes we advocate after 5 days, you can say, to stay very, very specific. We advocate electroneuronography after 5 days. And that will test, that is a comparative test on both sides. So we will test on the same side, ipsilateral side which is injured, how many fibers are not showing electrical conduction as compared to the opposite side. And that makes the difference. It is not a single test, the serial test, 5 days, 7 days, 10 days, 14 days, I will do 4 times. To see the progress, that how many axons are not working, you know. So if the both things have value, the intensity, like on the first test, I find 95%, it is reduced by 95%. It is significant. If you find on the first time 95%, that means there could be significant number of axonomatosis and neuronomatosis also there, which may not recover. And many of them do not recover. That's why on the first injury, if you have 95% or so damage, keep your fingers crossed about the recovery, number one. Most important is serial changes. If it persists on the serial electroneuronography even on the 14th day, that is quite significant. Second thing which is significant is the, the intensity. On the first electroneuronography, if you have only 40% neurons functioning, that is good sign as compared to 90%. And they have a good chance of recovering back to normal. So if I do on 5th day electroneuronography and find 40% functioning, it's a great sign. I can be rest assured that this nerve is going to recover. I don't need to do anything. So on 14th day is the crucial, because that time the degeneration is complete, and after the degeneration of 72 hours to 5 days, after that the regeneration starts, So 14th day is a period where is the regeneration and degeneration both going on. Now the second test, electromyography. What is that? Myography detects the regeneration value. So what happens? Why do we do electromyography after 14 days or say after 21 days? So by that time, if there is a small injury like neuropraxia, majority of those neurons will start recovering, And if you pick up on electromyography after 14 to 21 days, you will find you put the needle in the orbicularis oris or the orbicularis oculi and ask the patient to do some volitional activity, voluntary activity, and you find the EMG response. That means that patient is going to recover. That may be having 95% EMG response lost. Got my point? Both tests has a value, not a single test. Yeah. If some test has a 95% damage on ENOG, electroneuronography, even on 14th day, but after that, the EMG shows the volitional activity after 14 day. That means the recovery is going on.
The regeneration has started.
Yes. So in spite of a zero ENG, if EMG is there working, that is a sign that you don't need to do anything. Okay? So now, keeping aside these number of patients, few percentage of the patient come into the category where the ENOG is more than 95% damage, and even after 21 days, no EMG, absolutely silent. You ask the patient to put a needle in the orbicularis oculi and ask the patient to voluntarily mobilize the eye, and no EMG activity at all, no volitional activity on the EMG on 21 day is the indication that you have to do something. Otherwise, this is the subgroup of patient which is not going to recover on its own.
Which needs something extra and intervention.
Yes. So only you have to address those groups of patients. If you ask me what patients you will do decompression in Bell's palsy, I will decompress only those patients who present with a grade 6 palsy at the beginning. Majority, 90% of the Bell's patient present with grade 3, 4 palsy, not with grade 6. Okay? So only patients who present with grade 6 palsy, out of them, patients whose ENOG shows more than 90% damage, and EMG along with that on 21st day is silent, only that group of patient I will address. Number one, that is one part.
Silence or defibrillatory footstep
No,
potential?
that is different.
That's different.
That
Please
is,
specify.
yes, fibrillation potential means they're not working at all.
Exactly.
I am talking of volitional potential. I am talking of volitional activity. Okay?
Satish?
Yes, madam.
Satish, as we are telling that after 21 days, if it is EMG negative, we'll go ahead and do the surgery. But basically on clinical ground, what we
Your voice
usually
is
do-
breaking, madam. Your voice is breaking.
Hello?
Yes.
Madhuri can't hear you.
Is it okay?
Yeah, better.
Yeah, better.
Okay, so usually in our clinical practice, we wait for at least 3 months. So now
No.
on
That-
EMG, we can start after 21 days.
that means that patient is a poor fellow. Is suffering because of the weak, we can say. Our lack of knowledge, because of that patient is suffering. If you wait for 3 months,
Scientific algorithm.
it is not scientific. I tell you, this was a study done by Bruce Gates in Iowa University and published in Laryngoscope 1999. That was a landmark study. Don't be dogmatic what I am trying to say. Try to understand. I am not after doing any decompression in every Bell's palsy. Ultimately, you know how many patients fall in this category? You know, less than 5%. Less than 5%.
You're right.
Only those patients who present with grade 6 palsy, only those patients with more than 90% damage on ENOG after 14 days, and only those patients after these two parameters have silent EMG on 21st day. That's it. And that
Scientific algorithm. Fantastic.
yeah, so that percentage of patient is less than 5%. So if you ask me, would you decompress in Bell's? I would say in less than 5% certain category of patients. Okay, number one. Now number two is what kind of decompression will you give?
Exactly.
Now, if you do a decompression of a tympanic and mastoid segment in those patients, that is a joke. Because that is not the site of culprit.
Inflammation, correct.
The site of culprit is labyrinthine
I want to
segment.
say
So
something
those,
about timing. Satish,
yes? Yes, sir.
Satish, I want to say timing.
Yes.
Ashish, a friend from Frisco, Jackler. Ashish Bhumkar,
Yeah.
your friend, Jackler in Sacramento.
No, he's in Stanford now, yeah.
Yeah. He recommends 4 months.
Sir, I will come to it. There has to be a...
I'm just bringing in a discussion.
So Satish will...
I will tell you the science behind it.
I'm not trying to...
Okay, Satish, explain that aspect or that perspective or that part
Yes.
of the science.
So that part is, the surgeons believe that why to do unnecessarily surgery on those patients who are recovering on their own, right? But that's why I explained in last 15 minutes in detail about the electrophysiology and the value of test and the science behind it, what group of patients to be addressed as early as possible. Now, in those patients, in those poor patients at 21st day EMG silent, and if you don't operate on that and don't do a complete labyrinthine and tympanic segment decompression, those are the patients who are likely to have with problems, with deficits, with synkinesis. And you know, initially, this was a large series. This was a 15-year hard work of Bruce Gates. He published in Laryngoscope 1999. It is not a small study, and it is not a study spanning months. It was 15-year long study, a very dedicated study. He found that observation, and in his observation, those patients, he divided the patients into two groups. Those having silent EMG, he is not operating, or patients are not willing to get operated. And those patients with the same parameter, he did a complete middle fossa transmastoid decompression of the labyrinthine. And you know the results. 1 year down the line results. Those whom he decompressed, 91% of the patient had a complete recovery without any deficit. And those who didn't operate with the same parameters, only 58% of the patients could recover completely. And those 40, almost 40% of the patients are suffering because of the lack of scientific knowledge by surgeons, I tell you.
Yes.
Why not to operate? Now I tell you why. Why we are dogmatic about not operating. Certain people,
Just one question.
certain people, I'll come to you, Ashish.
Yeah.
I'll come to you. Certain people are so dogmatic, coming to the level of fighting out that why are you unnecessarily operating. First of all, not required in every patient, mind it. Before they discuss, they should come out with a science, number one. They should come out with a something to substantiate their finding, number one. Number two, those are the people who do not know middle fossa approach, who have never done middle fossa decompression, and they will speak against that. Any of them, if has done middle fossa approach and not found result, he should come out. That is my submission. Now, Ashish, yes.
Satish, is there any value in Sherman's test to determine the level of the decompression?
Not really, boss. That is not so diagnostic. On the
One minute, Ashim. This Bruce Gant's study, does it make 21 days as the milestone?
yes, yes.
Yeah.
So if you delay more,
Yeah.
the less are the chances of recovery.
And then
That
can you
is
make
the
a comment on Morwani sir's thing about observation about Jackler saying 4 months. Where is the discrepancy?
you ask
here?
Jackler now. That was the past. That was the past. You ask Jackler now. Is your friend.
I have a question.
Fine. Control.
Now people will always fight that I have seen a lot of Bell's palsy patients recovering on their own. Why to operate? The reason is
That's anecdotal.
those patients who are not recovering are not going back to that surgeon. They are going back to some other person. So they don't know their failure. They don't want to come out of their failure. They don't want to learn middle fossa approach. And you can't do anything to psyche of those people.
Your message is very clear. I can see
You can't do anything to the psyche of those people. This is something against I tell you.
Many people are asking to start discussion, but I think I should say to everyone that this discussion of last half an hour, they should review it again and again, and I think you will not get in this discussion anywhere in books and things. I think.
So this is pure evidence-based medicine I am talking. Pure evidence-based
It's very
medicine.
clinically relevant. Ralph,
Now-
do you have any comment on this?
Ralph, your experience.
I haven't performed decompression operations in Bell's palsy so far, so it's not really an option for me.
Okay,
And Satish
fine.
told us
So, see, the middle fossa approach is not popular amongst ENTs. And I tell you, it is a difficult approach, not as easy as other approaches. You have to get used to this approach. That's why, a lot of people are not doing the middle fossa approach. That's why this science is not taken up, and a lot of people are defying the surgery even when it is needed. That is the reason behind it.
Okay.
Then if in some places, if we do not have electroneuropathy or EMG, then what should we do?
Then
No.
then you cannot.
Separate
Then
to
you have to take your own
substantial
decision.
No ECG, no heart treatment.
Satish,
Yes, sir.
Satish,
Yes, sir.
you know, me and I have been doing transdiagnostics approach for middle for a level 9 question.
Yeah, I will come to that, sir.
If you give opportunity to Madhuri, he can show you in 2-3 minutes the complete approach.
Yes, I know. We
Videos
are
of
coming.
better than my videos. He
Sir,
can give
I am coming to it. I always mention Madhuri's approach and the reason to it, the science behind it. It is very,
Madhuri is
very.
doing much more cases than me. Now because my volume is this.
Or you have grown old.
Hello, Sajid, carry on, Satish.
Yeah.
Carry on, Satish.
Yeah. So I'll come to that. The decompression.
Madhuri,
See,
you can talk.
for
Madhuri
the
can talk on
okay.
transdiagnostics.
Let me put
He
it.
finishes in the last one.
Yes.
In
Let
the
me
last
let me tell let me tell audience what Morwani sir was saying. His point was, you don't need to go to the middle fossa approach every time to decompress labyrinthine segment. What is he trying to say? What I believe now in between.
Highly pneumatic master.
Now, yes, Ashish, what I believe in between, in certain group of patients, which you can pre-op predict very well on radiology. I will tell you criteria. By means of which, pre-operatively on radiology, you can make out that these are the patients wherein you can do a labyrinthine segment decompression, even by the transmastoid approach. You don't need to go by middle fossa approach to unnecessarily make your life hard, okay, difficult. So what are those criteria? What I mean to say, in a more pneumatized atic, you have the option to dissect to go to the labyrinthine segment without going up to the middle fossa. So what I have 4 criteria. I look at the CT scan. Number 1, if you want to note down, 4 criteria on CT scan by means of which you can predict whether you will be able to see the labyrinthine segment and decompress by the transmastoid approach. Number 1, in the axial section, anteroposterior, if you see the semicircular canal, lateral semicircular canal and the labyrinthine segment in the same level, at the same level in one section, anteroposterior, that means your labyrinthine segment is quite below, it is accessible, number 1. Number 2, in that section, if you find the length of the labyrinthine segment more than 2 millimeter, that means it is not obscured by the semicircular canal and you can access it. Number 3, which now is not relevant, as if we go by Morwani sir's approach, the transzygomatic, it has not relevance, but it is, the third segment is, if you go by a regular approach, the thickness, anterior thickness of the semicircular canal. That bone should be more than 1 or 2 millimeter thick, otherwise, the moment you go to, trying to go to the labyrinthine segment, you will end up damaging the inner ear. Okay? And 4th is, on a coronal scan, see on the coronal scan, you see both the labyrinthine and the tympanic segment in one piece, in one view, like owl's eye. Owl's eye, both the nerves in one view on the coronal. The inner one, the medial one is labyrinthine, outer one is tympanic. If the bone between them is more than 1 millimeter thick, means you have good access to drill out and find the labyrinthine segment. So on pre-op radiology, if you have 4 criteria fulfilling, that means you don't need to go to middle fossa and go to the labyrinthine segment by the transmastoid approach. And to add on to exposure, you can lift up the middle fossa, dura up, and you get more exposure. That way you don't have to go to the middle fossa approach. Is that okay?
Yes, sir.
Okay?
And when you lift up the middle fossa dura,
yeah,
you don't have to be worried. Put a thick elastic sheet.
Yes, sir.
Between your dissection and the middle fossa dura. Thick elastic.
Yes, so that will protect as well. That's a good point. So that comes from experience.
Wonderful, yeah.
So now, what are the other indications of decompression here? When we talk of decompression, this was one I talked about, the bells. Second thing is, when you give a iatrogenic injury to the facial now, let me, meantime, I'll keep on dissecting see, I am not going to the mastoid and the tympanic segment. We have all seen in detail in the temporal bone dissection.
You're
Agreed?
going to show the middle fossa?
Yeah, I will show middle fossa on the other side. So can I skip the tympanic and mastoid segment? We have always seen in, we have seen so many times in ear surgeries, and I mentioned in detail in the, in the temporal bone dissection. If anybody wants to refer, can go to the temporal bone dissection video on YouTube. Ashish, do I skip that part?
Yeah, okay. Otherwise, if you don't mind, can you show it up to the GSPN? If you don't mind.
Okay, I will show the middle fossa, everything, all the segments again, from a different perspective. Middle fossa is different perspective than anatomy of the middle fossa is different than others. Because now you are seeing from upside down. What my point?
Yes, yes.
Yes.
So,
Above downwards.
see, I will show on the opposite side. Are you getting picture?
It is yet in the transforming phase.
See, this
yes,
is.
now we getting.
See, this is opposite side. Can you see the upper part of the pinna?
Yes, very well.
Or can you bring the external camera here? Get me external camera for the upper part. So meantime, when I show this approach, let me tell you the other indications for decompression. Decompression is one subject which is always unnecessarily has brought to the kind of something kind of discussion, dispute, full of dispute unnecessarily. So the first part is clear about the bells. Only less than 5% of the patient require. Second indication is iatrogenic injuries. Idhar aao. Uncha karo. Iatrogenic injuries means, अरे यार इसको.
Sir, here I have a question. question that what if post-operatively we see a facial palsy and we are sure that we have not done anything to the facial nerve? So then should we wait till the next day morning and then
Yes.
explore?
That's what I am coming to, iatrogenic. So the second indication is iatrogenic. If you have injured intraoperatively, or if, like Paramita is asking, if you found post-operatively patient doesn't have a normal function, and you are sure or not confident where you injured intraoperatively or not. So that is the second indication when you have to go back and look at the facial now. If it is not injured, decompress to the proximal and distal level until you find the normal level. And many a times you find if it is not very infected field, we advocate the sheath opening so that it completely decompresses. So the second indication is iatrogenic. Yes, Paramita.
You wait for a day and
No. If it depends upon the surgeon. See, if you have injured the nerve,
Any role for imaging in this, Satish?
sometimes, not always. So it depends upon the surgeon. If surgeon is experienced, suppose if surgeon is experienced, if a surgeon like Ashim Desai is operating and he is sure that he is not injured the nerve, obviously he doesn't have to rush now. He can wait. It may be because of some other reason, edema or something, the nerve is, compressed or something, he can wait. But a junior guy who himself is not sure of having transected the nerve, and patient has a grade 6 palsy, immediate post-op, that is something where you don't have to wait. You don't have to wait for the degeneration to progress, and in that situation, you get some senior person with you and re-explore. Many a time we have re-explored such situations and done facial nerve repair. It is available on YouTube also of different interesting situations. So the second indication of decompression is iatrogenic. Third indication is trauma, and that is again a lot of dispute over it. In which traumatic situation you have to decompress, which situation you don't have to, and the timing of decompression at the same time. That is again an issue of big debate. I tell you a very clear concept. If post-trauma, the patient immediately develops a grade 6 palsy, then you imagine that the nerve is injured and you have to do something. That is the indication if the patient condition permits. But if the palsy, कौन सी जा रही है? नहीं, इसी को जाने दो.
Satish, can I say something here?
Yes, sir.
Satish, Mario Sana had a head injury.
Yes.
He had a facial nerve palsy after 3 hours.
Oi.
3 hours.
After 3 hours?
After 3 hours, gradually he started getting facial palsy. He went to Yoga Fish. Yoga Fish says that red palsy you are going to improve, so he did not operate him. And Mario has a deficit of grade 2 or grade 3. I think it's grade 2, he calls it grade 3. So what is immediate is also important. Immediate, when people say immediate means right now, injury hua or hua. So according to me, few hours, I will consider immediate, okay? Where there's a small body spectrum which has gone in, and it is gradually causing edema to the facial now. And this is why after 3, 4, 5, 6, 7 hours, you get aggressive palsy.
So yes. So if there is a
example is Mario Sana.
Immediate palsy, you have to explore. That is one of the indications. In patients who sustain trauma and develop palsy after few days, doesn't require any immediate exploration. And those are the patients where the nerve is injured because of the edema and the nerve is compressed in the canal. And those are the patients you don't need any exploration. Third is the category when on imaging you find a fracture line and the patient has a complete palsy. See, CT scan, a good high resolution CT scan can pick up the trauma, the fracture, but it is not 100% sensitive. Bulb hai ki nahi?
So what about this? We say bone specule.
Hello?
Hello?
Yes, Paramita.
So what about the bony specule that we say after trauma, which is causing the palsy? So how
Bony specule, yeah, that's what I am coming to. So you can take the help of imaging in that situation. And on imaging, CT, On imaging, if you find that there is a fracture line or some bony spicule impinging on the facial nerve, that is a straight away indication for, exploration. See, a fracture line of the facial canal in the present context with a facial palsy is an indication for exploration. Because in that situation, it may not have completely transited the nerve, but it may have given hematoma inside the nerve, which is compressed, and decompression will certainly help that. So in trauma, all patients do not need, number one, immediate palsy are the patient who have to be done. Secondly, delayed palsy not required. And thirdly, patients having fracture line, you have to do. And fourth is no fracture line, but still you are suspicious of, you can follow with the electroneuronography. The same philosophy like you do in the Bell's palsy. Electroneuronography at 14 days, more than 90% loss, EMG silent, you have to go ahead with the decompression. Okay?
Satish,
Yes?
there are certain, going back to Bell's, there are certain situations where certain studies have shown that there is MRI enhancement of the facial nerve.
Yes.
Contrast enhancement of the facial nerve.
Geniculate ganglion, I think.
At the geniculate ganglion.
Yes, yes.
So is that an indication for
No.
intervention?
No, that shows the inflammation, edema going on, but that cannot be translated into the, the indication for surgery.
It may go off on its own. That's what he's saying. That's the pathogenesis. Okay. Middle fossa, please tell us all the steps, Satish.
Yeah, see this lateral part, Ashish, this incision on this thing, I am going fast because we have to discuss other core issues. A lot of things to be discussed, lot of nerve anastomosis and animation.
Yes.
So
Let's
we need.
catch up. Yeah. Okay.
So what I am doing here, just raising this flap. See, I am going very fast and crude. That doesn't make any difference here. See the temporalis muscle below?
Yeah.
This is very important in anastomosis, and you remember the Ralph demonstrated in Pune the temporalis myoplasty.
Yes.
Yes.
Please go ahead.
The lengthening myoplasty described by Daniel Lebe.
Lebe technique.
Ashish, your friend.
So we had approached Labe, and Labe was to also come, but he has promised some other time. He's not on this. With Labe, we are going to do one more seminar.
Yeah, I remember before this course, Ashish contacted Daniel Lave and he was busy.
Yeah, no, but he wants to come also. But he says you have to give at least a half an hour slot for his physiotherapist, he calls him. Because he says without intense physiotherapy, his technique has no meaning.
We will discuss that. Ashish, it has some role in certain indications, Every technique is important.
After the lengthening myoplasty.
Yes.
He says post-surgery.
Yeah, see, I will show every technique today and with its indication and contraindication in the present context.
You're going to show the Labe technique
So,
also?
are you, yes, we'll show Labe. Labe will not take time.
Yeah, okay.
So, are you oriented?
Yes, very nice.
Or do we bring the external camera? Still, this is with the microscope. So, for your orientation,
Very good.
so for your orientation, this is superior to the auricle. See, this is superior. This is anterior and this is posterior, okay?
Yeah.
You can see the extraordinary canal here, the tragus here, okay? So, in the middle fossa approach, the approach is coming from above the temporal bone. And see now what I am doing here again, I am dividing this temporalis muscle and making a flap of it. A lot of people do differently. There are many ways to do the same thing, But here quickly, I am just exposing the bone because our goal is the bone removal.
So making a posteriorly based flap?
Inferiorly based, madam.
Okay.
So, sir, there are many questions from the audiences. So, this is just an announcement for all the viewers who are watching. We'll take all your questions at the end of the session.
You can ask in between also, no problem. I have no issues.
Okay. Dr. Nageshwar Rao from Vizag is asking, in post-traumatic bilateral facial palsy, what will be your protocol?
Post-traumatic bilateral. I have already discussed You have to monitor with the EMG and ENG. In case you have to take a final decision, you have to monitor with the EMG and ENG. Now see from above, where I have reached, this is the level of the superior surface of the extra-aortic canal. Can you see?
Yeah.
See again to reorient you. This is the extra-aortic canal from here, cartilaginous, and this is the bony canal. Can you see here?
Yes, yes, very nice.
Clear? And then you have to make, this is the temporal line going behind. You see this is the defining the tegmen here.
Yes.
Yes. Yes.
So now we have to make a craniotomy of roughly 3 by 5 centimeter.
So how much anterior, how much posterior?
So 3 to 5. वो देना वो बस craniotomy से कर दो. Craniotomy लगा दो. Craniotomy से कर दो. Yeah, craniotomy से कर दो. Fast. So we'll do fast with the craniotomy here.
So is it just above the root of the zygoma that you will approach?
Yeah, it will be like this, rectangular.
Yeah.
See this? Just above the root of the zygoma, and then we'll go above 5 centimeter above, like this. See this middle fossa has a lot of applications. This is one of the application to do a labyrinthine segment decompression. I told you this is a difficult approach. That's why a lot of people are against any decompression of the facial nerve in bells. That is the major reason.
Trained. I don't think it's difficult. No, it's just that we have not been trained.
So, अरे यार क्यों हिला दिया? गई, light गई. So there are other indications of this approach as well, and very often we use this approach for the, dealing with a temporal lobe herniation into the mastoid. So when there are big herniation of the temporal bone in the mastoid, what we do? The same bone, like I told you, to elevate. We elevate the bone.
Craniotomy bone.
We elevate the bone beyond the dimensions of the defect of the tegmen. Like tegmen has a defect 1 by 1 centimeter. I will elevate 1.5 by 1.5. And then I will push that bone from above the tegmen, between the brain and the tegmen, to interpose that bone so that the brain doesn't herniate below. Got my point?
Yes.
Yes.
So that is something different. अरे यार light, सब जो आता है light हिला जाता है यार.
It is a loose connection. Somebody.
Yeah.
The plug is.
इधर आ
Can you
जाओ.
rotate
बिना हिला.
the camera a little bit because
Yeah,
it's
a
looking
slight
angular.
axis.
Yeah, I will.
Just
See,
rotate the camera.
the problem here, the microscope. Let me just do a craniotomy and then show you.
Yeah.
You see below, that is the extra-aortic canal.
Yeah.
Just keep orienting towards the canal. This is the canal, you can see.
We can see where that. Yeah.
And
Not
this
where
is,
he's drilling. It's just,
yeah, one place you see the dura.
Yeah.
Then we'll place our craniotom and remove the bone flap completely. So by this approach, this is one of the best approach for dealing with the temporal lobe herniation in the brain, for large tegment defects. Many a time post-mastectomy, post-trauma, iatrogenic, so many things. And this is the final approach. And in coming webinars, we'll probably show in one of the case this middle fossa approach for tegment defects.
Prepare.
Now, Madam Madhuri has a very good video of this. I saw last time of this showing with the middle fossa approach. Then are the lesions in the intra-aortic canal which have not gone to the CP angle, only in the canal with good hearing.
Yes.
Why I am saying so?
Sparing hearing.
Why I am saying so? The intra-aortic canal you can approach by the translab approach also, but at what cost? At the cost of hearing. But in translab, as you go, you sacrifice the hearing. If you try to go with a retrosigmoid, it doesn't give a good exposure of the lateral part of the canal. Okay? It gives a good exposure of the medial part you can get without sacrificing the hearing. But in the translab, in the middle fossa, you can preserve the hearing and can remove the lesions from the medial part of the canal. So this is the craniotomy going. See how the craniotomy being going on. You can remove this segment. In the live surgery, if you can give time, You can use your diamond drill and do this, but that can take long and long hours and hours. Studio can no. Drill se karo. Without damaging the dura. So the indications for the middle fossa approach are different. Now, last point regarding the decompression we were discussing. The indications for decompression we have discussed. Number one, for bells, for trauma. The third indication for the decompression is for recurrent facial nerve palsies. You know, in some syndromes and some infective situation and many patients who do develop recurrent facial nerve palsy, it is best to do a total decompression of the facial nerve. And now the literature supports it, a lot of publications. It works. So that's a good indication in the situation of recurrent facial nerve palsy.
After which episode?
Pardon?
2 times?
After 2 times, yes. If the patient has come back with a recurrence, the better to do a decompression. So there are so many indications for recurrent.
What about the cases of cholesteatoma? If there is preoperatively facial palsy, then you think that we remove cholesteatoma and it will be,
Yes, that's a good point, Paramita. Cholesteatoma, patient presenting with cholesteatoma, having facial palsy, is a straight away indication for surgery without wasting time. And it is always the cholesteatoma sac which compresses the facial nerve, and majority of the time, if the patient present early, the moment you remove the sac, decompress the facial nerve, proximal and distal to it, it recovers, unless it is completely destroyed by the cholesteatoma. So earlier you do, better are the chances of recovery, and majority of the patients do very well. See this middle fossa, the problem with the middle fossa is the time consuming. First this bone flap, though we are doing very fast, I will remove this bone flap. What I will show only from this, I will not go to the intra-auditory canal. What I will show is the access to the labyrinthine segment of the nerve, so everyone who is watching can justify and start doing this for those poor patients who can be further improved by, yes. Further improved by, बिल्कुल नीचे तक लेना, एक सेकंड, yes, this approach. So this middle fossa should be taken up by the ENTs. It is purely extradural. We are not going to go inside the dura at all. Yeah. It's very, very safe approach, except in elderly people above 65, where the dura becomes so, resilient, you can injure easily. This is a very good approach. But for indications which are important for this, not for everything. And for labyrinthine segment, it is amazing. Along with this, I will show from inside the anatomy of the middle ear and mastoid. I will today show now the anatomy from above of the middle ear and mastoid. Number 2, if you want, I can show from above cochlear implantation. The reverse strategy of cochlear implantation from apical to basal segment. Got my point?
Yes, sir.
So, this was devised by Coletti long back. Coletti devised the middle fossa approach for cochlear implantation in patients who have CSOM. Patients who have CSOM, if you go by regular approach, your implant can get infected. Middle fossa being extradural approach, I will show you exactly where the cochlea is. I will open the cochlea for you from above, and you can pass on the implant from above, staying out of the middle ear and mastoid at all. So that can be possible even in the patient who have CSOM. Without dealing with the CSOM, still you can go ahead with the implant. But now, there is no need, we have a better technique for that, and that is subtotal petrojecmin implantation, which treats both the pathology together. That treats the CSOM as well as that gives the best opportunity to implant also in the sterile zone. So, after the subtotal petrojecmin implantation, no need of middle fossa approach for implantation. Okay, next.
So, the subtotal petrosectomy. over middle vein fossa approach.
Pardon?
You subtotal petrosectomy over middle vein fossa approach for cochlear implantation in chronic SOM?
Yeah, not middle fossa approach, subtotal petrojectomy.
Okay.
There are many indications of subtotal petrojectomy implantation, same stage. Not only CSOM. All difficult situation of implant can be easily taken by subtotal petrojectomy, implantation and obliteration.
Okay.
So here my bone flap is going to come out in a minute now, and then I will show you how to identify the labyrinthine segment from above. The principal landmark for this going to be the GSPN and the arcuate eminence, and taking two in consideration, I will show how you can go to the labyrinthine segment and then to the intra-auditory meatus, and how you can do a total decompression right from the labyrinthine segment to the second genua, to the stylomastoid foramen. Total decompression of the facial nerve from above. From here you can do the tympanic segment also, you can do the transmastoid segment also. So that is actually the complete decompression if you want to do for such indications.
So the middle meningeal artery as well.
Yeah, that is far anteriorly. If you want to refer to, I will show you. That is far anteriorly, you will find the middle meningeal artery. Yes.
So many a times there is difficulty in identifying the arcuate eminence. So
Yes.
do you have certain
Yeah.
landmarks for that?
Yeah, that is sometimes very difficult because arcuate eminence doesn't always, indicates the superior semicircular canal. Not always.
Yes, yes.
Bone nibbler. Bone nibbler there. Now see, I remove the bone flap. Can you see?
Yes.
Yes.
See, just to refer you, orient you again.
Satish, zoom out a little bit.
Boss, this is the minimum. Minimum on this microscope. But anyway, this zoom out is required for the lateral part, but see, in the medial part we will be requiring the magnification. So let me show you at this.
Orient once again, can you tell us the superior, inferior?
Yes. That's what I am coming to. Now see. This is the ear. छोड़ दे. इसको पकड़ना है. This is the ear now. Can you see?
Yes.
We are above the pinna. उठा इसको. उठा दे. Can you see above the pinna?
Yes.
Are you oriented?
Yes.
This is anterior. You can see the eyeball, and this is posterior. Now this middle fossa. This is the approach where we are going to go from above. Got my point? Now there are lot of extensions of the middle fossa. We do many a time middle fossa, extended middle fossa approach, middle fossa transpetrous approach, and by this approach I can go even to the cavernous sinus. This is the best approach for the middle canal fossa, for any disease in the middle canal fossa, infratemporal fossa, for managing the course of the carotid, any lesion affecting, you can deal with this middle fossa transpetrous approach. That is amazing approach, the middle fossa transpetrous. So now, bone nibbler. I will elevate this dura. See this?
Yes,
Are you
very clear.
oriented?
Yeah.
Very
Yes.
nice.
Just rotate the camera a little bit.
Yes.
Slightly वो shift हो गया है जो उसका वो.
बस.
Perfect.
Now see,
Perfect.
very focused over there, and I am elevating this dura.
There's really nothing here that you can damage. It's very safe.
Yeah, as long as you remain extradural, you are quite safe, But the only thing while elevating the dura, you have to be careful anteriorly is the GSPN. Because
Satish, which retractor you use to retract the brain?
not now, but later on, if you are doing the, if you are going to the intra-auditory canal, at the petrous ridge, you need to have a good fish retractor.
Yes. Which?
Ashish has promised me earlier to give that fish retractor. I am waiting.
That is with Morwani, sir.
Okay.
See now, as you go deeper, the only thing you have to be careful is the GSPN sometimes, because the GSPN comes along with the dura. GSPN is dehiscent here many a times, and you can damage that because that is an amazing landmark here as you go deeper. Lot of people take into...
GSPN. First structure is GSPN and then arcuate eminence.
Yes.
Is needed, Satish?
Yeah, I have Pankaj was here behind. He's saying, if you want to reduce the pressure of the brain,
Take a
you
small
can.
puncture, yeah.
Yeah, but see, why to go into the intradural space?
Yeah, it's not advisable.
Yes.
But fish used to do it. I think used to make a small puncture, and he says that would make the retraction of the.
One of the biggest disadvantage of this approach is the need of retracting the temporal lobe.
Yeah.
And
Particularly.
for how long that?
Yeah, bone nibbler. Particularly when you are going to the, intra-artery canal, that is quite deep.
It takes time.
Yeah, you can release CSF.
Intermittent release is recommended.
Now see anteriorly, I am going to show you something. I hope the picture is clear in the depth.
It is.
Beautiful.
Yeah, this should be GSPN.
GSPN and the arcuate eminence, they form an angle and you have to bisect.
Yeah, arcuate eminence is behind. Right now I'm working anteriorly.
Yeah.
So we can also always correlate it by zooming out and looking at the external artery canal.
See, I am going far anterior to this Petrus ridge here. Yeah, and that is the, see, far anteriorly where I have reached anteriorly to show you something, the branch of the trigeminal. Can you see that?
Okay.
Yes.
Yeah.
Please show, I could not spot it.
Yes. So now, yes. And this is my GSPN here for everyone. This is GSPN.
Yeah.
Okay.
That is GSPN. GSPN is a great landmark for the, carotid artery. Just inferior to it. Just inferior to it.
Yes.
If I drill, I'll find the horizontal Petrus carotid.
Yes.
Okay, great.
Got my point? And just lateral to it. Just lateral to it, if I open it, is going to be the Eustachian tube.
Yes.
So anatomy from here is different as compared to anatomy from the other side. Now if I go posteriorly, yeah. नहीं उधर जाना नहीं अपने को. Now see the Petrus ridge below.
Yeah, very nicely.
To keep it retracted, you need a special retractor. This is posterior canal fossa dura. Now here.
Okay.
At this junction, you start getting venous bleeding, no, Satish? In real surgery?
Yeah. Not really. Some venous bleeding, Ashish. Only venous bleeding. Not much. Only venous bleeding you can encounter. Now, give me something to orient you with the middle ear structures here. What I was telling you. Give me the drill. Drill.
Tell us where the hell is that middle ear now from this approach?
So the arcuate eminence is still not visualized?
Arcuate eminence doesn't always corroborate, I told you.
It does not correlate with the superior semicircular canal. So only in rare cases is there.
But her question was, did you see it now? Can you see it here?
Just
Yeah. See this. This was your GSPN. See that?
Yes.
Yeah.
Could you see this?
Yes.
I told you the GSPN was going from here in this canal. Can you see this canal?
Very nice.
Yes.
That was the GSPN going, and it goes over the Petrus ridge. Now, following the GSPN behind, give me the drill.
In the same area.
Yeah, GSPN is a great guide.
Yes. So you don't even give much importance to arcuate eminence.
Arcuate eminence, I told you, madam, it doesn't always corroborate.
Yes. lost while looking for it.
Yeah, that's why I'm showing other landmarks. See this?
You're what, in the attic or?
Attic.
Yeah, see, this is the semicircular canal here, superior semicircular canal.
Superior. Yes.
Can you see now?
Yes, the color change we can see.
Can you see the superior canal now?
Yes, beautifully.
Yes.
See, there are many ways. Mario Sana, Hugo Fish, Garcia Bane, they have different house, have different methods of predicting the intra-artery canal.
Yeah.
See, this is the GSPN, okay?
Yes.
This is GSPN, this is arcuate eminence.
Yeah.
If I draw two lines like this and like this, what Mario Sana says at the bisection of this line,
Bisecting.
Yeah.
Yes.
this will be the level of the intra-artery meatus, and here at the medial end, if I retract this dura and drill away this thick bone, will be the full length of the intra-artery meatus. See this is how you have to retract. And there is a special fish retractor by means of you can retract and protect the dura. Why? Because this will require lot of drilling. It is too deep here. You remember in the trans lab, when we made a superior trough, all that superior bone was this bone which are seen from above. Now when we see from above, that entire superior trough is to be removed from here, this side. And the intra-artery canal will come below. Got my point?
Yes, sir.
So all that bone in the trans lab which was removed superior to the canal, now we are seeing from superior, and this is the bone superior to the canal.
Yeah.
So if you have come from superior to see the intra-artery canal, you have to drill that thick bone.
Yes.
So my direction of the intra-artery meatus in this situation would be like this. This.
Yes.
Roughly like this. Okay?
Yes.
Now, this is your GSPN.
And sir, what about the superior petrosal sinus?
Superior petrosal sinus. Superior petrosal sinus is at the Petrus ridge here, where I put my retractor.
Yes, sir.
See, just below that, I have retracted superior petrosal sinus only.
Yes, that is what. Yes,
Yeah,
sir.
here. This is superior petrosal sinus, you have to retract.
Just beyond the ridge.
We need a good fish retractor. Morwani sir says it is with Ashish. Ashish says it is with Morwani sir. I am not getting at all.
No, I had bought it from Ankleshriya, sir, and I was not using it. I gave it.
Now Ashish.
Yeah.
Ashish.
See the malleus.
Hello.
Yeah.
Everyone see the middle ear now, ossicles.
We can see the ossicles.
See the ossicles now from here.
Yeah.
Yes, sir.
Can you?
Yeah.
Yes.
This is the, and see the best landmark I tell you, patla dena. If you find the processus cochleariformis, your labyrinthine segment is exactly in the line of processus cochleariformis.
Yes.
This is our observation.
Say it
3
again.
millimeters.
This is our observation. We have many a time seen. Now see, this is the incus behind. See that?
Yes, sir. Yes, sir.
This is the malleus.
Yes.
And this is your horizontal facial now. Can you see? This is horizontal facial now.
Yes.
I told you this was the GSPN going anteriorly.
Yes.
From the first genu.
Yes.
Is everybody clear with the first genu here?
Yes, sir.
You can magnify and show it a little bit before you drill it away.
Do I magnify?
Yes, sir. Magnify.
Magnify and just demonstrate before you drill it away.
Okay, I will. Just a moment. Let me expose the first genu better. Now see.
Fantastic. Yeah.
Now see the first genu. See, that is the processus cochleariformis here. See this?
Yes, sir.
My labyrinthine segment will be right in this line here.
Yes.
If I drill this bone, keep this in eye, my labyrinthine segment will be right there.
Yes.
The reason is, this tympanic segment is going like this at the first genu, where it is giving GSPN and then coming back and medially here. Okay?
Yes.
Between is coming back and medially here. So between this GSPN and the labyrinthine segment in this angle here will be my cochlea. So here at this angle will be apical turn, then the middle turn and the lower turn.
Yes, the basal.
See, staying extradural, once you remove the bone flap, it is so fast.
Yes, sir.
Now I can straight away do the cochlear implantation in no time. So let's see. Now I am
You have to blue line. No, you have to blue line the superior canal.
now see what I am uncovering. The labyrinthine segment of the facial nerve.
Yes.
See, it is going medially. Can you see it is going medially?
Yes, yes.
Patla de suction tip. See now, better picture.
Very nice.
Beautiful, beautiful,
That's
very
the
nice.
geniculate ganglion, yeah.
Those who are dealing with the facial palsy, want to learn middle fossa, do practice on cadaver. This is, I tell you, little difficult approach. But once you get used to, and there are now so many landmarks to take into consideration. You can do it. It's not impossible. It's not very difficult.
Sir, there are a few
Patli
requests
diamond.
to clear the confusion of lateral and medial
Cutting
end
it,
of
Patli.
the internal acoustic meatus.
Pardon?
There are a few requests that to clear the confusion of the lateral and medial end of internal acoustic meatus.
Okay, here I will show. Where you follow the labyrinthine segment, it will go in the intra-auditory meatus only. Now, see here. Why I have taken this? I am picking up slow and smaller and smaller burr. The reason is, as I go deeper, I am going to be very close to the apical cochlea.
Yes.
Cochlea is only a millimeter away.
Sir, can you repeat the last sentence again?
What I was telling, as I am going deeper, I am changing to the smaller burrs. So that I don't damage the cochlea. See here,
Yes.
this here is going to be my apical turn, where my force suction is. I will show you the cochlea. See on
The idea of this
this,
procedure is hearing sparing, so you can't afford to damage the cochlea.
yes, see this is going to be the intra-auditory meatus like this.
Yes.
On one side of the intra-auditory meatus is the cochlea, you have seen several times. On the other side is the semicircular canal in the vestibule. Okay?
Semicircular. Yes.
Now this is, see, lateral, this is, the semicircular canal is lateral and medial to that is vestibule. If I drill this, I will be in the vestibule. You saw the vestibule that day in the temporal bone. Now I am showing that from above. Okay?
Yes, yes, sir.
So orient yourself. See, this is three-dimensional anatomy. I told you in the anatomy of the skull base, our course is 5 to 6 days minimum. Anatomy from the lateral skull base, anatomy from transcranial, anatomy from endoscopic, anatomy from transfacial approaches, neck, and then radiological anatomy. See now, here is my cochlea now. See now the dense bone coming is cochlea.
Yes.
Intra-auditory meatus is still quite deep. It is quite deeper structure. And if I go lower down, I can show you jugular bulb also. Cochlea, jugular bulb, every anatomy what you see from above can be seen from below as well. Point
So show the labyrinthine segment, please.
And for your reference, I am very close to the carotid as well. You saw that day in the cochlear implant dissection how close you are to the carotid. Remember? A millimeter distance from the anterior part of the cochlea. This is cochlea. Anterior to the cochlea, I told you this is GSPN. GSPN is running immediately above the horizontal carotid. See this. What is this?
Yes, carotid. Yeah.
See, you three-dimensional anatomy is so important. You should know where is what. That is carotid canal.
Yes.
See, this is carotid canal. Can you see?
Yes, yes.
Yep.
Very clear. And now GSPN, if I drill lateral to it, here would be the Eustachian tube.
You stay.
Yes.
This is carotid canal. And this is the cochlea. This is the anterior border of the cochlea and see the genu of the carotid. So let me open all those.
So Satish.
Yeah. Yes, madam.
Satish, what is the usual exposing the intra-aortic canal from lateral to medial or medial to lateral in medial.
Pardon?
What is the approach? What is the way of tracing the intra-aortic canal from lateral to medial or medial to lateral?
Carotid canal.
No, internal auditory canal.
Intra-aortic canal, medial to lateral.
Medial, yes.
Always.
Satish, you need to show us which part of the labyrinthine you have to decompress.
Yeah. I am going. See, I am going. Labyrinthine is the smallest segment here. You can see the labyrinthine getting exposed.
Yeah.
See, this much I have already exposed. From JNU to this much I have already exposed.
Yeah.
And the moment I remove this bone here will be the beginning of the intra-aortic canal.
That is what you need to decompress?
Yes, that is the site of constriction, man.
And that is labyrinthine portion visible there.
Yeah. And be very careful during this. And that is the region all who are opponents of this approach of decompression of this segment are those, I tell you, who are not well versed with the middle fossa, who have a fear of injuring the cochlea. And these are practical regions. You know, I am not criticizing, but these are the practical regions. But that is not science. See this labyrinthine segment. See the bone I have thinned, and that is the.
Yes.
Can you see the nerve itself?
Yeah.
Yes.
Can you see the nerve?
Yes, we can see. Now, yeah.
Let me bring out. See this now.
Yeah.
Just for your anatomy, I am bringing it out. See this.
So in decompression, what is the medial limit of your decompression?
Nothing. You just decompress one wall. It's enough.
Okay, it's enough. Okay.
Only one wall.
And also the geniculate ganglia.
Yes, obviously. And this is the tympanic segment also together. See this. From this side only.
Fantastic.
All. Now, for those I have already mentioned, there is no periosteum on this part of the facial nerve. Don't try to open the sheath. You'll end up injuring the nerve. Okay?
Yes, sir.
The patla de diamond.
And sir, what about the superior semicircular canal?
Superior canal is here. I will open it and show you. Okay?
No, so
if you want, I can show you all the lateral superior posterior canal here.
So Satish, we have to only remove the bone, just unroof it. That's it.
Just unroofing, dear.
Okay.
That's it. Because we have just to allow it to expand.
Expand. Okay. You just drill away the bony canal around it. That's
now, since I have already decompressed, you know what I am doing now?
Yes, sir.
opening the cochlea.
Cochlea. This is a very thick bone.
Yes.
So, I showed during cochlear implantation that day, this part of the apical segment of the cochlea, see this is the GSPN. This is the GSPN. The apical segment of the cochlea is just underneath the GSPN. So it is oriented like this anterior-superiorly. Apical here, middle here and the basal here.
Basal is down, yeah.
Okay? Orientation should be very clear. So now I have forgotten facial now. That we have already done. If I have to do a cochlear implantation, I will not expose the facial nerve. So goal of exposure was to show the facial decompression. And now this is a different exercise. After exposing the facial nerve, I am drilling the cochlea. So this is going to ruin the facial nerve. Yes. Anyway, so our exercise is over. This is additional exercise I am doing.
You have to show some other procedures, huh? Don't get carried away.
Yes. And see the intra-aortic canal is deep to both of these. Deep to this. This is the semicircular canal. This. The vestibule is here. Cochlea here at this level. Deep to this canal. The vestibule is here at this level. And deep to both of these here where my body is now is going to be the intra-aortic canal. Okay? So my cochlea is opening now in no time. In this minute, next minute, my cochlea is, I am in the cochlea. See this. See, this is the apical segment. Can you see the apical segment?
Yes, yes.
So, can you zoom in little more, sir?
Yeah. Let see now.
Yes.
This is the apical. This is the apical segment of the cochlea. See this.
Yes, sir.
Can you see?
Yes.
So you have to focus little more.
Yeah. Now see the apical segment.
You made it worse.
Yes, sir.
Make the focus
Yeah,
better.
focus karo. Yeah. Can you see now?
Yeah. Yes, yes.
See, the GSPN was going right here, where my, and this labyrinthine is going back. At this angle is the apical segment. Now, if I drill below, that will be the middle segment, and if I go drill down further, deeper, that will be the basal segment. And see this part of the basal segment here, where my forceps is closest to the labyrinthine segment. And that is the reason for facial stimulation when the bone is hypodense, you know, like in autosclerosis. You implant and the current may pass through a more less dense bone and stimulate the facial nerve because of close proximity to the basal ton here. So now this is the middle ton and this is the basal ton. Okay? If you drill, it will come like this, and the intra-aortic canal is medial to it. Intra-aortic canal is very medial to it.
Yes, sir.
The medial limit of the cochlea is intra-aortic canal. I shot that day in the base of the cochlea where the cochlear nerve was starting. And you can see the same thing from here as well. As you drill away the complete cochlea in the base, you will find the cochlear nerve starting and going in the intra-aortic canal. See, it is the same anatomy you are seeing from different perspective.
Yes.
Yes, sir.
Medial is deep. Okay, now.
Yes.
Now what is the change in the programming when you do cochlear implant from this side and that side? The change in programming is in that you put the electrode to the basal ton. So your tip electrode is towards the apex. Got my point? Here if you are putting the tip electrode to the apical ton, the tip electrode will go to the basal area. So your programming will be reversed. Got my point?
Yeah.
See now the middle ton of Dalpani. Middle ton coming.
Sir, so you can repeat this thing again?
You are putting the electrode retrograde. Retrograde means your tip of the electrode going through the apical ton. The tip of the electrode will reach the basal area. Otherwise, when you put through the round window, see this, that is the base. That is the cochlear base and that is the beginning of the intra-aortic canal. See this, everybody,
Yes,
can you
sir.
see the intra-aortic canal?
Yes.
And see all these nerves here inside. I quickly open this. See the intra-aortic canal and all the nerves?
Yes.
Can you or not?
Yes, clearly.
See the nerves there inside. See all these nerves here. See this better?
Yes, sir.
Very nice.
And this is the cochlear now, the whitest of all. See this? And that is the cochlear base here from where it is going down.
Yes.
So you can do cochlear implantation by this qualities approach to the middle fossa, but it is not required after the subtotal petrojectomy. This is the labyrinthine segment. I am bringing it out. See this?
Yes.
See this complete facial now.
Yes.
Yep.
See the labyrinthine segment and the intra-aortic meatus segment, both.
I'm sure that waist beautiful. See the constriction, you can appreciate that.
Yeah, here at this level.
Yes.
And see immediately dilates after that.
Yes.
So this is intra-aortic meatus, labyrinthine, first genu and tympanic. Okay?
Yes.
Mastoid and tympanic we all always discuss. We don't need to go in detail over there. Okay?
Yes, sir.
Now,
Beautiful, Satish. Super.
now I will go to the other aspect of the facial nerve, because in the temporal bone, what all you need to do on facial nerve is either decompression, grafting, you know. If the nerve segment is injured by your drill bit or anything, you need to place a graft. And the graft, let me show you graft first, because every time now we'll be needing graft. And suturing, I have brought all the sutures and needles also to show you the grafting, epineural grafting. So the graft you need is either the greater auricular nerve, and more preferred now is the sural nerve. Sural nerve has more fascicles. easier to identify with hardly any morbidity, and the length, whatever length if you want 40 centimeter, you will get 40 centimeter.
40 centimeter would be family package, I think. Whole family.
More than that, sometimes from the main trunk, if you want to, co-opt the branches of the facial nerve, on the main trunk you can co-opt with the sural nerve and divide the sural nerve in 3 branches, 3 fascicles. And you can anastomose to the 3 branches also. So sural nerve is versatile. Okay? Now, let me bring in the microscope field either.
What is typically the diameter of the sural nerve?
It is 1.8 something millimeter. Oh, इसको टेढ़ा करो. टेढ़ा. Come. इसको यूं करना पड़ेगा. Let me in 5 minutes show you the sural nerve harvesting, and then we'll go to the face.
I have seen Ralph do a neurovascular anastomosis for a pinna thing that he transposed from the forearm to here. Brilliant. I mean, he won my respect and my affection.
Sir, Dr. Ramesh Rohiwal from Aurangabad is asking that is the middle cranial fossa approach good for the superior semicircular canal dehiscence? Yes,
direct approach. See, that's a very good point, sir, you have raised. I forgot to mention. For superior canal dehiscence, it is not so uncommon, I tell you. And many of the time it goes undiagnosed. So we'll discuss in our autosclerosis session also next Sunday. This is one of the reasons of a conductive hearing loss from an inner ear disorder. The reason is
you get a mild conductive hearing loss, and people misdiagnose it as secretory otitis media.
Yes, exactly. The reason is normally when the sound reaches the tympanic membrane, it preferentially passes through the ossicular chain to the oval window. Oval window goes in, and due to the baffle effect, the round window comes out, and that's how the fluid is propagated and sound signal is propagated. With the dehiscence in the inner ear anywhere, superior canal dehiscence is one example. Dehiscence in the inner ear anywhere will lead to a third window, and that will lead to hearing loss. As simple as that.
Other indication is idiopathic CSF autoria.
Yes.
For the repair. Idiopathic CSF autoria.
Yes.
CSF autoria is a very, very common condition. CSF autoria is a very, very rare condition. Idiopathic especially, and same middle fossa approach can be done.
Yes.
And so Dr. Gauri Belsar is asking, can we put the implant through the middle turn?
Huh? Pardon?
Can the implant be inserted through the middle turn?
Yes, it can be any turn. It can be through any turn, no issues. See what I am showing quickly is the harvesting of the sural nerve. This is the nerve of choice now, I tell you. See, let me orient you first. Can you see the heel?
Yes.
Hello?
Yes,
Yes.
See the...
This is the magnification.
Yes, sir, this is minimum, sir.
Okay.
This is pico microscope.
Department.
But this is quite nicely visible.
Okay. So this is the heel, and the landmark here is the lateral malleolus. See this? And behind it, from the heel, is the gastrocnemius tendon. Can you see this? Tendon Achilles. Or you bring the external camera. Ye lao yaar. Let me have the external camera. I think the better picture will come from the external camera. So, the two landmarks what I want to show is the tendon Achilles and the lateral malleolus. Jaldi dikhao. Isse connect karo. You can harvest in no time. This is so superficial. Here, connect this. Yes. इधर लाओ ना यार, ऊंचा रखो, आगे लाओ. बार बार हमेशा ऊपर से दिखाया करो. कहना क्यों पड़ता है? जल्दी लाओ. यहाँ करो, बीच लाओ, ये सबसे सेंटर में. Yes, focus. Can you see now?
Yeah, I think the light. Okay, yeah.
फोकस करो यार, फोकस.
400 mm distance से काम कर.
ऊंचा उठाओ ना.
Keep your microscope on 400 mm and you work without
Sir,
microscope.
showing through the external camera. ऐसे कब तक पकड़ के रखोगे?
Okay, ठीक है. Then it's fine. Otherwise.
इतना हिलता है यार.
No, it's better.
No, the external camera. ये ऊंचा नहीं होता क्या और? भाई मैं हाथ में नहीं यार, इसको रखो नीचे. I don't want in hand. मजाक मत करो यार. Focus this.
Okay, it's okay. Relax. Don't worry.
Yes. Focus this.
Yeah.
Little
nice.
better.
Very nice.
Better. Yes, fine.
Now it is better.
Okay,
Yes.
perfect.
Good.
Now see, this one, यहाँ रखना, मेरे बीच में रखो इसको. जहाँ मेरा इंस्ट्रूमेंट बीच में रखो. Yes. Now this is lateral malleolus and this is tendon Achilles. Okay. In the center of this, पकड़ ले पाऊँ. In the center of it, around the malleolus, exactly in the center of these two, I am making this incision. Okay.
Yes, yes.
This nerve is quite superficial and a landmark for that is the short saphenous vein. See, about the length of the vein, how much you want, you can extend the incision. Yes.
Nowadays, they have a ring curette sort of a thing. They take multiple small incisions.
Yes. Yeah. Lot of people, when you need lot of length of this, you can do that. Now through the microscope, I will show you. Connect, please. Artery there. Can you see something structure?
Focus.
Focus.
Please.
Focus.
Saphenous vein.
Is it focused now?
Yeah.
Yes.
See the full length. I will show you the full length.
Satish, can you show the deep saphenous vein also?
Yes. That's what I am showing you for the landmark.
Okay.
Can you see this vein?
Yeah.
And can you see the nerve?
Yes, nicely.
Now, this relationship is almost constant, you know.
Yes, right.
This is the short saphenous vein. And see immediately. See what a nice nerve. See this?
Very nice.
Beautiful.
Whatever size you want, you can harvest. You can go right to the palm.
Yeah.
See this?
Gluteal fossa.
And if you want a higher one, a lot of people harvest it endoscopically as well.
Yes.
If you want a more distance, a lot of people, what do? Like Ashish said, they make incision at multiple levels. Or small incision here and then put an endoscope and tendon stripper.
Yeah.
Yes.
And you can acquire the length of the nerve, whatever you want. See the nerve. See how good a nerve it is. And this is best for the facial nerve, I believe. The greater auricular can never match this, I tell you. Greater auricular has the advantage that it is available in the same field. But if you see, the number of axons in the greater auricular are less than the number of axons in the facial nerve. And
Close to its division, great auricular becomes very thin.
Yes, so that is never a first choice nerve. The only advantage is it is in the same field, that's it.
Or very small segment is needed, then we can take.
Yes. Up to 5 centimeter greater auricular can work.
Yes.
See this now?
Donor side morbidities in this after harvesting the sural?
Pardon?
Donor side morbidities?
Yeah, little bit of the paresthesia, anesthesia in the posterior lateral part of the heel, and that because of the surrounding connection, it never gives a problem. But see how good a nerve it is,
Beautiful.
how superficial it is, how easy to harvest, and whatever length you want, you can. And more than that, you can harvest and divide into different fascicles also.
Right.
Yes.
To coapt with the branches. To coapt with the branches, you can divide it also. Okay?
Yes. You're already doing it?
Yeah, just to show you. Just to show you.
Great.
Okay? Like what we do when we divide this, when you do a cross nerve grafting, you know, what we do in the cross nerve, rather than taking one branch from the normal side, we take two branches because there is a, you know, lot of branches there in the zygomatic-buccal region. Lot of branches I will show. And we divide this sural nerve into two branches to coapt with the two branches of the normal side and then pass it to the other side for cross nerve grafting. We'll discuss this later.
To the opposite side.
Yes, I will show that.
Okay, great.
सीधा कर दो इसको. Any doubts regarding sural nerve?
No, absolutely brilliant.
Now, where is the greater auricular? Let me show you in a minute. And now then afterwards will come extratemporal to our area of interest, that is face, and there quickly I will show the other procedures one can do.
Mesenteric, Mesenteric and exposure in parotid.
Yes. Mesenteric, we have a live case also. I told you I have kept 4 live cases.
Oh, it is going to go till night?
I don't know.
Yes, we are all with you.
Now artery there, knife there.
Ralph,
Yes.
do you have to say anything about sural nerve or anything? You want to say something?
Ralph, which nerve you take? Which nerve you take?
Both. The greater auricular and the sural nerve too. In
both.
In crossface and we need the sural nerve graft. I prefer stepwise incisions. I have no experience to harvest it endoscopically, and I don't like to use a large incision over the nerve. So I prefer.
Oh, great! That means you harvest endoscopically.
No. He takes multiple small incisions along the leg.
Step incisions.
Okay. See now, this is greater auricular here.
Yeah.
See this? I will show today, we have a parotid case in the evening. I will show there also this greater auricular, how to save this. See this greater auricular? This is the mastoid above and see below the mastoid running on the anterior surface of the sternomastoid to run towards the parotid. Here it gives in 2 branches. The posterior one goes to the pinna to give sensation to the lobule, and anterior one to the skin over the parotid region. See, this is going to the skin to the parotid, this one, and the posterior one going towards the pinna. See the 2 branches, very clear?
Yes, very clear.
So this is greater auricular running on, and here it is coming out from the Mechanis point where a lot of cutaneous nerve come out of the, cervical plexus here. That is Mechanis point. That is Mechanis point. Okay. Now coming to the face. Boss, पीछे आ जाओ ये लेके. External camera. Now I will elevate this flap as a whole. ऊपर से लाओ यार इसको. इसकी पिक्चर अच्छी आनी चाहिए यार. फोकस करो. थोड़ा छोटा करो, फोकस करो. Zoom out. हाँ, zoom out or zoom out. Yes. Can you see this side of the face as a whole?
Yeah.
How is the picture overall?
Fine focus is a little bit required.
Yes, because this is the external camera.
Okay.
As a broad picture, I'll show you the external camera, and then wherever we do anything, I will show you the microscope. Okay? So now what I am doing to show you everything, first of all, I am elevating this flap, the same side facial flap completely, so that everything will be exposed.
So the modified Blair's.
Yeah, it is a hemifacial incision, I would say.
Hemifacial. Okay.
This incision we use in a very massive approach known as facial translocation approach.
Oh, what is
For
that?
facial translocation approach for tumors, skull-based tumors. Like I give you an example. The last facial translocation approach we used for a patient. You know what pathology he had? That is almost a hemifacial resection.
Oh, great.
That patient had a malignancy of the upper alveolus, buccal mucosa, infiltrated the maxillary sinus, infiltrated the ethmoid sinus, involved the eyeball, through the ethmoidal roof, went in the anterocranial fossa.
By God.
Then through the buccal mucosa involved the mandible as well. Then the outside skin was involved. This outside skin was involved and had a positive neck nodes. So we had to do, see this complete incision. It is like an apron incision, you elevate everything. It is like apron incision, you elevate everything. So in that we had to do a radical neck dissection in the neck, hemimandibulectomy, maxillectomy, orbital exentration, and a part of frontal lobe excision of the brain. And this entire area, along with the outer skin, everything, outer skin, hemiface excision, and that entire area was covered by a latissimus dorsi flap. Huge one. And the patient is doing well. It's so well. It was a composite resection. So that hemifacial resection. So those are composite resection. I am not going into that, but this is the same incision, what I am telling you. I am going towards the face so that I can show each and every branch of the facial now and the anastomosis or reanimation required at every level.
Yes.
One by one we'll cover. Now the question of direct suturing or anastomosis has gone. Now only two questions left. Either bringing a nerve or doing a nerve and a muscle. Okay? And thirdly, some specific procedure of rehabilitation of the eye as well as lower lip. That is our
Static procedures.
yeah.
Static procedures.
Static and dynamic both.
Dynamic this elongation of the temporalis muscle.
Yes. So I have kept one case for static suspension also today out of the 4.
Great.
So
cases are, what are the cases, Satish? 4 cases?
One is, post skull base surgery, facial nerve palsy, and no proximal nerve, so that is for facial-mesenteric anastomosis.
Okay.
One is for the elderly patient who cannot undergo, all this gracilis muscle transplant and all, had a flaccid facial nerve palsy, total flaccid. So we'll be doing some static slings over there.
Static.
Third patient we have a angle for the angle, and I will show DLI excision of the opposite side. Depressor linguae oris. Depressor linguae inferioris excision of the opposite side to give a good symmetry. Balance. And the fourth one is a rehabilitation of the eye by means of a lateral tarsal plate excision and loading. And that loading will not be
with gold implant.
No.
Something better than gold, better than platinum.
No, why to waste so much of money?
Okay.
I will do cartilage implant.
Very good then.
अरे यार वही लाओ कैमरा पकड़ना इसको उठा पूरा फ्लैप उठा
So Dr. Girish Umredkar from Bhilai is asking which part of the greater auricular is to be harvested, proximal to or distal to the
any good segment beyond the bifurcation, as long as you want, as long as it's feasible.
Bifurcation can be used, Satish, for when you are doing it on the face.
Yeah, but the greater auricular after bifurcation is such a small nerve. If you want for bifurcation, harvest the sural.
Yes.
Sural nerve is complete, See now, I have exposed the entire parotid up to the eyeball from ear to the eye, complete exposure to show. Now I am going to show almost 30 to 40 procedures here. Quickly.
Okay.
Whatever in the given time we get to do for different indications, you know. Now, show them. Can you see the ipsilateral face completely exposed? ऊपर से दिखाओ.
Yes. This camera is to be shifted. Yeah, now it is okay.
कोई लाइट जल सकती है क्या यार ऊपर?
More light, please.
Yeah, you need more light. No, this is too much. This is too much. ना कहाँ है लाइट? क्या देखूँगा? वही है. या थोड़ा सही हुआ. Okay. यार ये कोई
लाइट चाहिए
नहीं
बेटर
नहीं यार मैं माइक्रोस्कोप से दिखाता हूँ. हेलो. Okay. Yeah. I'll show you the microscope only, one by one area. Now, first of all, identifying the main trunk of the facial nerve. Then we'll go to the peripheral branches and we'll show one by one every procedure. See now.
Dr. Satish, if
Yeah.
you want to discuss about tympani also, they want to regarding the principle, what are the disadvantages? If we cut the nerve, then what are the sequelae?
Which nerve?
What tympani?
Okay. What I will do at the end of the procedure, you remind me, I will show you the course of the chorda tympani from the ear to the infratemporal fossa, how it meets the lingual nerve from the lateral skull base perspective.
That is the main thing.
Okay?
Yes.
Okay, now, in the parotid surgery, we all know how to identify the parotid, you know, leaving this facial nerve leaving the parotid. And we always take few landmarks in consideration. See, this is tragal cartilage. Can you see?
Yes.
This is tragus here, below. This is tragal cartilage.
Yes.
And the tragal where it ends below is known as tragal pointer. Okay?
Anterior end.
Yes. The second landmark I will take into consideration from here. This is, you know, your
posterior belly of digastric.
No. This is your sternemastoid.
Okay.
Now the anterior branch cut. This is your sternemastoid muscle. You can see.
Very clear.
Can you see clear?
Yeah.
And in the anteromedial depth is the digastric. Anteromedial here is the digastric coming. See this? This is digastric.
Yeah, very clear.
That is digastric. And where the digastric insert on the temporal bone, where the digastric inserts on the temporal bone, anteromedial to that is the facial nerve.
Facial, yes.
We'll see in detail. Here I am not wasting time here. We'll see detail in a live case. We have a parotid today. And see how the facial nerve ascends laterally into the parotid. That is the facial nerve.
Yes.
The direction is slightly anterior-inferior.
Yeah, it is lateral. It ascends lateral. Absolutely lateral it ascends.
Yes.
See, can you see the division?
Yes.
Now,
Beautiful.
the first thing we always tell everyone to do this parotid surgery under microscope. All those head and neck surgeons doing parotid surgery without microscope, they preserve the main trunks. Obviously, 5 branches, they believe there are only 5 branches. If you do under microscope, then you will find what is this pes anserinus actually is.
Yes.
Pes anserinus is the plexus of these nerves as they come out. See now. This is lower division. Can you see?
Yeah.
Now you count how many branches we see as we go distally. N number of branches.
So Satish,
Yeah.
can you show all those 3 nerves which are in the neck, like styloid and posterior auricular and posterior belly of digastric? Those are also important to see.
Yeah, that I have I could show earlier. See, this is the digastric which I have kept here, and the styloid muscles are there in the depth, deep to the styloid.
Muscle, yes.
These are all styloid muscles here in the depth.
Yes.
And this is digastric.
Yes.
This is digastric.
Okay. Okay.
Now, इसको यूँ कर ले. Now, from the division, mop करना. From the division, roughly, there are two main branches, divisions. You can see the lower and upper. The lower one is the cervicofacial. See that?
Yes.
And many times you have to do a retrograde dissection. So we should be able to trace every branch from both sides. You know, sometime in a difficult situation we may have to go retrograde. For example, if I am doing a parotid and my tumor is right centered here on the stylomastoid foramen, how will I find the main trunk? I would prefer to come retrograde through one of the branch. Secondly, if I have an inferiorly placed tumor here, why to find the main trunk and unnecessarily try to traumatize it? I'll find only the lower branch and do surgery over there only. So retrograde dissection is important sometimes to know seriously. Now, this area where I am going, I hope the picture is good.
Yeah, very good.
This is microscopic. Now, as I go in this, and if I keep on removing the superficial parotid to it, you will see these branches going. And one of the most important branch, see this below. See this below?
Yeah.
This branch is the marginal mandibular.
Very beautifully seen.
See this? And below that goes the cervical. There are multiple. See, from here, how many branches you can count? How many? 1, 2, 3, 4, 5. I can see here.
Yes.
And those surgeons say there are only 5 branches of facial nerve. And number of,
And each of these
you know,
branches, I think it's, yeah, correct.
why it is so important? Why it is so important? Because if you preserve under microscope all these branches, in any given case, if any of the branch is injured, there is a high chance of regeneration through the other branches. Because there is a strong neuronal plexus in between these branches. Now see, this branch you see, this branch you see, this branch you see. Now I am giving you high magnification. What is neuronal plexus? Connecting, interconnecting branches to these. See this under high magnification. There are n number of interconnecting branches running. See these. See this, so many interconnecting branches going. Can you see this?
Yes. Thin fiber like thing, yeah.
See these fibers and see what happens. If this branch is injured, it can be innervated by the other branch.
Yes.
And if you don't care of all these interconnecting in neuronal branches, if one of the nerve is injured, that part is deficit. So it should always be done with a microscope to protect maximum branches. Number 1. And see another point here for the mandibular branch. Can you see this posterior point of the mandible?
Yeah.
Posterior angle. This is gonian. This is gonian. And this mandibular branch, for the mandibular branch, this gonian is the landmark. This branch crosses in the 1 centimeter vicinity of the gonian. I showed in the carotid body tumor case also. The branch going right onto the gonian. That's why this is a great landmark. Like if you are doing a submandibular gland surgery, your gonian should be the landmark. Though it is variable, sometimes this branch may go even lower than this and that. But see this, see where it is going. Right on the gonian.
Yes.
Can you see these branches? Can you see?
Yes, nicely seen.
Light more focus.
This is right at the gonian. See this. This is the point.
Yes.
And where these branches are going. So this marginal mandibular nerve, this supplies mainly the lower lip muscles, the depressors of the lower lip, and there are 4 or 5 muscles it supplies. It supplies a little mainly to the depressor anguli oris. It supplies to the depressor anguli inferioris. It supplies to the mentalis. It supplies to the orbicularis oris also a little bit. So what happens if this nerve is injured? Suppose if you have a deficit of angle because of injury to this nerve, I have n number of options. Now depending upon the age, severity, what all you can do? If this is an immediate transaction, what I will suggest, do two procedures. One is join the ANSA. ANSA you saw that day on carotid body.
Yes, yes.
See this, go in the neck. They are so close to each other. See, my marginal mandibular is here at the gonian. See this? This is the nerve. Can you see very clear?
Yeah, very clear.
Yes, yes.
Yes. Now see where the ANSA is. So you go lower down on the carotid sheath and bring the ANSA up. See this. See this ANSA.
Yeah, very clear. Apollo, sir.
See my jugular here, and this is the ANSA. This one.
Yeah, yeah, yeah.
Very beautifully seen.
See this is. So go lower down, isolate the ANSA and bring up and anastomose this here at the gonian.
Right.
Immediate. If you are doing a surgery in this region and if you happen to injure, completely divide this, immediately do this neurorrhaphy. And after this neurorrhaphy, because it takes few months to, come into effect for the neurons to grow. So meantime, what all you can do to prevent the deformity? Number one, see for the angle. That's a very, very simple procedure you can do to the angle. See, this is the level of the angle. Can I have a pen? Can I have a pen? Pen. Black pen. Let me show you through the pen here.
But most of these cases recover after some time. Once we damage the marginal mandibular, but these we have seen after 2-3 months or 6 weeks, they recover very well.
That is neuropraxia that recovers.
Yeah, yeah.
The transaction will never recover. Transaction will not. See now, this is the angle. Can you see the picture?
Yeah, yeah.
Lateral to the angle here, 1 centimeter over here is the modulus.
Yes.
Modulus is what? Where all the muscles are joining. Like for example, the orbicularis oris like this. See this? This is the only single muscle in the face. Otherwise, rest are all paired. They join here at the modulus. From below, another muscle goes laterally, and most superficial of them is the depressor anguli oris. Okay, and medial to that and deeper. See this, to the angle of the mouth, this muscle, a fan-shaped muscle, goes. See this? From the angle of the surface of the mandible, lower angle of the mandible, to in superior-medially, quite deeper in the lateral half of the lip, like this. Can you see here? And that runs medial to this. This is depressor anguli oris. This is depressor lingui inferioris. Okay? So DLI is the most powerful muscle. This is the most powerful muscle. So what happens? Suppose this side facial is injured. Now overaction of the DLI will take the opposite lip to the opposite side. So what you need to do in that situation? The best is you have to do a DLI transection. That you can do from inside. So how to predict the result? We have a case today. How to predict the result? You inject in the opposite DI here xylocaine. Xylocaine. That is reversible. The moment the DLI is paralyzed with the xylocaine, you will find the mouth coming in the center and that deformity goes away. And if patient is happy with that, you can do a transection.
Good.
Botox is a midway. If you don't want to do transaction, patient doesn't want surgery. Yeah, then you can use Botox, but the effect of the Botox is not long lasting. You have to,
5-6 months.
After a few weeks, you have to again and again inject the Botox. So what I want to say here, all these muscles which control the lip, now the upper muscles are, here above is the zygomaticus major and the zygomaticus minor, pulling the lip up. See like this, pulling the lip up. And here and laterally the risorius, pulling the lip little out and laterally. So that's how the lip is controlled. So if the facial nerve on this side is gone and there is a deformity in the lip, immediate level you can, suture the hypoglossal nerve with a ANSA. And to prevent the deformity, you can transect the DLI. So I will transect the DLI of the opposite side and I will show you.
So this is a case also, no? Today you are going to show in a live case.
Yeah. It's a very simple procedure you can do under local anesthesia. See the mouth from above downwards? This is lower lip.
Yes.
पकड़ना उठाना इसको. Not focused. Now focused?
Yes, very nicely.
Now this is the lower lip. So what I will do for the DLI, see DLI inserts in the lip, lower part of the lip, first of all. You are not supposed to damage the orbicularis oris, number one. Yes, now. You are not supposed to damage the orbicularis oris, which is the main part of the, lip. You have to go one away from the orbicularis and 1 centimeter from the gingival buccal sulcus. Can you see this?
Yes.
And now in 2 directions I am going to cut it. 2 directions. See, this is DLI I am cutting.
Okay.
So one direction is, you see this completely cut?
Yeah.
That's it. And the other is the medial part so that it doesn't grow. So one towards the lip where it was going and one towards the mandible where it was coming. Can you see this?
Both sides you are disconnected.
Yeah, completely disconnected. That's it. That is DLI transaction. And in no time, the face improves.
Great.
Now the second is, another procedure is for a dynamic, because this is not dynamic. Second, what you can do is, you can make a flap of digastric. And that is a dynamic. That works very well. I love that.
Anterior belly of digastric.
Yes, you have to rotate. The reason is, the basis behind them is, the anterior belly of digastric is not supplied by facial.
Yes, it is supplied by...
This muscle has a dual innervation. The posterior belly is supplied by the digastric and anterior belly is supplied by the mandibular nerve branch, that is inferior alveolar nerve. Inferior alveolar nerve, as it comes out of the alveolar canal, it gives nerve to mylohyoid, and from there the nerve to anterior digastric comes, anterior belly digastric.
Yes.
And this transfer is again a very simple procedure. See, this DLI transaction anybody can do. 5 minutes procedure. You can predict the result by giving Xylocan before. And it is so amazing. In any patient, you can use it like that. In any patient, you have unintentionally, during surgery, you have injured the, marginal mandibular branch. To prevent the deformity, making so obvious, you can cut DLI. That time, that is inside, from inside. And you suture the mucosa back, it doesn't give any morbidity.
Okay.
Now, what to do with the digastric? This is again an amazing procedure, I tell you. How the picture there? How is the picture there?
Perfect.
Very good.
So what I want to do with the digastric, uthana isko. This is the angle of mouth, okay?
Yes.
I'll make an incision at the vermilion border. See this. So it will not be visible. See this?
Yes, sir.
My incision is right at the angle and the vermilion border. Can you see this?
Yes.
Good.
Now my second incision will be at the lower border of the mandible. See this?
For creating the tunnel.
I create a tunnel here. See what a simple procedure it is, and it starts working immediately. The moment you do it, it will start working. Okay, this tunnel, simple. Now what I will do, digastric everyone knows, so simple in the neck. Everybody knows about digastric.
Yes.
It is not difficult. See my digastric here. I will elevate digastric beyond the tendinous portion. See all this soft tissue lateral to it. And this is the tendinous portion of the digastric. And I will go behind it. This is digastric. See this?
We can see.
Yeah, digastric niche. Yeah.
Yes, yes.
Sorry. This is digastric here.
Yes.
See that?
Yes.
This is the tendon of the digastric.
Tendon. Yes.
So clear? So I will cut it behind the level of the tendon. See this?
And rotate it. Yes.
Yes. So simple a procedure. Anybody can do it again. For the lip, you can do many maneuvers. And this is a dynamic procedure, I tell you. This is not static. I have kept a case for a double sling static today. I told you an old man. And that is a very good thing. That is,
That is static. You are going to.
that is semi-dynamic because I am going to use 2 slings. That is a novel procedure. You can make semi-dynamic, I would say.
So how?
Now that I will show in the case.
Okay.
The cutting DLI is a cosmetic issue, but any functional effect afterwards?
No. See now, my digastric elevated. Can you
Such
see?
a long sling now we have.
Now what I will do through this tunnel which we created. Can you see this?
Yes, yes.
वो लाइट करना हुआ वो देखा टैटवा कहाँ गया लाइट से दिखा ना उधर से मैं इधर आ गया
दिख रहा है गो अहेड
बहुत अच्छे से दिख रहा है बहुत ही बढ़िया
दिखा नहीं सकता क्या फोकस
No, it's seen well, Satish.
Now, देखना वहां जो दिखे. See this. I am going through the tunnel to pull it out.
So now you will make 3 heads out of it, or you will put it like 1 head?
Yes. Now, I will bring it out here. Can you see here?
Yes, yes.
Yes.
And now I will suture it to the, orbiculus oris and the modulus.
So you will divide it into 3 or 2 heads. What will you do finally?
No. This is 1 head only.
So can't we do this, that we divide it into 1?
See this. This is the main belly of the muscle.
Now the end of the muscle. The end
Yes.
of the muscle.
And this is coming here. And you have what you have to do is, you have to suture here with the orbicularis oris and the modulus here.
Okay.
So the moment when the muscle contracts, it will bring the lip inferiorly and laterally. And that is dynamic because this is now based on the nerve to myloid, which is a branch of 5th nerve. So this is something you can do at the same time. And when you close this verminal border with a subcutaneous or fine nylon, it is not obvious at all. So there is no obvious deformity, and immediately it becomes a dynamic, reanimation. It is not static. So
many points about DLI. In fact, DLI on the opposite side should be done on same sitting or after some time. So you wait for some time.
You can wait. Sometime patient come late. Like this patient I am going to do today had undergone some skull-based procedure. And his eye is by and large, he's a good Bell's phenomena, so eye is not exposed at all.
Yeah, okay.
Eye is not bothered about it. Only lip is the thing which is giving problem. So DLI is the answer for that. Why to do so much invasive procedure?
It is best to do at a second stage after the xylocaine test.
Yes.
Yes, after.
The patient accepts.
Yes. Yes.
Okay.
Satish?
Yes.
Satish, hello?
Yes,
Satish,
please.
this means that this procedure is only for the damage to the marginal mandibular. We should not be doing it when there is a complete facial avulsion.
No.
Then
You
it is
can.
not to hit in the angle of
If there is an isolated repair of the lip is required, lower part,
then
or if the patient after recovery of the facial palsy has a deficit in the lower part, you can say incomplete facial palsy.
Long-standing palsy, you can do them bit by bit.
Yeah.
Yes,
So you can address the lip first, then you can address the eye.
Now, sometimes you don't have this. Suppose digastric is not there because of some neck dissection earlier or something. The other muscle you can take, again very, very robust, is a sternohyoid. Sternohyoid is a strap muscle which is rarely injured. See this here in the midline, there are stenohyoid and sternothyroid, two muscles, one above another, we all know. And this can be used many times as a free flap as well.
Yes.
I tell you, this is an amazing muscle. This is stenohyoid. See, I am exposing stenohyoid.
Centralize a bit.
Yes. See this muscle.
Yes. Yes.
See, this is the step muscle in the center. This is your sternomastoid laterally. See, this is the sternomastoid laterally.
Yeah.
And in the midline, this step muscle is stenohyoid.
Yes.
So this is based on a branch of facial thyroid artery, superior thyroid artery. In this upper part. What you can do? You can release it completely from lower down. You can use it two ways. One is as a dynamic sling, like we use this, digastric. If digastric is not available, what you can do is, you can bring this there. See, it's not far off. It is there from the upper part. Just from the hyoid you have to rotate. At the level of the hyoid was digastric, and just below is the beginning of the sternothyroid. So you can cut from below and make a tunnel and revert it back towards the lip. That is dynamic. And it's a very strong muscle.
It's a flat muscle. Does it add to the bulk?
Yes, yes. It is a flat muscle, but it is very strong. And second thing is, it is used as a free flap for flaccid palsy, where it can be used at the level of zygomaticus major. See this. From lower and upper end, you can cut, and a branch, it is supplied by the ansa, lower loop of the ansa. Along with the ansa and the superior thyroid pedicle. This is the pedicle here.
So neurovascular pedicle is.
Yes. And you can take this entire thing for the zygomaticus major.
So we can leave the gracilis and take this muscle.
Yeah, sometimes if you have a good bulk there. If you have a good bulk there, what you can do, right from the modulus here, and the other end is sutured to the temporalis fascia and pulled. And it pulls like zygomatic up, major up, and it is a good muscle for a smile.
Satish, one question for me.
Yes.
Satish?
Yes, sir.
This digastric muscle which you created and put internal, to me it looks a long muscle. In the sense, would you like to trim it to give a firmness to that? It's too long.
Yeah, it is.
Would you like to trim it to give a proper definition? You know what I mean?
No, but
it looks too long. So when it contracts, if you shorten it by half a centimeter, probably you'll get a better result.
See, the length you can adjust. See, the beauty of this muscle is, length doesn't make any difference. You can trim a little bit if it is. The blood supply to the digastric comes from the anterior angle here.
No, that part I understand. I'm telling what you brought it up. It looks too long.
So what? It works. See, digastric has a long tendon.
Yes.
Long tendon, strong tendon, it works, and that's what we want. To contract this, to contract the lip. That is what we are taking the advantage of.
So if you have adequate length of muscle, would it be better than having a longer muscle?
I don't
know anything about it.
It should be adequate only.
Yes,
so second is zygomaticus major as a free flap like gracilis. You can use it. That is a simple one, not so complicated like gracilis. You can use it.
I'm going to take some break and join you at the time of surgery. Thank you very much. Marvelous presentation. Thanks a lot.
Going, sir?
He says he will come back. He'll come back.
Okay. Now,
there's a question from Nepal. They're asking that do you divide DLI completely or partially?
DLI completely. Partially will not serve the function. Okay. Complete matlab complete.
And sir, what is the amount and site of injection xylocaine in DLI?
2 ml. 2 ml is good enough. 2 ml is good enough.
Okay.
Now, I am coming to the most important part. See, we have seen this main trunk of the facial nerve here. Yes. As I said you, the best muscle for reinnervation nowadays when you have to bring the other nerve is the mesenteric. And I will tell you the reason behind the use of mesenteric, and on the base of that, mesenteric muscle also has a flap. So now, where is the mesenteric? Why mesenteric? Why it is so close? And why normally it is so commonly used is because of difficulty in identifying the mesenteric. I'll tell you the simple tricks to identify and suture or coap the mesenteric nerve. So I'll tell you few landmarks. Number one, first of all, when you use the mesenteric to the facial, you have to dissect the upper branches completely. So during that, you don't injure that. Okay? The upper trunk branches. See, all these upper trunk branches have to be completely dissected and isolated. So because our mesenteric is quite deep to them. So while doing a mesenteric anastomosis, we should not end up injuring the facial nerve branches which are quite superficial.
Yes. Satish?
Yeah?
You please show us very clearly which
Yes,
zygomatic or temporal, which one comes in the way when we are looking for masseter nerve, whether it is zygomatic or the temporal branch.
Which nerve is it?
When we are tracing the masseter nerve now, which branch is more commonly coming in the way?
Is zygomatic branch.
Oh, because temporal goes slightly above.
Temporal is also going in the close vicinity above.
But slightly goes upward.
Yeah. See, this is temporal branch.
Yes.
I will show you. This temporal is more related in the skull base when you do subtemporal approach.
Okay.
Subtemporal approach to the middle fossa, and then you have to raise, the temporoparietal fascia, temporalis muscle. This temporal branch passes through all the layers in this region. It is so notorious. It becomes from deep to superficial, it goes like this until it goes to the eye. See this temporal branch?
Yes, beautifully seen.
As you go up, it becomes more and more superficial.
Yes. So we have to be really careful.
Careful, yes.
Looking for the mistake.
See this temporal branch?
So temporal is also called frontal branch?
Yes. Yes, exactly. Temporal is also known as frontal branch. Now see, this is zygomatic, the thick nerve. Patli there.
Yes.
Can you see? I hope the picture is good.
Very nice, very nice.
See now, this is the main trunk. This is the lower division. We have already seen branches. This is the upper division. And from them, the upper one going more and more superficial here. This is the frontal branch. See, as it crosses the zygomatic arch and becomes so superficial. See this? It divides into so many branches, Then the most important to the eye, this zygomatic. See this?
But they say the zygomatic branch supplies only the inferior part of the orbicularis oculi. The superior part is
part of it.
Part of it.
Yeah.
Yes.
Orbicularis oculi is supplied by all branches in the vicinity.
Yes.
Knife there. Knife here. See now, I am elevating this to show you some good anatomy. I am just removing the superficial part, not the deeper one. Here, this is the vein. See the zygomatic branch?
Yes.
Going in the depth. This is zygomatic branch.
Quite deep.
See this? How big it is?
Yes.
See this?
So mostly it is the zygomatic branch which comes in just closest to the masseter nerve.
Yes, mesenteric nerve. That forms a triangle, zygomatic triangle. Subzygomatic triangle, you would say.
Yes.
And that is the one of the area where you will find mesenteric.
Yes.
See this now? So clear? Very clear or not?
Very clear.
And see, this gives to so many branches over here, which if you go anteriorly with a buccal branch, they form a sort of plexus. There are more than 20 to 30 branches there anteriorly at the anterior border of the masseter and the vaccinator region. And these are one of these branches we should take for the cross nerve anastomosis. So the idea behind cross nerve, let me put up here, what is cross nerve? As I mentioned earlier, the spontaneity can come only when the firing of the branch, the neuron comes from the facial nerve only. So like a situation here where we don't have a proximal nerve intact and we are bringing this masseter nerve as an anastomotic nerve, okay? At the same time, if we do a cross nerve grafting from the opposite facial nerve branches like zygomatic or buccal branches here, lower zygomatic and buccal branches, cross nerve graft take through the upper vestibule to the opposite side and leave. And that if we anastomose to the nerve, the spontaneity will come. What's my point?
Smile. Spontaneous smile.
Spontaneous smile.
Satish,
Now,
you'll have to go step by step.
Step by step.
On the paralyzed side, you have done a masseteric to 7.
Yes.
Along with that, you're putting a cross nerve across to the normal side.
That's what I'm saying.
Yes.
The advantage and disadvantage of cross nerve. Why cross nerve graft? Suppose on the right side, I have a complete facial palsy, no proximal branch of the facial there.
Right.
So I would need the opposite facial nerve fiber for the spontaneity.
Correct.
That is the advantage of spontaneity. But the disadvantage is those cross nerve fibers in this branch are very less in number, lightly. See,
So
in the cross
smile
facial,
can be brought.
in cross facial nerve graft, you cannot have more than 1500, 1600 axons. So what you need is a double innervation. One for the power and one for the spontaneity.
Strength. Yes.
That's why we always believe in mesenteric plus cross nerve graft for every case.
So this is called babysitter procedure.
So yes, so why babysitter? Now see, how it can be done. Now for the cross nerve graft, from the opposite normal facial nerve, you put a sural nerve, join with the sural nerve, go across the vestibule and put on the paralyzed site in the first stage. It takes almost 9 to 10 months for the axons to grow there, and you can tape on with the finger. That is Tinel signs. The moment you find the Tinel sign, that means the axons have come, and now you can do a second stage. So the advantage is only advantage of this cross nerve is rest are all disadvantages.
Spontaneous.
Spontaneity.
So, but the big disadvantage is that we can cause trauma to the opposite side because we are going
That
to
is,
place in a
madam,
retrograde manner.
Madam, I will show you here. There are number of branches of the zygomatic and buccal plexus. If you take 2 branches out of them, it doesn't give any, morbidity because there is a lot of interneuronal communication. Lot of communication.
Yes.
Or for that matter, we are not taking very distal branch. Before this plexus comes, we'll take the proximal branch. So distally the other branch will innervate and there will be no, deficit. So the disadvantage number 1.
From your questions, is the discussion going in the right way? Is there some clarification you want about the cross nerve? No? All okay.
Okay, let me tell it. So first only advantage is spontaneity. Why we are striving for the cross nerve? The disadvantage number 1, it doesn't contain too many neurons, maximum 1500, 1600, so it cannot give power. So for that we need another nerve we need to add on to the power, and that is mesenteric. So mesenteric will give power and the cross facial nerve graft will give spontaneity. Number 1. Number 2 disadvantage is time. For the cross facial nerve graft in first stage and axon to grow there 9 to 10 months, and after 10 months you come with the second stage. So the disadvantage is in patient like already a patient whose 1 year is elapsed with a facial palsy. Now 1 year you elapse another with a cross facial nerve is never a good option. So that can be done only in the early time of facial palsy. Then you have ample of time for the axon to grow. Number 3, since it doesn't contain axons too much, we need another nerve. So what we do, in the first stage, we put a cross nerve graft and leave on the opposite side. At the same time, at the first stage, we anastomose with the mesenteric nerve. So meantime, 9-10 months for the cross graft to come into action, to reach there, the muscle will not get denervated and the mesenteric will give innervation. So to prevent the muscles going denervated, the mesenteric is working like a babysitter, you know.
Yes, babysitter procedure.
So it is a babysitter until the cross nerve graft come into action. The mesenteric is working like a babysitter because it takes time for the cross nerve to come into action.
So Satish, hello.
Yeah.
They say if it is already 1.5 to 2 years the facial palsy has happened, then don't do this crossover because it takes really a long time, you know.
Yeah, it is for immediate. Cross nerve is immediate because it takes 1 year additional time.
Or within 1 year, yes.
It takes 1 year additional time. So
The proximal end of this cross nerve is sutured to the mesenteric.
At the opposite side, no,
opposite side buccal, but if you're saying in the same stage.
I tell you what you do. In the same stage, if you are doing cross nerve also, you can do that. What to be done in the first stage, what to be done in the second stage, and what to do in the same stage. Let me clarify very clear, crystal clear.
Yes.
First situation, stage 1, you do a fascio-mesenteric anastomosis.
Yeah.
At the same time, put a cross nerve graft from the opposite zygomatic buccal branches to the paralyzed side. Leave it in the preauricular region. Okay? That is first nerve. In the second stage, and put a nylon thread, black thread to identify.
Suture is to be left.
In the second stage, you come. Now it takes 1 year. Mesenteric, I told you, is a very good source, and it gives sometimes spontaneous also. And in 1 year's time, you will identify, you will come to know the result of mesenteric also. So if 1 year's time, if you find that the eye is very good or the angle is very good, okay? If one of them is very good, then co-opt the cross nerve graft to the other thing. Leave the one part.
Satish, we can do end to side also.
Yes, I am coming to madam that. So first of all, let me complete. First of all, if the eye is good, I will anastomose the cross nerve to the lower division. Okay? If the lower division is good, I will anastomose the cross nerve to the upper division. If both are partial, gone, I will do an end to side to the main trunk. Got my point?
Okay.
That is the philosophy in the second stage. Now, a lot of people have started doing one stage also. What they do, in the first stage only, when you put the cross nerve to the opposite side, put a end to side that sural nerve anastomose to the mesenteric nerve.
Opposite side,
Mesenteric nerve, leave it. So the role of mesenteric is very important. If you don't put a mesenteric and wait for 1 year for the cross nerve graft to grow, many of the motor end plates of the muscles may got denervated.
Very clear. Thank you.
So keep them innervated, keep their tone intact. You have to use something like babysitter, and that is mesenteric. Earlier people would use hypoglossal. Now I tell you why not hypoglossal. Hypoglossal is a huge nerve. There are 5 types of hypoglossal facial anastomosis are being done. Quickly, one by one, before I move on to the mesenteric. I will forget otherwise mentioning this.
But forget it, if it's obsolete, we don't want to know.
People should know what type. In case,
it is not obsolete. It is not obsolete.
Ashish, in case somebody is not able to do hypoglossal, at least mesenteric at least can do something. Okay. So see this. This is your hypoglossal now. Cut. See, the anatomy of neck is very important, man. Can you see the hypoglossal now here?
Yeah.
How it is? It is crossing the carotid. See the carotid?
Yes.
See the carotid bifurcation like you saw in the carotid body tumor?
Yes.
See the carotid bifurcation?
Yeah, very good.
This is the main trunk and this hypoglossal crossing both the carotids. Okay? Number 1 type, go anteriorly, go follow the hypoglossal far anteriorly, and then divide far anteriorly wherever till you can go.
As
anterior as possible. This is the classical one. I am telling you all varieties. So, go anteriorly, far anteriorly, right on the hyoglossus muscle. I am here. Hyoglossus muscle, and then bring in and anastomose end to end with the facial now. See this?
So, Satish, don't do it. We will like to see the second part when you do the partial cutting.
Got, everybody got my point?
Yeah.
See this whole length of the hypoglossal, bring in here and anastomose to the main trunk of the facial now, which is here. Can you see? This is hypoglossal, this is facial. See, both things.
Yes.
This is facial main trunk. Can you see?
Yes.
And this is hypoglossal main trunk. So you bring here and do end to end. Number two, what you can do? Take a sleeve of hypoglossal. See this as a babysitter. Take a sleeve of hypoglossal. This is hypoglossal. That is known as hemi-hypoglossal. Give me a sharp knife. 40% of the thickness of the hypoglossal. Yeah, give me a sharp knife. And the entire sleeve you divide and take and suture to the facial. That is hemi-hypoglossal facial. Okay? Third is Mark May's procedure. What Mark May described. He said that you don't have a proximal end of the facial now. But yes, you have a facial now and till the first genu. Why don't you utilize that? Ashish?
Yes, this much length will be added. Yes.
Ashish, trying to get what I'm saying?
Yes, I'm understanding.
Follow this facial nerve back in the temporal bone. Take the vertical as well as second genu as well as till first genu. Divide at the level of first genu to increase the length to the facial. See, this much of the length will be added.
Yeah.
And then put a end to side on the hypoglossal.
On the hypoglossal. Oh, yeah.
After the this thing, your ANSA is left. Always done beyond the ANSA left, so that you don't traumatize the ANSA.
Satish?
Yes.
Hello, Satish. There is another way of doing. If there is a facial nerve neuroma involving the nerve up to the stylomastoid foramen, then we can use a jump graft between the facial nerve.
Yeah, exactly.
If we don't have the length of
it. See what madam is saying? That is another variety. I was saying here to go up to the first genu. Now, in case your temporal bone facial nerve is involved by some pathology, you can cut from here, join a saphenous vein end to end here, and then end to side to the hypoglossal.
Cable graft.
Got my point? But that is a weak proposition because now there are two site of cooptations. What my point?
Yes, it takes a longer time.
Okay.
For this because
so that is type fourth variety. Now another is when you do end to side, there are two varieties of end to side. In the one variety of end to side, give me the knife. A thickness of the facial nerve is taken. See, after the hypo, this rima is gone. This ANSA is gone. This is ANSA. Can you see here?
Yes.
This is done beyond ANSA. In one variety, Pakar, a part of the thickness of the hypoglossal is taken. See this? Sorry. I injured everything. Part of the thickness of the hypoglossal is taken and then end to side is done. And in the second variety, only the epineural window is made and the facial is anastomosed there. And there are a lot of regeneration studies, publications have shown that even if you make an epineural window, the neurons start sprouting and it works. And it doesn't damage any part of the function of the hypoglossal.
Yes.
Okay? So all these varieties are added on to preserve the tongue function. I hope it is clear.
Yes.
Now coming to the mesenteric. We lost. Coming to the mesenteric.
Yes, you were telling about the tricks.
Yes. See this is the main trunk of the facial. Lower division. This is you see this. This is the frontal branch. Can you see this?
Yes.
And this is the main zygomatic branch.
Yes.
And there are a lot of interconnections. See, lot of interconnections.
Yes.
So many interconnections, boss. There are hundreds of interconnections. Amazing. Now, for the mesentery, what are the landmarks? Landmark number 1, let me show you to uncover so that you'll never forget in life. I am uncovering so that you'll never forget in life. Number 1, this
go slowly.
Diagomatic arch anteriorly. See this?
Yes.
Superiorly is the zygomatic arch. Can you see this zygomatic arch?
Yes.
I have gone to the bone. Can you see this?
Yes.
And behind here is the mandibular ramus, condyle.
TM joint.
TM joint and the condyle. Let me, just for the sake of demonstration, let me take out this. I am not cutting this zygomatic branch. See, this is the condyle. Can you see? This is the condyle. And this is your zygoma. This is zygoma and this is condyle. Like, give me a paper and pen. You have paper and pen?
45 degree, yeah?
This comes from the anterior division of V3. I told you that day when we saw in the endoscopic dissection V3.
Yes. Yeah.
V3 had two divisions. From the second division is the lingual, which joins the chorda tympani. Inferior alveolar, which goes in the canal and gives nerve to anterior valley of digastric. And the third one is this thing, lingual, inferior alveolar, and third one, auriculotemporal. Wait, cool drink mangana. Now, give me the paper and pen. Mila ya? Okay, let me show you some drawing here. Can you see this?
Yeah.
This was the zygomatic arch I showed. And this is the mandibular condyle.
Anterior margin, yes.
See this? Is this clear or not? Let me. Yeah. Now this zygomatic condyle, this is the zygomatic ramus below. See this? This is the ramus.
Mandibular.
And here is the, what is that? Coronoid process.
Coronoid process.
So, and this is the mandibular notch. See that?
Sigmoid.
The mandibular notch between the condyle and the coronoid. Clear?
Yes.
This now comes out of this notch. This is the notch. Comes out of this notch at the angle, at this upper angle. And then goes 45 degree antero-inferiorly.
Right.
Okay? 45 degree antero-inferiorly at a depth of what? More than a centimeter. More than centimeter means? I will show the mesenteric flap after that, muscle flap. This mesenteric muscle has three parts. The superficial, middle and the deep part. This now passes through between the middle and deeper part of masseter. You know? And how to identify that? The aponeurosis will be seen. You have to go deep to aponeurosis to find this now. And this is, the depth is almost a centimeter deep. Okay? Is that clear?
Yeah.
Okay, now let's see. Let's come to the area. Following these landmarks, now I am coming into the same area. See, this is all about anatomy. So this is the angle. Can you see very clear?
So you tell about subzygomatic triangle, Satish?
Yeah, this is the zygoma.
Yes.
And this branch form the subzygomatic triangle.
Zygomatic branch and the anterior margin of
mandible, zygoma and zygomatic branch form the subzygomatic triangle.
Yes. It bisects this triangle.
Now I am going in the depth. See the muscle. Can you?
Yes.
It is not so superficial.
Quite deep. It
Very.
have to divide whole of the muscle to go into that because it enters from the medial side of the muscle, na?
Yes. So I will go in the depth of the muscle.
We can see.
And same thing I am going to show in the live surgical case today.
It is there.
Yes. Can you see?
Yep.
इतना इजीली मिल गया. See the nerve below. ना एक इधर लगा retractor, एक इधर लगा. एक इधर लगा. See the nerve. So nice. See, this is the nerve.
Yes, absolutely clear.
Beautiful. Let me clear it and show you how it goes anteroinferiorly. You get a length of almost 2 centimeters. And you know where the facial is? See, this is your branch and this is your facial trunk. See that?
Yes.
If I cut my facial trunk here, for anastomosis and I bring it here, see this?
You really have to release the lower
See
branch
this?
because it keeps on pulling.
See, my facial trunk is coming here.
Yes, yes.
And I can go up to 2 centimeter down to bring my...
Up to 3. They say 3.2 centimeters the whole
Yeah,
length.
because
So
I don't want to go beyond, branches.
branches. Okay.
See this now? See this now? And I can go and I can release this nerve from here and anastomose to this nerve here. So close. That's why the function starts in few months. Fastest than any other anastomosis.
Yes, they give really good results.
See how
Really
close they are. I will show the anastomosis today. This is facial now, trunk coming here. And this is, see, so far I can go and cut this nerve. So far.
Till its entry into the masseter nerve from
Yes.
the medial side.
Can you see?
And the thickness also
I can
matches.
cut over here. I can cut over, suppose I cut over there and bring it. See this? This now. मेरे कैंची काटती नहीं है यार क्या दे रहा है hey, this is not the scissors यार come on and you can anastomose so easily see that simplest of the anastomosis I tell you the fasciomesenteric is the beauty is nowadays what some people are doing they are doing selective innervation in the sense why hypoglossal has gone to disrepute number one it is the spontaneity is the big issue and if you co-opt with the main trunk of the facial it leads to mass movement synkinesis. Synkinesis is the biggest problem.
Yes.
So what you can do now, some people what do? The upper trunk they anastomose with the masseter.
Yes.
And lower trunk you can take a hemi-hypoglossal.
Yes.
So that will be
avoids mass movement.
dissociated, so there will be no mass movement. Minimize, you can do it.
Yes, yes. Yes.
Now, having known the masseter's nerve anatomy, the next thing what you can learn is the artery to this masseter gets blood supply from many, but the masseteric artery is immediately deep to it and run in the same plane. So, understanding this fact, what we do now, many a times, we use the masseteric flap for the reanimation of the angle. I will show you. That is amazing. I tell you, some patients you are doing a parotidectomy, suppose, and happen to injure the facial nerve at the same time, main trunk. You could not save because of the pathology, malignancy, whatever reason. What best you can give intraoperatively as a dynamic sling. Intraop, same time, in the same field, no morbidity, no extra time. Masseteric flap. See this. This is amazing. External camera low. I will show you the external camera. Are you getting this picture? Good?
Yes.
So what I will do...
This masseter sling can be done when the injury has caused trauma to all the branches of the facial on the face.
Yes,
That also can be taken.
yes, and also after the years of injury, when the muscles have undergone atrophy, the nerve anastomosis is of no value. Either you do a free muscle transplant like gracilis, or you can do this muscle, because this is not supplied by facial now. So now what I want to show is, this is the modulus here. Can you see here?
Yes, yes.
This is the modulus, okay? And this is the masseter muscle. Ashish?
Yes, yes.
Ashish?
Yeah, I can see it.
See the masseter where it is going.
Going, yeah.
This is the lower insertion on the lower edge of the mandible here.
Yeah.
And see, close is the modulus.
Yeah.
And now this vessel as a nerve, it is going anterior-inferiorly like this. So, lot of anatomical studies done. The main trunk of the nerve and vessel from the angle are almost 3 centimeter away.
Okay.
So, if I can make variety of mesenteric flaps now.
Okay.
Looking at the anatomy. Let me show you simplest way. Just mobilization, yeah. Mobilization along with the periosteum.
Of the entire muscle.
So, Satish, hello?
Yes, madam.
Satish, the only disadvantage they say is the trajectory of the action is different because we are, using it in a reverse.
No. Trajectory will be same like zygomatic major. I'll tell you.
Okay.
I'll show you.
Okay, let's.
Trajectory will be same like zygomatic major muscle, direction is going to be same.
Okay.
See this, in the live surgical situation, you have to absolutely go subperiosteal so you don't damage any,
Fibers.
yes, neuromuscular territory, anything. See this? This is one type of flap as a whole. Now see the direction from upward down. Can you see the direction from upward down?
Yes.
I have elevated from the, then now mandible is bare. See this? Upward down, and now I will suture it to the modulus here. Let me show you the modulus first of all. Scissors. Modulus.
So for when they are
can you see the jump bunch of muscles here?
Yes.
Yes.
This is modulus. This is modulus. So what I will do, this is dynamic, very strong. Patient will not appreciate any deformity. See this, I will go and suture this to the modulus.
Yes.
And see,
you know what?
once it works, it pulls upwards and laterally. It will pull upward and laterally. See the lip, how the lip is going to work.
Fabulous.
This is amazing, simplest of all the flaps.
Yeah, very simple.
Simplest, robust, very effective. And if you do intraoperatively post-paroidectomy, boss, many a time patient will not even appreciate the facial has gone. It works like that.
Realize, yeah.
So these are the procedures to the lower lip, masseter, hypoglossal. Now another flap, in case you need to show, like Ralph had demonstrated last time, is Labes technique. See, this technique is undergone. Yes, please, bolo, madam.
Sorry, sir. Satish, out of the two, they say temporalis is always better than the masseter because it has a upward pull. No.
The problem with the temporalis is the procedure of lengthening is very tedious.
Very difficult. Yes.
And now
very
what difficult. You can do, that's what Lebe has, changed the procedure. That is the evolution. Yes. Earlier it was described by someone else with a different technique. That is what we are. I will show both orthodromic and antidromic temporalis transposition. What Ralph had described that time, if Ralph remembers, is the orthodromic transfer. Remember, Ralph?
Please explain to us the difference. We don't even know what it means.
Yeah. So what he demonstrated was the orthodromic temporalis transposition. And what Lebe described, when you mobilize the temporalis, you can give an extra length by peeling the temporalis from the attachment and mobilize it. Remove the posterior attachment of the temporalis to give it to extra length.
Yes.
Posterior half of the
otherwise, if you don't give, what you can do, if you don't do that, when you divide the attachment of the temporalis lower down from the temporalis, this coronoid process, you can attach a facial lata graft and then attach the facial lata the other end to the modulus.
For creating the length. Yes.
So,
either release it from superiorly or add on the sling.
Yeah, add on a facial lata sling. Both can work, but the originality is originality without making any, the static tissue in between. So
it gets fibrosed, I think, that facial lata that you put.
No, it works. It is stiff, but it lessens the dynamicity of your flap,
Because the natural functioning of the temporalis muscle will not be added onto the sling. Sling will just add on to the length of the.
Yeah, Now I will show this.
Ralph wants to say something, Satish.
Yeah, please, Ralph, we need your comment.
Satish, I have to leave the session. It was a pleasure again to watch your preparations and to hear your explanations. You are really the best for me. So I have to say goodbye.
Wow.
Thank you.
And good luck for the rest of the session. Bye-bye.
Bye. Achha, Ralph, last comment from you. Last comment from you. How often you are doing lengthening myoplasty, temporalis?
It is one of my favorite dynamic facial reanimation techniques in long-term facial paralysis in older patients. So sometimes a year, yes, maybe 5, 6 times a year, 10, yeah.
Okay, and then do you use a facial atta in between?
Sorry?
You use facial atta?
If you fall short, do you use a facial atta from the distal end of
to give it a length?
I use the distal end of the tendon, yes, and bring it to the.
So he doesn't use the facial atta. He will mobilize it all the way down to the modulus.
Okay, great.
Modulus, he separates the coronoid, I think, and that gives the length.
Yeah, right.
So,
thank you,
Raj. Thank you. Now I will show, the classical Lebe's technique. Daniel Lebe, what modification he has given us? ये दो यार तुम्हारा ये अच्छा नहीं आता यार. Okay, can you see the temporalis as a whole above?
Yes, nicely.
So what I will show, knife, periosteum रखना. This is the upper attachment of the temporalis. You can see. इधर से आओ, मेरे पीछे से आओ. See this. See the upper attachment of the temporalis?
Yeah.
Here. That is superior temporal line. So what I will do, I will completely mobilize this temporalis like this, particularly from superiorly and behind. See this? So I can push it down. See what all we need is this temporalis goes here down and insert on the coronoid process. Okay? And from here, coronoid we want to take to the modulus. So this 2 to 3 centimeter is the key mobilization we need. Okay?
Yeah.
So in that manner, this innervated vascularized temporalis which is inserted on the coronoid will be inserted on the modulus to make a dynamic sling to the to the angle of the mouth. Got my point?
Yes.
So in order to get that mobilization, that is so difficult. There are many ways, and what Lebe has given us, see this, mobilize the muscle as a whole, leaving some part attached. We need to have an anchoring of this muscle as well for this to work.
So there are studies about how the vascular supply is not to the bulk of the muscle.
Yes. Yeah.
Mainly
See now.
area.
Now at this point, this muscle goes deep to the, zygomatic arch.
To the zygoma.
Yeah. This is my zygomatic arch.
So you have to separate it from.
See, this is zygomatic arch.
Yeah.
And we have to break it to reach to the coronoid. See this. See, this muscle is going deep to it. See this.
Yeah.
Yes.
No. So I will break this zygomatic to mobilize this muscle below. Okay? Okay, I have broken with the nibbler. See now, this posterior part of the muscle will be fully mobilized down without damaging. The beauty of the temporalis is all the entire neurovascular pedicle comes from the deeper surface. So you don't mobilize anything. See this? Don't damage anything. And it stays subperiosteal. Can you see here?
Yeah.
Now only the anterior part is attached here. See that? Rest you have to mobilize completely. See this? Complete matlab complete. See this?
Where is the coronoid?
Now this is my condyle and this is here is the coronoid. I can feel here. See this? Can you see the mobility?
Yeah.
Here is my coronoid. I can feel it. Now this muscle is so free. See this?
Yeah.
And other way around if I pull, other way around I pull, see this how much muscle is gone mobilized. See this from this point, how much muscle is mobilized now. Okay?
Yeah.
So my next point is, I will break the coronoid and advance this and suture to the modulus. That's it. That's it.
I believe that is the main trick, fracturing the coronoid and pulling it down.
Yeah. For audience, you can do both ways. This coronoidectomy can be done transoral very easily. I can feel with my finger. See inside the mouth, I can feel the coronoid.
Yeah.
And many of the OSMF patients, the coronoidectomy we have been doing as an additional measure to relieve the trismus. The coronoidectomy is simple. You see, go in the buccal mucosa and feel the coronoid, make an incision right over there and fracture it. That's it.
Okay.
Simple. It's a very simple process. So here also you can do transoral as well as from outside. So now what you have to do is, having done this, the entire muscle is mobilized. See this? Entire muscle is mobilized completely, only attached anteriorly. See this? And now from this attachment will break the coronoid. Then remove the bone and this muscle will be taken right from here to here. See this?
Super.
See, right from here it will come to the modulus. This is the modulus. Upar se dikhao.
Yeah, can be seen. Very convincing.
See, from here to here modulus. So it is lengthening. The name of the procedure is temporalis lengthening myoplasty.
Yeah.
Okay? Yeah. Now, once we raise the temporalis, I will show you something. Microscopic picture. Once you go to the medial surface of the temporalis, you will see the deep temporal nerves.
Yes, and that flap.
See the deep temporal nerves. And these are the nerves you can take an anastomose with the orbitozygomatic branches to give dynamic innervation to the eye. Eye is the most difficult to treat. What's my point? So these
run along with the artery, Satish?
No, just not neuronal coaptation. Simple.
Achha.
And nowadays, Ashish, the neuronal coaptation, a lot of papers are coming, vascularized neuronal grafts.
Okay.
Nerve graft along with the vessels. Time is changing. Everything is a free flap now. More and more free flap. So, on the deeper surface, you will find the temporal branches. Can you see? Deep temporal nerves. Deep temporal nerves here on the medial side. See this deep temporal nerve?
Yep.
So how to bring it out?
No, just coaptation from here. See the frontal branch was going right over there. So if the facial is gone, you can coapt with the frontal branch that supplies to the orbicularis, frontalis, so as to give dynamic innervation to the eye. Like we take the help of ansa hypoglossi for the marginal mandibular, you can take the temporal branches for the eye branches. Okay?
Okay.
Now, this is about the dynamic innervation with the local muscles. Now coming to the eye, and then finally neuromuscular transplant, when the time has elapsed, the muscle have gone atrophic, and you have to bring the nerve as well as muscle both and transplant. Like gracilis, I will we will run that Tessa's video to show them that is a complete message about gracilis. Out of all muscles, the gracilis is the best one. What is therein done? The gracilis has a segmental neurovascular innervation. A particular segment from here, see. Yes.
How is the cost message after mesenteric and this muscle flap? After
It is better. It is always better.
Don't feel bulkiness over there? Like
No. See now, what is done in the gracilis is a 15 by say 8 centimeter, whatever size, a segmental gracilis along with the obturator nerve anterior branch and a circumflex artery, femoral artery and vein, they are taken. One end of the gracilis is sutured to the circumferentially around the commissure. Lower lip, upper lip at the commissure, one end. See like this? And then this muscle extends from here and the other end is sutured to the temporalis fascia, zygoma and temporalis fascia. And that obturator nerve is anastomosed with the mesenteric nerve. And the cross nerve graft is anastomosed end to side to the obturator nerve. That is a complete dynamic innervation where the spontaneity you can get. This is the highest procedure one can think of. And a properly done procedure has an amazing result. So again the gracilis muscle along with the vessel and the artery and vein and the anterior branch of obturator taken. The both ends are inserted from the angle to the zygoma, and the nerve is, facial artery and vein can be used for the vessels, and then for the nerve, the anterior branch of the obturator is anastomosed with the mesenteric nerve, and the cross nerve graft you can anastomose end to side with the obturator nerve. I hope it is clear.
Yes.
Then you will see.
Pachauri is asking, after cutting hypoglossal completely, and what will happen with tongue supply and subsequent deficit in tongue muscles? Because we are taking hypoglossal as a.
After cutting hypoglossal completely.
Yeah, means what will happen to the tongue supply and subsequent?
Yeah, that's why we don't do hypoglossal. The tongue atrophy will take place, and we add on to the. See, this facial nerve injury. Palsy has an implication on so many things.
Yes.
The eye is exposed, can lead to blindness because of exposure keratitis. The mouth, the eating, deglutition is a big problem because of the drooling and the incompetence, oral incompetence. Speech is a problem because your cheek muscles are gone. Now, adding on to this, if the hypoglossal is gone more, that will add on to the compound difficulty. So hypoglossal is no more a choice. So the facial now has a huge impact. Now the next is the reanimation of the eye and the brow. The classical procedure described on the eye, I hope the picture is good.
Yeah, it's very good.
Okay. Now the classical procedure described on the eye. What do we need in the eye first of all and why? See, because of the orbicularis oris gone, the sphincter function of the eye and the blink is gone.
Yes.
That is spontaneous. And because of the unopposed action of the levator pelvis. The upper eyelid is elevated and not closing the eye completely, and that may expose the cornea as well. So first of all, the sphincter action is gone, blink is gone, spontaneity gone, and then the eye is at risk because of the exposure. So many procedures are directed to rehabilitate the eye. Upper lid, lower lid, sphincter function, and at the same time the lacrimal function also goes, because the eyelids got everted and that pumping action required for the tears to go down is gone, because the eye is not blinking effectively. That blink is required to pump the tear down the nasolacrimal system. Everything is affected. Now the biggest thing is this eye is turned up, eyeball is turned, eyelid is turned up because of the unopposed action of the levator palpebris superioris and the cornea is exposed.
Yes, yes.
Now it can be rehabilitated by various ways. Dynamic, static and others. For dynamic, I will come later. Static, what all you can do, you can put some weight in the upper eyelid to keep the eyelid down to prevent corneal exposure. Okay? After the conservative measurement fails, this is to be done, like suppose today the facial nerve injury happened. You have to wait, you see if the Bell's phenomena is good, the eyelid is not exposed, you can wait. Conservative treatment, all those, you can use, and if required, then what you have to do is, so the procedure described one by one. Number one, pakadne isko. See this, if I open this eyelid, see what is the anatomy here. See this muscle which I am cutting. See this thin muscle, that is orbicularis oris. See, I have cut this muscle. Can you see?
Yes,
This muscle, and this is the tarsal plate. Chodna. This is the tarsal plate. Okay?
Yes.
This is tarsal plate. So after cutting the orbicularis, you can use some weight according to the requirement. What you do? Before doing it, keeping the patient in sitting position and tape your upper eyelid and put a weight below. So how much weight is required to close the eyelid is the chosen weight, and of that particular weight, according to the dimensions of the eyelid, you have to get it from the goldsmith. Get the, the gold plate done. The gold is traditionally being used, though nowadays platinum is the choice because it is more dense. Gold plates sometimes are so thick and seen obvious under the skin. Particularly if this skin is very thin, the gold plate, thick gold plate seems obvious through it. It doesn't look nice. Platinum is more dense, even the thin plate can work. So the first is the weight. Okay?
Yeah.
Parameter sleeping.
Oh, sir.
So what you can do, you can use your weight and suture through the holes to the tarsal plate. Then suture make this, orbicularis oris muscle and the skin line. Yes. Now, in cases where there is not too much of weight is required, when too much of weight is not required, what we do, instead of a gold eye plate, we use a simple conchal cartilage. Take a piece of cartilage and suture to the tarsal plate all the way, and it can serve the same purpose. Now, but the cartilage is not very heavy. So what you can do, you can put another piece of cartilage, another piece of cartilage in the pocket above the levator to further, here in this pocket above the levator, this is the levator muscle in this pocket, okay, over the fat, to additionally give more weight with the cartilage. Cartilage is own tissue, it doesn't give problem. Now the third thing what you can do is, see, the orbicularis is gone and unopposed action of the levator is going on. So do something for the levator. Dissociate the levator. So what you can do, see, this is the upper end of the tarsal plate. Go to the upper end of the tarsal plate here. See this?
Yes.
This white is the levator aponeurosis. Can you see this?
Yes.
Can you see this? White is the levator aponeurosis. Take a piece of cartilage. And between the tarsal and the aponeurosis, put a piece of cartilage to dissociate the unopposed action of levator. So eyelid will not go up, it will fall down. Got my point?
Can you repeat it again? Because
to dissociate the action of levator, because it is the unopposed action of the levator palpebralis superioris, which is supplied by the third nerve, not by the seventh nerve. That is bringing the eyelid up. And that is unopposed because the orbicularis is gone. So this levator, it is attached to the tarsal plate through an aponeurosis. What you need to do is separate the aponeurosis and interpose the cartilage in between.
So Satish, hello?
Yes, madam.
Satish, by releasing this and putting the cartilage beneath, don't you disturb the actual action of the levator,
No.
that is, lifting,
Is
it
still,
cause ptosis permanent?
no. Still we will suture the aponeurosis to the cartilage.
Okay.
And that cartilage is suture both to the aponeurosis and the tarsal plate.
Okay.
But
in
now
between
that
we have-
strong action of the levator will be gone, and the cartilage is interposed in between.
Okay. Light action will remain,
Yes.
strong action will go. Okay.
Now, all these weights, they are working by gravity. So now, this is simple gravity. They are not doing anything. They are not treating the cause. They are not treating the problem. By means of putting weight, we are avoiding corneal exposure, preventing corneal exposure.
Yes, yes.
So they work by gravity. When the patient lies down, the gravity effect is gone. The eye is again exposed. So it works only when the patient remains upright. This is simple gravity, nothing else. So, in order to give a more dynamic, suspension, the next answer is a spring. There are palpable springs available. We tried to make our own spring. It is simple spring. That gives a dynamic opening of the eyelid and closure. What do you mean by that? You got any spring, riffle spring, anything you understand spring?
Yes.
That is a metallic spring, which if you press, it will press and release and it will open up. Got my point?
Yes.
So that dynamic spring, it's sutured at two places. One, go up to the bony margin of the orbit above. See this orbital margin above?
Yes, sir.
And one to the margin of the eyelid, inferior margin of the tarsal plate here to the eyelid. Leave it. Chodo. Now see this spring, once pushed over there under the orbital margin and once here. The spring opens and closes the eye. This is amazing. This is not related to the gravity. But the problem is you have to keep on adjusting the spring again and again sometime. And the available springs, some of the companies are marketing springs and they are very costly. Okay. So now the next, this is to the upper eyelid. What you can do to the lower eyelid? What happens once the orbicular is gone? The lower eyelid goes like this. So now,
Yes, sir.
the ectropion happens to occur to the lower eyelid. So there are many ways. What you can do simply, we have kept a case today as well. The best is the lower tarsal plate excision. Pakadna idhar. See, this is the lower tarsal plate.
Yes, sir.
I will do a canthotomy here first. See this. Scissors. See, this is the tarsal plate cartilage. Can you see?
Yeah.
Canthotomy, you have to, this is the cornea, to separate the cartilage here. Can you see this cartilage here?
Yes, sir.
Separate the skin as well from the cartilage. See this? And now this cartilage, Shona, is sutured here onto the orbital margin. See the tightening of the lid.
Okay.
Got my point?
Yes.
Tightening of the lid which was like this ectropion, with this margin, half a centimeter of the, the tarsal plate is taken and sutured laterally to the orbital margin to make it tighten. Okay? Is that clear?
Yes, absolutely clear.
Very
We have to see that it should not be very tight. Huh?
Yes. Very simple procedure. Another thing for this lex lid, you have to support the lower tarsal plate. What you can do here is make a subciliary incision and insert a cartilage between this and the orbital rim to support this. Now here I can insert a cartilage between this and the orbital rim. See, this is the orbital rim below.
Suture it between the orbital rim and the
Orbital rim and the tarsal plate and close it again. So this will be supported like this. A quadrangular cartilage today is supported like this. So to prevent the eversion of the lid. Okay? Another thing is dynamic. Nowadays, because of the free flap availability and one of the brands from the opposite side, cross facial nerve graft again and put a dynamic, free flap of platysma, and so many things are available for the dynamic reconstruction of the eye. So this is how, because the time is going, so I am leaving this part here. There are so many procedures still, more you can do to rehabilitate the facial nerve and its effect on the face.
It just shows the quad actually.
Pardon?
Quad tympani, no.
Quad tympani.
Adjective.
Okay. अभी रुक वो लेना है parotid. Okay. See the axonotary canal there?
Yeah.
Now, this chorda tympani, how it goes, first of all. In the middle ear, it enters from behind, as we do the posterior tympanotomy, we all know. It enters into the middle ear, lateral to the incus, medial to the malleus, and then go in the anterior part of the atic, anteriorly, to leave through the petrotympanic fissure.
Yes, sir.
Okay? Yes. There is a fissure in the anterior part of the atic medially, which is known as where the, the anterior malleolar ligament comes out. Yes. That is petrotympanic fissure. In the medial part of the petrotympanic fissure is a canal through which this goes out of the ear. That is canal of Hughes ear.
Yes.
Okay? After getting out of the canal of Hughes ear, it comes out here anteriorly, deep to the temporomandibular joint.
Yes, sir.
Okay? So in order to show you the further course of this, let me. I have to break the temporomandibular joint, and you see here, this nerve which was going in the ear anteriorly, as it comes out of the canal of Hughes ear, it comes absolutely vertically down. Absolutely vertically down in the medial wall of the TM joint. Got my point?
Yes, sir.
So, I have to remove this TM joint for that, fast. And there, it runs lateral to the spine of sphenoid.
Yeah.
When you see the greater opening of the sphenoid, where its nerves go down, there is an anatomy, that is a part of the sphenoid known as a spine of sphenoid.
Right,
this nerve goes lateral to the spine of sphenoid in the infratemporal fossa and join the lingual nerve. Why it is important? The spine of the sphenoid is a very important anatomy, because medial to the spine of sphenoid is what? Medial to the spine of sphenoid is what? Auriculotemporal nerve.
Yeah.
In head injuries, accident, it happens very commonly when the spine of sphenoid is injured.
Yes.
What happens? Complete ipsilateral salivary paralysis. Why? The chorda supplies submandibular and sublingual gland. Auriculotemporal goes to the parotid gland.
Yes.
Got my point? And in a spine of sphenoid fracture where the chorda goes, I will show. This is complete, something leads to the complete ipsilateral salivary paralysis.
Where the sphenomandibular ligament is that same thing?
Stylomandibular ligament. That is different.
Sphenomandibular ligament, something.
No, that is different. That is from the angle of mandible.
Yes.
That is from that ligament arises from the spine of sphenoid, right?
Yeah.
Goes to the angle of mandible.
Yeah.
Now see, this is the mandible.
Yes.
As I divide this will uncover the infratemporal fossa. You saw earlier the infratemporal fossa from the nose side.
Yeah,
okay? And now here in no time I will show you infratemporal fossa from the lateral side. The same concept, the anatomy for different sides differently.
So there's a question from UAE. Dr. Isam is asking that is there any specified direction for the tunnel for digastric sling? Like
Specify?
direction for the tunnel of digastric sling?
Direction is superolateral.
Okay.
Because it comes from the midline, the muscle is attached towards the midline anterior belly and it goes through a lateral tunnel in the angle of mouth. See this. See this. Again, we are here only. See, this muscle is attached here in the midline. Can you see? And tunnel is made laterally here. And it goes laterally and up to the angle. Can you see?
Yes.
So the direction is superolateral.
Yes, sir.
And it is, this muscle is sutured not only to the angle of mouth. This is sutured to this orbicularis here to bring it down. At the same time sutured to the modulus also to bring it laterally and down, which is paralyzed.
Okay, sir.
So now, bhai, cut isko, mandible ko katna. Then we'll cut the mandible to show you. Just immediately medial to the mandible is infratemporal fossa. When you see from endoscopy, the lateral limit of the infratemporal fossa, lateral wall of the infratemporal fossa is what? Mandible and temporalis muscle. Because temporalis there medial attached onto the, drill se cut. Temporalis is attached to the coronoid. Coronoid is right here. See, this is temporalis attached to the coronoid. So the moment I cut it, I will show you the chorda tympani. We'll be in the infratemporal fossa. Underneath the neck of mandible is where the external carotid divides into two branches and the maxillary artery goes anteriorly with all its branches, all the V3 and its branches. So this is different anatomy, though it has nothing to do with the facial now. But since you have asked, let me finish in 5 minutes quickly. Because now we have to...
Significance of such chorda tympani nerve cut in during surgery, like stapes or anything, how it recover and
Satish?
Yes, madam.
What he wants to know is he feels that can we do re-anastomosis if the chorda is cut? Is there any procedure which can revitalize the nerve?
Actually,
which is not possible.
yeah, it is not possible, number one. Secondly, a lot of studies have proven when the chorda of the same side is injured. See, why it is so? When you do a procedure like cholecystoma, canal wall down, the chorda is gone, rarely a patient will complain.
no, because already the chorda is damaged.
Because the neuritis happens in the chorda, but why the taste is not affected? Because it is taken over by the opposite side.
Yeah, posterior
Simple. Yes.
So,
because of the adjoining area of the test, areas are for the test, it is supplied from the opposite side, behind by the branches of glossopharyngeal, and ultimately takes care. Secondly, there are a lot of neural connections between the chorda here and the branches of the fifth nerve in the infratemporal fossa.
Yes.
And that also gives innervation, and ultimately in long run it doesn't give a problem.
But usually for 3 to 5 months, patient develops some symptoms. For that, what we can do?
Pardon? Knife.
Immediate post-op surgery.
you make him ignore it. You make him ignore it, no other way out.
But generally, these taste complaints are not long lasting, you know.
Yeah.
See, this is, see, I am removing the condyle. And what is there inserted on the neck of the condyle? See the thick muscle. See this? This is lateral pterygoid.
Yes.
Attached on the neck of the condyle. This is the thickest muscle in the lateral part of the infratemporal fossa.
Yes.
Superior part.
This masseter nerve runs over the lateral surface of this lateral pterygoid.
Yeah. Now see, we have removed this. Now see the lot of anatomy coming into the picture. This is the maxillary nerve and its branches now. See this vessel going horizontally in the infratemporal fossa. And now we wanted to see the chorda tympani. Okay. Yeah, hata isko dekha.
Then
Yeah.
Satish, you will
Yeah.
have to
See the
pass on
chorda.
because people may be waiting
See the
for
chorda.
answers.
First of all, see the chorda. I told you, this is the middle ear. From here, it comes out here.
Yeah.
Can you see here? And now see the chorda going absolutely vertically down.
Yeah, we can see very thick.
Very beautiful, very beautiful.
See the chorda. This is the chorda. This nerve is the chorda.
Yeah, yeah.
See this now?
They're going down.
Can you see this now?
Yeah, we can
Yes,
see.
yes, yes.
And what is there? It is crossing laterally what? This is spine of sphenoid. Can you see this spine?
Okay,
Yeah, yeah.
okay.
Let me cut this muscle. Boss, what you were saying, this is a stylomandibular ligament. See this?
Yes, yes.
Coming to the mandible from here. Oh, sphenomandibular ligament.
Phenomenal.
And see, I am uncovering the spine of sphenoid. This is your, what is this? Styloid process.
Third process.
Going down. Let me show. And 1 centimeter below from here, it joins the lingual nerve.
Okay.
That is the nerve going. See the chorda going?
Yeah.
That is chorda.
Yeah, going down.
See, this is chorda. Can you see very clearly the chorda?
Very
Yeah, very
clearly,
clear,
very
very
clear.
See, it is coming down. This is the anterior superior part where the atic. From here it comes out of the, here, and I remove the mandible, the condyle, and it runs in the medial wall of the condyle, and now it is going down to the infratemporal fossa, and very closely here in the 2 centimeter vicinity it joins the lingual nerve. That is how the anatomy is. Now, where are those nerves coming from? See, once we have removed this, this is the infratemporal fossa surface. From the roof side, the mandibular nerve and its branches come down. That is the capsule of the TM joint. See this?
Yes.
That is the capsule of the TM joint. That is the coronoid process here. Anything else you want to see here?
No, I think that's more than enough.
So perfectly fine, Satish, perfectly fine.
So any question, or do we go ahead with anybody, any more procedure to be shown on cadaver? Because I have left so many procedures because of the time.
But we have to see surgeries also.
Yes, so we have to go to the live surgery. Ashish, anything?
Dr. Nishita is asking how
Who?
old facial palsy can be taken.
Nishigupta.
Dr.
Dr. Nishigupta.
Nishita,
Yeah. How is?
how old facial palsy can be taken up for repair, and when do we manage only with rehabilitation surgery?
See, after 2 years of palsy, we generally avoid neural transfer because a lot of neuromuscular junction, motor plate junction, motor end plates have denervated. So the nerve transfer will not have that much of impact. So after 2 years time, when the muscles have gone atrophied, you have to bring in muscle along with the nerve. Because now the muscles have atrophied, what will the nerve do?
So, but Satish, sorry. Satish?
Yeah,
Hello?
yeah.
Satish, 2 years old palsy, but EMG positive can be taken up. But 2 years palsy or more than that with EMG negative are to be taken for
See,
rehabilitative life.
what will EMG show? Once there is palsy for 2 years, there will be nothing on EMG.
No, muscle trophy, they will show that much because you know
Yeah,
what, I
so
got a
you,
EMG done.
the best is to get MRI done to see the muscle volume loss and compare on the both sides. If still the muscle volume is good.
Listen, I got a EMG done of 5 years old palsy and it showed the muscle activity because then I read in the literature, they say that they start getting innervation from the surrounding trigeminal nerve or rest of the nerves around.
But
and
after 5 years, why the patient come? Because it is a complete palsy.
Of course.
So if still there is a palsy, then you have to rehabilitate it. The whatever you are saying, the nerve is coming from the opposite side would have repaired the palsy.
So we can combine it with the static dynamic and mess it up.
Yeah, if the patient is a good candidate for the free flap, that's a very good question. If the patient is young, good candidate for free flap, free gaseous with double innervation with mesenteric and cross graft.
Yes.
That is the answer.
Yes.
If the patient is elderly, then you have two options. For dynamic, you can do lengthening myoplasty or this, what do you call this, mesenteric transfer, muscle transfer. rotation, mesenteric muscle flap or lengthening myoplasty, because you have to bring in muscle. Or you can do static. I will show some static slings today in an elderly patient. So depending upon the age.
Answer to that question is that it can be a long-standing palsy and something can be done.
Yes, 100%. You can give a reasonably good smile, man.
Improvement. Yes.
If the candidate is good for a free muscle transplant, neuromuscular transplant, gracilis, he can acquire a good smile.
Yeah.
Because the spontaneity.
Lot of patients to whom a lot of things can be done.
Yes, because you are giving a spontaneity by cross-facial nerve graft.
And also it gives fullness in the area where the muscles have got atrophy.
Yes, and see, it is not always free of problems. This muscle bulk and the nerve which can, handle that muscle, the ratio is not always appropriate. Yeah,
she will talk, I think, Tisa's thing, she talks about debulking, making the gracilis thin.
Yes, keep on thinning from superficial surface. If it is not, the excursion is not good, you have to make it thinner and thinner. The thicker muscle.
Hello. Satish?
Yeah.
Then both the temporalis elongation and gracilis, both are equivalent. We have to choose one of the two. Huh?
Gracilis?
Temporalis is also.
No way. Gracilis, the innervation of the gracilis will be through two nerves.
Opposite.
And yes, it is high powered, and it is dual innervation is amazing. It will give spontaneous smile. Temporalis cannot give.
Top of the pyramid procedure. Top of the pyramid.
Yes. Temporalis is never a procedure of choice. I told you, if an elderly patient who is not a good candidate for free flap, because free flap needs a lot of neurovascular anastomosis.
Yes.
It can be, this temporalis flap can be done. Lengthening myoplasty. So depending.
Satish, are you moving to the operation theatre?
Yes. No, here, first of all, I am running this amazing video from Tessa that is showing each and everything about basics to everything about the temporalis, gracilis free flap. Right from anatomy, anastomosis, every theoretical, practical, everything. In the meantime, I will be reaching the theatre in half an hour's time and will be ready. Our case is already induced. So
just to tell you, 6,000 viewers are watching you.
Oh.
No, and
how many are complaining? How many are giving galis to you?
All are giving compliments to sir that you are a movable library. There's a message from Baghdad. Someone sent.
Renita, how many people from Germany are watching? I just want to know later on the side.
Ralph.
Ralph and another associate, they had promised us a lot of people are going to
watching, but they haven't asked any questions, so I'm just getting the questions.
Yeah, you can take question, Paromita, I am here only.
Okay, Satish, we have, before Tisa's thing gets over, you should be... Who's going to put on the...
Okay, run the video. Let me show you, Ashish, how the video you can see. Run the video.
Hey everybody, greetings to India from Boston and Harvard Medical School, Mount Sinai Infirmary. My name is Tessa Hadlock and I run the Facial Nerve Center here at Mount Sinai, and I really greatly appreciate the invitation to share some insights about free gracilis muscle harvest and inset for facial reanimation. So before I get into some slides and some video clips that sort of show our techniques, I really want to say a huge thank you to Ashish Bhumkar, who has included me in this, and Satish Jain. I feel like this is a tremendous effort that you have put forth for this course to help people understand facial nerve anatomy. I understand there's going to be a very thorough, or maybe there already has been a very thorough dissection from skull base all the way out to the distal branches, and that you have talked about multiple methods of facial nerve coaptation, reinnervation strategies, etc. All my favorite subjects. And so if there's anything that sparks interest or people want to dialogue further about, I have a wide open door, as Ashish knows, since he has been to visit me here in the Facial Nerve Center. So without further ado, let me just give you a brief 20 to 30 minute overview of free gracilis transfer, which, as I understand, is not something that is widely performed in your neck of the woods. So I'm going to first start by talking about the muscle harvest. But before I get to that, the basic concept is illustrated in this piece of art by Bob Gala, where you can see we take a thin strip of muscle and we secure it both to the medialis medially and to the true temporalis fascia out here laterally. Now, the truth is that today our inset doesn't quite look like this piece of art. In fact, we inset more from the philtrum across the upper lip to the medialis, but we really no longer include this segment to the lower lip, and that's because we discovered that it was displacing the lower lip too far superiorly. So this is sort of a little bit of an outdated schematic. So just some basics about the harvest before I show you a video. This is just a cadaveric dissection, and you can see that in order to identify the gracilis muscle, we first have to identify the pubic tubercle, or really the thick tendon of the adductor longus muscle, and we identify the medial tibial tuberosity down at the knee. If you make a dotted line from one landmark to the other, and then about 1.5 centimeters inferior to that, you're going to make an incision. Again, we no longer open up the gracilis incision this long, but for the purposes of education, sometimes it's nice to open that up. Again, first I'm going to show you a cadaveric dissection and then live surgery. But the schematic that you see down here also gives you a representation that we are really only interested in a segment of the gracilis. So here, this shows that we use about 60% of the cross-sectional surface of the gracilis, but in contemporary times, we actually only use 50 or 40% of the width of that muscle, and sometimes even. Hey everybody, greetings to India from Boston and Harvard Medical School, Mount Sinai Infirmary. My name is Tessa Hadlock and I run the Facial Nerve Center here at Mount Sinai, and I really greatly appreciate the invitation to share some insights about free gracilis muscle harvest and inset for facial reanimation. So before I get into some slides and some video clips that sort of show our techniques, I really want to say a huge thank you to Ashish Bhumkar, who has included me in this, and Satish Jain. I feel like this is a tremendous effort that you have put forth for this course to help people understand facial nerve anatomy. I understand there's going to be a very thorough, or maybe there already has been a very thorough dissection from skull base all the way out to the distal branches, and that you have talked about multiple methods of facial nerve coaptation, reinnervation strategies, etc. All my favorite subjects. And so if there's anything that sparks interest or people want to dialogue further about, I have a wide open door, as Ashish knows, since he has been to visit me here in the Facial Nerve Center. So without further ado, let me just give you a brief 20 to 30 minute overview of free gracilis transfer, which, as I understand, is not something that is widely performed in your neck of the woods. So I'm going to first start by talking about the muscle harvest. But before I get to that, the basic concept is illustrated in this piece of art by Bob Gala, where you can see we take a thin strip of muscle and we secure it both to the medialis medially and to the true temporalis fascia out here laterally. Now, the truth is that today our inset doesn't quite look like this piece of art. In fact, we inset more from the philtrum across the upper lip to the medialis, but we really no longer include this segment to the lower lip, and that's because we discovered that it was displacing the lower lip too far superiorly. So this is sort of a little bit of an outdated schematic. So just some basics about the harvest before I show you a video. This is just a cadaveric dissection, and you can see that in order to identify the gracilis muscle, we first have to identify the pubic tubercle, or really the thick tendon of the adductor longus muscle, and we identify the medial tibial tuberosity down at the knee. If you make a dotted line from one landmark to the other, and then about 1.5 centimeters inferior to that, you're going to make an incision. Again, we no longer open up the gracilis incision this long, but for the purposes of education, sometimes it's nice to open that up. Again, first I'm going to show you a cadaveric dissection and then live surgery. But the schematic that you see down here also gives you a representation that we are really only interested in a segment of the gracilis. So here, this shows that we use about 60% of the cross-sectional surface of the gracilis, but in contemporary times, we actually only use 50 or 40% of the width of that muscle, and sometimes even less. There is a lot of discussion these days around multiple paddles of muscle for different segments of the smile musculature, and I'm not going to get so much into that today, just to mention that it does exist and that people are sort of working on different inset strategies with multiple paddles, but really the literature has not yet helped us decide whether those things improve results or not. So let's take a look at some of the fine points of the dissection. Again, the cadaveric view, this here is the gracilis muscle. It's now being reflected, and on its deep surface, you can appreciate the artery and the two venae, one superior and one inferior to that arterial pedicle. And right over here, coming in obliquely, is the obturator nerve that is going to innervate this gracilis muscle. So if we pick away at the fatty tissues around, you can start to see a much cleaner neurovascular pedicle that comes in at a hilum, and that has to carefully be incorporated into your harvest, obviously. So a couple of pointers that I've sort of learned over the years. In order to maximize your pedicle length, you've got to take the perforators off the deep surface of the adductor longus. So if you look carefully up in this top photograph, what you can see is that the longus is being pulled away, and the vascular pedicle kind of comes up and goes back down and runs for quite a bit further towards the profunda femoris vessels. But it's critically important to take down these little perforators in order to maximize your length on the vasculature. The vascular pedicle, like in a lot of free flaps, always looks longer, and then when it's harvested, kind of shrivels up. So you really want to be sure that you're taking as long of a length as the body will give you. The other point to be made is that you want to choose the right segment of the gracilis so that the neurovascular pedicle hits the muscle in the appropriate location according to your inset. So for example, if you're going to drive the gracilis muscle by the masseteric branch of 5, you want that neurovascular pedicle to lie at the junction of the superior 1/3 and the inferior 2/3 of the muscle. Whereas if you're going to drive it by a cross-face nerve graft, you want the neurovascular pedicle right at the very edge of one of your cut edges of that muscle, so that you can maximally reach into the upper lip for the cross-face nerve graft. So these are sort of important details that you need to start thinking about the more that you perform this operation. The other thing that we've learned over the years is that it's critically important to thin the gracilis muscle. So not only do you take just a short segment, 10, 12, 14 centimeters, and not only do you take only 40%, 50% of the width of the muscle, but the thickness of the muscle must be shaved down. So the neurovascular input comes from the deep surface, so the superficial surface is what we shave. And you can do that in a number of ways. You can see here that we basically are pulling away the superficial 20 or 30% of the muscle. And here we sort of have continued that dissection. And remember, your neurovascular structures are intact because they are entering that muscle on the deep surface. So let's go through very briefly kind of a live gracilis harvest. This is my partner, Dr. Jowett, Dr. Nate Jowett, who's performing surgery. And you can see that he's done some really nice modifications where he now makes a curvilinear incision instead of that straight line. And we all know the principle that nature abhors straight lines. And I think that his craftiness and ability to kind of change that shape has made this a little bit more of a pleasing donor site. However, I usually tell people that if somebody's looking in this location high in the medial thigh, they probably aren't concentrating too much on scars there. Okay, so we raise the skin flaps, and lo and behold, the gracilis muscle is the first muscle that we encounter. So it's very superficial under that fat. And as you can see here, he is bluntly dissecting and elevating the skin and soft tissue off of the superficial surface of the gracilis muscle. Now, so this is north at the thigh, and the feet and the knee and the feet are down here. So he incises the fascia between the adductor longus muscle, which is sort of lateral to the gracilis, and the gracilis, and he's entering that fascia so that we can begin to identify the nerve and the vessels. And even when we think that we have found the vascular pedicle, we wait until we find a nerve that we can stimulate that causes the muscle to jump so that we are absolutely certain that we have our anatomical structures identified properly. It can get confusing in the medial thigh. So now you're starting to see this real gracilis muscle taking shape, and you saw him put his finger underneath the gracilis muscle and try to really define it a little bit more. So gracilis here and a little bit deeper and more lateral is where we get into the adductor longus superficially and the adductor magnus deeply. So here, again, he's around the muscle now, 360 degrees. So at this point in the dissection, we have not dissected the neurovascular pedicle. We're really working on the belly of the gracilis muscle, and we're getting deep to the vascular pedicle. And you can see he's getting his fingers around so that he's preserving the area that contains the hilum right in there. And now he's popping out at the other free edge of that gracilis muscle. You can see he can do that bluntly. And now we are really starting to define the whole 360 degrees of that gracilis muscle. Fascia comes down. This is just sort of more of a meticulous dissection to separate it from the surrounding structures. There's our obturator nerve coming in obliquely, as we talked about. And when he stimulates it, it causes the nice jumping of the gracilis muscle. So now he's starting to think about what segment of the muscle is necessary to harvest, and he marks that with a pen. So the critical point to recognize here is that you can get quite a long segment of gracilis, 10, 12, 14 centimeters through that small curvilinear incision. Now here, he has punctured longitudinally through the gracilis, started that longitudinal cut, and now has made that inferior cut. So here is the inferior division, and here is that longitudinal cut that's being developed. And because the neurovascular pedicle runs across the muscle, here we're going to divide it if we don't plan on a second paddle, and we're going to actually amputate that between two clamps so that we don't get bleeding. So the dissection then continues more superiorly, and now you can see that before he does the superior cut, we're actually going to thin that superficial surface of the gracilis, a little bit like what I showed you in one of the earlier slides. So it's just gentle snipping, and then it's some pulling, and it turns out that you can identify perforators into that superficial surface, and you can cauterize each one of them. Now this is critical. He just put a running vicryl suture right across that cut edge of the muscle, which serves as sort of a neotendon, so that when we go to inset it, the purchase of our inset sutures is going to go behind that running suture. Here you see he's snipping some of the perforators into the part that we're going to amputate. This is now the superior cut of the muscle. So now our entire segment is isolated, and it's just on its neurovascular pedicle. The last few fascial attachments are taken down. You can see that stimulating that obturator nerve here that you can see causes nice jumping of this harvested segment. And now we're simply working on the perforators to the adductor longus. Snip those, and you'll be surprised at how much extra length you get toward the profunda femoris vessels. So here you can see the fully harvested muscle, and we stimulate and we get some nice jumping. Very straightforward to close that incision, and we usually do that over a closed suction drain. So once again, just to stress the importance of thinning the muscle, You can see that I was doing this here with a bipolar scissor. It turns out that when we were using this kind of cautery scissor, we still were not adequately capturing all of the perforators. And so this did cause us to develop more hematomas as those little arterial perforators would open up after surgery. So I would not recommend the bipolar scissors anymore, but the point behind this is simply that you can further tailor the muscle so that you really have a nice, delicate, small slip rather than a huge piece of meat in the face. Okay, so now simultaneously while the harvest is going on, we use a two-team approach where we also prepare the face for gracilis inset. So let's have a little look at those steps. Now this video has not been sped up too much, so you've got to bear with me as we go through the steps. But so this is superior and this is inferior, and we basically make a temporal preauricular incision with a little bit of a cervical extension. Here, we used to go down a little bit further into the neck than we now do. You can see that when I make this temporal incision, I bevel along with the hair follicles so as to leave the least conspicuous scar possible. Once that's done, we usually take a brown Adson and we sharply elevate right onto the surface of the superficial temporal vessels and then the parotid-mesenteric fascia. So we're preserving the vessels just in case we need them for inset, not likely, but there is our parotid-mesenteric fascia. That is our target, and we sharply incise all the way until the anterior border of the parotid gland. Once we get to that anterior border of the parotid gland, we can start making some tunnels and further open things out. So here is the strategy to make those tunnels. And in people who have some preserved facial nerve function, you do need to stimulate each one of these tunnels before you divide it. So you might do that in post-paralysis facial palsy. Here I'm showing you the buccal fat, which is the next structure more anteriorly that you want to identify. And then as we work our way inferiorly, we're also going to want to get down and identify the facial artery and vein. We'll show you that in a little minute. So we're going now basically into the central face. We also expose the true temporalis fascia. We take those down, and you can see here that we are all the way at the medialis and at the lateral border of the orbicularis oris muscle. So we're really hunting around. Another landmark that helps us find the orbicularis oris and the medialis is the facial artery, which is right there. So you can see that facial artery really coursing in the oris. And that's what it looks like through the skin. And now here is our neurovascular pedicle, the artery and the vein. Almost always in a very predictable location right over the, just anterior to the angle of the mandible. Beautiful pulse pressure, and we'll put some vessel loops around them and tend to them later. That next step is to identify the true temporalis fascia, which you can see here. Interestingly, I'm just pointing out the middle temporal vessels, which some people have, which lie deep to the true temporalis fascia. Here we've identified the cross-face nerve graft inside the upper lip in the gingival buccal sulcus. And again, we pass a vessel loop around it. And just make note that we're now doing our neurorrhaphy work actually on the healthy side of the face, keeping that cross-face nerve graft quite short. Now we're placing some inset sutures right into that medialis so that when we pull on them, it leads to a pleasing smile. So you can see that there's a lot of sort of futzing around here. We usually grab the tissue with an Alice, see what it looks like. If we're pleased with it, we will throw that vicryl in that area, superficial to deep, as I tell everybody, and that's so that when you go through the gracilis muscle, you go deep to superficial and you're tying on that superficial surface. After 4 or 5 inset sutures are placed, we're ready, the recipient bed is sort of ready for that, to receive that muscle. So now let's talk about putting it all together. This is sort of what it would look like on the face, that piece of muscle, the vascular pedicle heading downward. In this particular case, you've got the nerve heading toward the mesenteric branch of the trigeminal nerve, but if it were a cross-face nerve graft-driven smile, the muscle would end here, the entire muscle would be moved forward, and the nerve would be pointed into the upper lip. So that's what I mean about kind of picking which segment of the gracilis you use. So this photograph sort of shows those 5 vicral sutures that are placed, and each one of these still contains its needle so that it can accommodate the tip of the gracilis muscle as we parachute it in. This video is a little bit darker than I'd like it to be, but I really just want you to see that I'm throwing each one of those vicrals into that medial gracilis edge from deep to superficial. So the knots are on top, and then each one of those gets pulled and tied, and then when you stimulate here, you can see that nice jumping of the muscle. Here, I just want to make the point that occasionally we also augment free muscle transfer with some static support. In this particular example, an elderly person with a prominent nasolabial fold gets a nice wide band of fascia lata secured to the deep dermis and subcutaneous tissues here. So it's sort of laid out on the face, but this is what it looks like when it's inset. So the gracilis muscle is here, and that static piece just lies superficial to the gracilis muscle, simply to recreate that nasolabial fold. So it's not like we do dynamic or static reconstruction. We very often sort of combine those, if that makes sense. Often at the conclusion of the gracilis inset, we just want to make sure that it's a pleasing smile, so we stimulate while looking at the smile to make sure that we see the right kind of lateralization of the oral commissure and that sort of superior displacement. Just to give you a sense of the kinds of results that we can see, this is a cross-face nerve graft-driven smile, and you can see a nice balance with the other side. So the function on this side is really yoked to her smile on the healthy side, and it's really quite pleasing and easy to use. This is a completely spontaneous smile since it's cross-face nerve graft-driven. This is an example of using a gracilis with the mesenteric branch of 5 because he has NF2 and bilateral tumors, but you can see a great deal of really meaningful movement in that area. This is just an example of a dually innervated flap that's driven both by a cross-face nerve graft and by the mesenteric branch of 5. So there are kind of clever combinatorial ways that we can drive the flap. This is a lady who had both a 12-7 and also then layered on a free gracilis so that she could really get that superior and nice smile in addition to really appropriate tone in the face. So that gives you just a little bit of a start at free gracilis for facial reanimation, and I hope that you have found this to be a useful adjunct for your facial nerve course. I hope you had a great day. Thanks so much.
The presentation was really very good, very useful.
Oh, she is very experienced and very crystal clear on what is to be done.
Yes.
How many cases you have done this gracilis transposition?
Pardon?
How many such cases you have done? Miss, what's your experience? Your experience?
Gracilis is amazing. See, for all those patients having long-standing palsies, particularly younger patients, this is the answer. In the present context, it provides you muscle as well as the nerve, and the excursion of the gracilis is too good for the spine. So this is the best answer when it is powered by 2 nerves, the mesenteric and the cross nerve graft. Mesenteric adds on to the power and cross nerve graft adds on to the spontaneity. So it's a great combination.
Okay, sir, then I will take up few questions which have been not answered. Actually, many questions have not been answered. So to start with, there's a question from Islamabad. Dr. Talat is asking about, not only Dr. Talat, actually many have this doubt. What about the malignant otitis externa? How will you treat these cases with facial nerve palsy? When will you go for a reposition? What will you do, sir?
Okay, first of all, malignant otitis externa is an infective condition in immunocompromised patients, particularly diabetics and elderly patients. And many of them develop facial palsy. So first of all, the treatment of the primary pathology is most important. since it is a infection, so we have to, and most of the time it is because of the Pseudomonas. You have to give long term because infection in the bone requires antibiotics for weeks and weeks. So it requires long term Pseudomonas directed antibiotics, a good radiological evaluation. It requires amazing radiological evaluation on a periodic basis. Like if you have facilities, you can get a PET MRI done and a high resolution CT scan. That's a great combo. That is for functional evaluation of the metabolism going on, how the pathology is going on, and along with the ESR. So if it improves with the antibiotics, nothing is required to be done. Many a time microabscesses form and antibiotics are not effective, then obviously you have to do a sort of debridement. You have to remove every possible, necrosed area. You may, the temporal bone is involved, you may have to do subtotal petrosectomy. If it is going beyond that, you have to remove every possible necrosed tissue so that the antibiotics become more effective. Now for the facial now, when everything is standardized, subsides, everything subsides. As I said, the priority of the treatment is treating the disease. Facial nerve is secondary here. And majority of these patients are elderly. In elderly patient, you cannot think of such gracilis and all those. That is not the choice at all. In elderly, if the patients are fit for surgery, you can do the muscle slings. Otherwise, the static slings are the answer. And secondly, if you find a particular segment of the facial nerve is necrosed, you can do a end-to-end anastomosis or a cable grafting. So depending upon the situation, you have to take up.
Okay, sir. And sir, John Shadow from Australia is asking, when grafting, do you use suture, fibrin glue, or just suture?
Almost same. See, wherever you can put suture, like on the face, you use suture. But the areas where you cannot use suture, like deep in the temporal bone or intracranially, you can wrap in the fascia and put a fibrin glue, and it works well. So a lot of studies done comparing the sutures and fibrin glue. It is almost same. Hardly there is any difference in the overall outcome.
Okay, sir. Dr. Nagesh from Vizag is asking, what is the management of facial nerve palsy in a neonate after forceps delivery?
Yes, in the children and neonate, sometimes they have complete facial palsy. And so after the evaluation, see, these muscle flaps, there's a, free transplant, muscle transplant are meant for young people only. So young people, if requires, you can do all.
Yeah, that's also for the congenital. For congenital facial palsy, the free gracilis is D preferred. That is how I went to.
Even congenital bilateral facial nerve palsy like Mebius syndrome.
Yeah.
Bilateral gracilis is the answer.
Okay.
Sandeep Kumar
with the mesenteric, of course.
Medial cranial.
Cross in bilateral, only mesenteric.
Okay.
Sandeep from Bareilly was asking, suppose we have to do decompression at some particular point, like trauma, trauma is there. How far? Suppose we have to do decompression for any trauma, any site of injury, then what is the, how far means we have to do decompression? Suppose it is on the second genu or first genu. How far means we will
Depends upon the site of trauma. Depends upon the site of the trauma. Mostly it is the first genu which is affected.
Yeah.
So according to the site of trauma, you have to be able to, expose proximally and distally to the area of damage.
So he's asking how many millimeters or what is the criteria where to stop the decompression. I think that's the question.
When you find proximally and distally a normal nerve, until that you have to go. And for the area which is involved, accordingly you have to choose the approach.
Okay.
And in decompression, Satish, excision of the sheath. What is decompression?
Yes, it is always better to incise the sheath because intraneural hematoma inside the sheath are common in traumatic conditions.
You would advise to always incise this sheath.
Not always. Like if you are in cholesteatoma and sometime when there is a infection in the surrounding, we tend to avoid incising the sheath to prevent infection involving the patient.
For trauma, yes.
Okay.
Trauma.
Okay. Okay, so what about maxillary? Many have asked about maxillary artery in relation to the mandible.
Maxillary artery, I showed now. Maxillary artery is given off from the external carotid as a terminal branch along with superficial temporal deep to the neck of mandible. So the superficial runs up superficially and the maxillary run horizontally deep to the mandible laterally on the this thing lateral pterygoid horizontally, and that's how it goes to the pterygopalatine fossa. So it goes horizontally deep to the mandible in the infratemporal fossa and then come anteriorly towards the pterygopalatine fossa.
Okay. And sir, is there anything, Dr. Krishnan from Mumbai is asking, is there anything like agenesis of
anything like
Genesis of
facial nerve? There are articles actually.
maybe anything congenital can happen, but I have not come across. Agenesis, she means to ask that the facial nerve is not developed at all. See, in the congenital issues, Ashish must have got more cases. In atresia cases, you find abnormal facial nerve course. Hello?
yeah.
Yes, sir.
Agenesis I have never seen, but yes, abnormal courses.
Okay, sir.
Are common. I would say not uncommon. As I told you, everyone is an amazing microtia surgeon and it deals with the hearing problems as well at the same time. I have seen the only one guy who handles the external ear, middle ear and the inner ear at the same time. And we have discussed couple of times very, very abnormal facial nerves, particularly in the microtia, most commonly the nerve run anterolaterally. Nerve may come on the promontory, on the round window, on the oval window. These are common findings in atresia cases. Agenesis I have not seen. Abnormal nerves are seen.
Okay, sir. So Dr. Pushkaraj from Mumbai is asking, in large vestibular schwannoma more than 4 centimeters, do you still prefer single stage translab or combined 2-stage procedure?
Single stage. Why 2-stage? Always single stage.
Actually, Varamita, allow me. I think now the new trend is actually when you have to sacrifice the facial nerve in any skull base, or they are actually doing the masseteric to facial anastomosis in the same surgical stage.
Only if the proximal end is not available, Ashish. If the proximal end is not available, like after acoustic neuroma, if your brainstem end,
then you said yes, correct.
Then you will put a saphenous vein and use the same nerve. Only if the proximal nerve is not available, proximal stump is not available, then obviously, fasciomasseteric.
In the same stage, they are not even waiting, right? When they
same stage, you can add on cross nerve graft also.
Okay. Dr. M.V. Apparao from Vishakhapatnam is asking, some people say if a vein is damaged accidentally, medial to the vestibular schwannoma, it is very difficult to control and translap. So what is...
What damage?
If a vein is damaged accidentally medial to the vestibular schwannoma, it is very difficult to control and translap.
Vein.
Yeah.
See, that is the principle in the vestibular schwannoma surgery, that you have to work in the arachnoid layer, not outside that. So, when tumor is there, between the tumor and the neurovascular structures is the arachnoid layer. So the first principle is do intratumoral debulking, stay inside the arachnoids, don't go outside. If you go outside arachnoids, neurovascular structures are there to be damaged. So this can happen. This is always preventable if you stay in the arachnoid plane. Number one. Once some vessel is damaged, obviously you have to repair. Vein, yes, the Dandy's vein is there. I've shown Dandy's vein. Some more veins are there. Obviously, you have to bipolarize and use Surgicel then.
Okay, sir. So Dr. Sanjay Helale from Mumbai is asking, what is your opinion about labyrinthectomy and simultaneous cochlear implant with cochlear nerve preservation?
Yes. Labyrinthectomy nowadays is a trend with any, not only labyrinthectomy, for that matter, any skull-based procedure you are doing, you can, if
I mentioned during the cochlear implant time, temporal bone, if your basic
I think he's washing up now. He's reached the theater.
Ashish was your experience with microtia and your facial nerve surgery at same. Suppose you must be getting so many cases with microtia.
Yeah. So I haven't started yet. That is where my pursuit of this facial nerve reanimation is, and that's how I went to TISA. But this is my next chapter. But I see a lot of bright future in this, and I really encourage a lot of people to get into this. You saw the post-op results. I think you can give a really very good result.
You got my answer, Ashish?
Sorry? No, we lost you.
You didn't get my answer?
No, we lost you.
Okay, let me repeat it. Can you hear me now?
Yeah.
After any skull-based procedure, forget translab only. After any skull-based procedure, if the basic functioning unit is intact for cochlear implantation, that is a fluid-filled cochlea and intact cranial nerve, that is cochlear nerve. You can do same stage cochlear implantation with any procedure you are doing.
Okay.
Yeah. Okay.
Okay, sir. Sir, Dr. Sanjay Gildial from Mumbai is asking, what is the minimum size of the gap that would require an anastomosis? I mean, this is a question which
you cannot measure in millimeters or centimeters like described, but I tell you, it is your gut feeling which should decide. Whatever anastomosis you are doing, if it is under tension, it should be avoided. Even if you are able to do it, better to put a nerve graft. Because any tension suturing is not going to give a good result, and that result will be certainly better with the the interposition graft rather than a tension suturing. So always take a call of if there is a tension, take a nerve graft.
Sandeep Kumar from Bareilly is just asking, suppose a trauma in the vertical portion of the facial nerve. You would go by pars canal approach or with mastoid approach, or what are the advantage of it?
See, once there is a facial nerve trauma in the vertical segment,
yes,
please take a good approach, giving good exposure. Now, once the facial nerve is damaged, you can't think of compromising with the exposure.
Yes, yes.
Exposure is not, approach is not important to reduce the incision and all that. Important is a good exposure to deal with the facial nerve injury. So whatever widest possible exposure they can take, should take. Now the exposure is not a question to minimize it. If vertical segment is injured and if some grafting is required, why don't you take a go postural, do a mastodectomy approach and do a proper work.
Get your open approach. That is the best. Your experience with you have any experience with auto strop drilling available in MS? You are using auto strop drilling like with strop when the nerve come or the vessel come. You have with you because John Shadow from Australia, he is asking because he wants some experience.
What is that?
Yeah, that is the bone drilling with what you call that. I know that
Oh, the Medtronic thing.
System.
Okay.
That is piezoelectric system. That is piezoelectric system, so that when you are drilling, as you come to any soft tissue structure, it stops. It is good, but it is so slow a system. If you are doing mastodectomy with that, it will take 2 days. But yes, it is useful. If you are working over the facial now with a thin bone over there, yes, you can use it.
For the cochlear implant,
selected areas.
So many people are using for the tunneling in cochlear implant. So many people are using for the tunneling in the cochlear implant of posterior cochleostomy.
Yeah, because they have a fear of injuring the facial nerve. So if they do not know the anatomy of the facial nerve and is scared, why to do tunneling? Why don't do posterior tympanotomy?
Avoid the implants.
These are not shortcuts. These shortcuts cannot work.
Okay.
We didn't discuss facial nerve monitoring at all, Satish.
Yeah, it is amazing tool, Ashish.
Yeah.
Now, indications are, you have to describe your indication according to your experience. But the thing is, the facial nerve monitoring gives you a lot of benefits. I mentioned it. Remember? First is, it helps you in localizing the facial nerve when you are operating. At the beginning of the surgery, you can localize the facial nerve by means of facial nerve monitor. Secondly, when you are working close to facial nerve, it warns you. It warns you that you are close to the nerve. Nerve is being, affected by the movement, traction, and you can modify your approach or modify your step to prevent injury. And third is, at the end of the surgery, like carotid I am doing, most of the injuries are not because of the transaction. Most of the injuries are because of the stretch. So at the end of the surgery, even with the nerve left intact,
if you get
nerve intact, at the end of the surgery, if your monitor says it is functioning, that gives you
can sleep peacefully.
Yeah, it gives you good relief that your nerve is functioning.
By Dr. Rajeev Pachauri, if suppose while doing mastectomy or vertical photo, some fibers of the facial nerve is exposed.
Fibers of the facial nerve?
Doing surgery,
Your voice, Rajiv, your voice is not clear.
Boss, just a minute. Please hold on. Just a minute. I am changing to different.
I would like to tell to all the viewers that the level of commitment and dedication which Satish Jain sir has, I think we all should salute. He has been talking non-stop. He's been sharing his knowledge even from college to the hospital operation theatre. He's been trying to answer all the difficulties and questions. This is the level of commitment, sir, which is we should really salute.
No, not salute, be inspired by too and try to emulate. And I'm going to tell you one funny thing that happened yesterday. Dr. Sethi had organized a music thing for his wife.
Yeah, I know.
And Satish was there, Aldo Stam was also there. And Satish actually fell asleep in 5 minutes. And Aldo is trying to talk to him and Satish is fast asleep. As if he's not working, he's asleep.
Yes, you're right.
So he's actually God's gift to ENT. I'm getting several such messages from all across the world, from Saudi, from Lahore, from Africa.
Hello?
Yes, sir.
Hello?
Yes, sir.
Satish?
ये राजीव बस ये माइक नहीं काम कर रहा यार. हेलो राजीव बस.
We can hear you. We can hear you.
Yeah, can you repeat your question now?
During mastoid, suppose the fibers of the facial nerve are exposed or some, you can say some damage, then what should be done at that level?
Okay, sometimes you expose the facial nerve. There could be periosteal damage, epineural damage. That is not going to affect the function, overall function. And if you find that you have entered inside the nerve and partially damaged, then it's a different story. So as long as you are up to the epineurium, nothing is required to be done. What you can do, additional few millimeters on either side, a prophylactic decompression in case the nerve cells up. Right. But if nerve is partially damaged, then you have to take a call. If 10-20% nerve is damaged, still you can leave and reposit whatever segment you have damaged. But if it is more than that, it is better to resect and do anasmos. Because that whatever regeneration is going to happen will give more synkinesis rather than a good appearance. So that is how you have to take a call. Can you hear me?
Yes, sir. Yes.
Hello?
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 Satish. Satish.
Hello?
Satish, can you hear me?
Yes, sir, I can hear you.
Satish, can you hear me?
Yes, sir, I can hear you.
Yeah, the question which was asked to you just now, when the fibers of the vertical course are exposed, and you answered it correctly that you should decompress on either side for a few millimeter. At the same time, give a shot of sodium hydroxide immediately to the patient. Give a shot of steroid immediately to the patient. Even if the nerve is not damaged, even the sheath is not damaged, give a shot of steroid because this can cause post-op edema and you can get a patient paresis, transient paresis. To avoid the tension to the surgeon and to the patient, give a steroid immediately. Madhuri,
Hello?
do you agree?
Yes. Perfectly fine, sir. Perfectly fine. And even if few fibers gone, nothing happens. We just have to do a bit of decompression on both the sides and put steroids also, local also, as well as injectable.
Hello?
Days.
Hello, yes, sir.
Yes, can you hear me?
Yes. I can hear you.
Your voice is not coming properly. What's problem यार? एक ही चीज को बार-बार क्यों कहना पड़ रहा है? Ask him to do ना. Hello?
Hello. Is it okay now?
Yeah, I can hear you.
No, okay. Paramita?
My voice is okay, sir?
Yeah, it is better now. And am I audible?
Yeah, very much.
Yes, perfect. But not picture is not there.
So I am
Not
here.
visible.
I am here all set with the first case. This patient has a benign lesion in the right side of the parotid gland. I kept it as a first case. Why? For the reasons so that first of all we should know the course of the facial nerve again. We have seen in the cadaver. Now again how to identify the facial nerve in the parotid and how to save the branches from the lesion in the parotid. So this is like preservation. Then next we'll be doing, as the nerve is not there, anastomosis. Third case we'll take when there is no possibility of anastomosis. Then we'll do some sort of reanimation. And the fourth is the elderly patient. When nothing is possible, we'll do the static sling. This is how our, the series of cases today. So first case is parotid, and the whole goal is the preservation of the identification and preservation of the facial nerve. Are you getting the picture?
Yes, external picture is there, but not the operative table.
Beautiful ceiling of your OT. We can see that.
Hello? Hello?
Yes, ma'am, we can hear you. Continue.
You can ask the question in meantime.
Yeah, so so to repeat once again, since there were many doubts related to Bell's palsy that sir had mentioned, so it is I will, Dr. Madhuri madam and Ashish sir, so it is, did he say that, he said that if in Bell's palsy, if the electroneurography is more than 90% degeneration and if the EMG is silent on the 17th or the 21st day, then we should go for FND, facial nerve decompression, right? Or any intervention.
Yes, this is what Dr. Satish was talking. Yes, you're right.
Yes. So this is what many had the doubt.
This is, but this is a logic.
Labyrinthine segment and the geniculate ganglia. That also he said. It's not
compression. He said, hello?
Yes.
He wanted to tell the usage of these two investigations, that both them showing this picture that more than 95% on neuronography and EMG silent, that means that case needs to be taken up. But usually in clinical practice, we usually wait for 1 or 2 months for this to, if there is a recovery, we don't get these two tests done.
Okay.
Usually.
Yes, there is
that is difference, that these two tests can be done But in usual practice, what we are doing is we are waiting for at least 2 months. If the recovery is there, why shall we go ahead and get these 2 cases done? But once the recovery is not happening, then we get into that and get a MRI also done many times, maybe Bell's palsy, maybe a presentation of facial neuroma also. So these 3 investigations come into picture once we have a doubt that Bell's is not improving on its own. So practically speaking, we should be giving at least 2 months of waiting period for this to recover. Okay.
Okay.
Announcement from this side. This Thursday we are having live surgery session from 4 p.m. onward, and we are doing basic surgeries to the highest high-end surgeries. Basic starting with the mastectomy, cholestoma, thyroid, maybe even some mandibular, and and trying to get some laryngectomy or even angiofibroma is there with intratemporal extension. So maybe that 5 or 6, 7 hour session will be on the live surgery. And this Thursday from 4 p.m. onward. And the next Sunday is the full day for the steppies, live surgery. And Dr. Asim Desai is there, Bhunkar is there, Dr. Satish is there, and lots of discussion and live surgery on the steppies. And again on next Thursday, planning to have implant day with lots of implants and subtotal petrosectomy or different approaches for the implant and different types of implant. Hence, let's see.
Great collection. Yes. People are enjoying.
Yes. So, Madhuri ma'am, I'll ask you a question. You've been my teacher always.
Oh, great.
So, I want to know, ma'am, what about the steroid treatment that you would give for the Bell's palsy patient? When can we start? And
the moment patient comes to you, maybe he comes in, it depends. Always a facial of palsy. The important thing is when the patient visits the surgeon or the doctor for the first time. If he is already come for 2 months late and there is no improvement, 0% improvement, then we'll get all the investigations done. But if he has come within few days of the facial of palsy, post Bell's palsy, so what we give is we can start with the oral steroids only. Okay. Almost 1 milligram per kg, I mean 50 to 60 milligram per day in divided doses, and then neurotonics also, and keep observing for tapering dose for at least 1 or 2 weeks. Hello. Then we will keep observing. We will keep the patient calling after 1 week and 2 weeks. If the improvement has started, we will keep increasing our waiting period. But after 1 month, or as I told you, 1.5 months, the improvement, totally no improvement is there, then we will get the MRI done, and rest of the 2 investigations, electroneuronography and electromyography. So steroid is the mainstay of treatment during our waiting period. It can be prolonged up to 5 to 6 weeks, the steroid, if it is giving improvement.
Okay, ma'am.
Okay.
Hello.
Okay, ma'am. Yes, sir.
Can you hear me?
We can hear you.
We can hear you.
Are you getting any picture?
Just outside means external camera picture.
Endoscopic picture, microscopic.
Microscopic. Wait. Yeah, we can see the microscopic picture.
Okay. So this is the right side where I am going to do a superficial parodontectomy.
Volume, please.
Okay.
I think, sir, you have to take your mic little more closer.
Okay. Now better.
It's better.
Yeah, it's better.
Yes.
Okay.
Better.
So this is not the the aim is not on the parotid. The discussion is on the facial now.
Yes.
But since we are doing parotid, so I am going to show some anatomical aspects here, not on the pathological aspect of the lesion. It's a benign lesion. The workup and all we will discuss in the parotid case. Okay. So for a parotidectomy, the first and the most important thing is the incision. Incision has many implications. Improper incision, only incision can damage the facial nerve itself completely. So in incision, you have to save the facial nerve. I will tell you, it has a cosmetic value. You have to preserve the greater auricular. At the same time, you have to prevent the Fraze syndrome. Fraze syndrome, when you do a superficial parotidectomy, if your incision was too superficial, whatever the bed of the parotid with the postganglionic nerve ending, if they come in contact with the subdermal nerve ending and sweat glands, can lead to stimulation and Frey syndrome. So all four things to be minimized, prevented. So my first part of the incision is the value is the cosmetic, and what I am doing, this pre-auricular component of the incision will be hidden behind the tragus. Can you see?
You're right.
So this will be hidden behind the tragus, so there will be minimal component which will be visible from outside. Okay?
Okay.
Same thing is around the lobule, and it will go behind. This is occipital component, little behind, and this is the angle of mandible, so it will be, this is the cervical component. See, this is cervical component. So the incision should be minimum visible. See, from outside, anteriorly, there will be hardly anything visible. Can you see?
Yes, yes, yes. A bit of centering is needed, Satish.
Yeah.
Yes.
वहाँ लगा रखा, दिखेगा कैसे मेरे को? इधर कर।
Yes, perfect.
So, सामने रख मेरे. So, this first important thing is the cosmesis. Now, second important thing here, as I mentioned, the prevention of Frey syndrome. What you need to do is, you have to elevate this flap, a deeper flap containing this, aponeurosis. You have to go right to the level of the parotid fascia, and everything to be elevated in the flap. Too superficial a flap raised,
Deep to the. Okay.
right to the parotid fascia,
Okay.
and to be included in the flap. Otherwise, can lead to a situation of Frey syndrome,
Later
and
on.
that is something to be avoided. And that again is important from incision point of view. Third is, we have to preserve the greater auricular. I showed the greater auricular in the cadaver. Now I will show you how to identify in the live situation and how to preserve the posterior branch of the greater auricular. The anterior branch is going to go because that goes to the skin.
Over the surface.
इसको करो ना. Yeah, and here the greater auricular is very superficial. So I will tell you how to preserve that. This is just deepening the incision, nothing else.
So we have to avoid using cautery here, so
Yes.
that we may not be harming the
Yes,
great auricular.
yeah, unless you identify and keep it away. Yes, yeah, we are changing the camera for a moment, madam.
Okay.
Just a minute, so we'll be back. So four parts, four importances of the incision: the cosmesis, preservation of the greater auricular, prevention of Frey syndrome, and protection of the facial nerve branches. Why I am saying protection of the facial nerve? When you raise this flap anteriorly, where the anterior border of the parotid gland ends, if you go beyond with the flap elevation, there the nerves, all the branches become so superficial, running on the
Very
masseter.
superficial. Yeah, yes.
Running on the
yes, right.
masseter. If you don't realize this and keep raising your flap anteriorly beyond that, you will end up injuring all branches.
Yes.
So
Bilkul.
that is something
Right.
very important. Is the picture better now?
Picture is a slight focus is needed. Satish.
Yeah, yeah, we will. Better? Hello?
No, not.
Yeah, is picture better
Still
now?
It is. The sharpness is not there.
Okay, we'll improve that something. Now, I will raise the flap. So the most important thing is, you have to avoid going far anteriorly.
Okay.
See now, this is the tragal cartilage which I am preserving. This is important to preserve the tragal cartilage. Can you see?
Yes, yes.
Tragal has a cosmetic value. Non-tooth matle sir. Tragal cartilage has a cosmetic value, you know. See, this entire cartilage is preserved.
Yes. Yes.
And here, the depth of the skin flap is important. See this depth.
Mm-hmm. You are going so deep that you are just over the parotid gland fascia.
Yeah. Just a minute, changing the camera. क्या हुआ?
Some issue with the camera.
Yeah. Changing to a better one.
Sir, camera is not connected, sir.
Now let me know how is the picture. यार एंडोस्कोपिक दिखाओ
Still
ना
the
यार.
roof is visible.
ये कौन चेंज करता है कैमरा मेरे को बोला.
Okay, now it is there.
It is? Okay?
Yes.
I hope it is better now.
Yes.
See now my depth of the flap. This is so important. You have to go right to the level of the parotid fascia. See, that is the parotid gland. So that you don't end up injuring you don't leave a thin flap with you, which can result into Fraze syndrome.
Okay.
Now, as you go down, the third thing I told you, which is very important, is to protect the greater auricular branch. See, many a time surgeons don't take care of this. What ultimately results in, if the posterior branch is damaged, anesthesia of the auricle.
Yes.
And that is so troublesome, particularly to the females who wear earrings, particularly to the people who live in old climates, cold climates, because this is a thermal sensor. And if you don't sense the temperature, it can damage. So this posterior branch is important. See, while raising this lower flap, I am so careful not to damage or not to cut through, because the nerve here comes very superficial. You have seen it runs on the surface of the this thing, sternomastoid muscle. Okay? Now this nerve comes from behind the McKinney's point, running on the surface of the muscle. Can you see the nerve now? Not? Can you see the nerve where I push my? Can you see?
Absolutely there.
That is most important. Now, how you can identify? I give you another landmark. See, this is a vein. Let me show you. That is a vein joined to form the retromandibular posterior division. It runs just above this vein. Let me show you. Yeah. See, my nerve is here. Can you see very clear?
Yes, very clear.
Can you see the divisions
Satish?
also coming into the
Satish?
picture? Yeah.
Hello, Satish.
Yeah.
Can you tell all the 2-3 markers for the great auricular nerve on this side when you're showing it to the people?
Yes. So most likely this run parallel a centimeter below a posterior division of the retromandibular nerve branch, and that is the best landmark. Number two, you have to stay absolutely superficial. See, this is the sternomastoid muscle. This runs right over the sternomastoid, and the nerve, as it crosses the sternomastoid, see the level. Can you see the gonian?
Yes, angle of mandible. Gonian.
Yeah. Let me show you. See the gonian here.
Yes.
Can you see the gonian? This now where it crosses the sternomastoid, it's right in the line of gonian. So don't try to look for here, there, everywhere. Just find your landmark and your nerve.
Satish, we can draw a line between the mastoid tip and the gonion, and the line bisecting the two.
You draw a line horizontal line along the gonian, and it is where it crosses the sternomastoid.
Okay.
Simplest way. That's how I find it.
Oh, great.
Now, staying superficial, now my concern is this anterior branch, the posterior branch, scissors, buddy. Now see this greater auricular. in our practice we are able to preserve over 95% of the time this branch to the lobule.
Posterior branch, which
Yes.
is important one.
Yes.
Okay.
See this branch going to the lobule. Anterior I am not bothered.
Yes,
Anterior
you're
you
right.
cannot preserve
Slight
because that goes
anesthesia over the
to
surface of the
skin. See this branch going up?
Yes.
Can you see very clear? Can you see very clear?
Make it a bit more clear, Satish.
Okay, okay. See this now, this one. Okay. That one. So it requires additional 2 minutes attention we must give to a poor patient. They
Right.
should not face this problem with this nerve. It's not
So
parotid
you-
about preserving the facial nerve only. See, this is the nerve, small nerve.
Yes.
I hope you are able to cut it.
So your carry home message is try to save the posterior branch at least.
Always, always. Try hard to save it.
Okay.
See this? You can save. See the long branch going?
Yes, sir.
Yes, yes, yes. Now it is visible.
So 2 minutes of extra attention and you can preserve this. As simple as that. Because this is going
In
deep.
such a case, Satish, in such a case, if there is, God forbids, in any person's case, there is an injury over the face, then also you'll not take the great auricular, you'll go for...
Pardon, injury?
If there is some injury during the surgery of parotid, even then you will take the great sural nerve in place of great auricular nerve.
Depends what injury. If it is a small branch injury, you can take greater auricular.
Okay. Otherwise, it depends on size, not the site.
Yeah. See now. Can you see this entire branch? Mop karna. You kar. See this entire branch going?
Yes, yes.
Going.
Very clear.
Going, and it is going to the lobule here. So what I have done now, my area of interest now working will remain anterior to it. As simple as that. See now. I
So
can
what
raise
is the
my flap
setting?
now. I can raise my flap easily now without any issues.
Yes, sir.
The entire flap I can raise. This posterior branch I can sacrifice.
So you are keeping anterior to the sternocleidomastoid and in the neck and separating it there.
Yes.
So what is the setting of the unipolar that you're using? How much
Minimal,
it is?
minimal. See here, I was not using the cautery along the nerves or blindly where nerve could be. So first define the nerve, stay away, then you can use.
Okay.
See, this is the lesion. Can you see here?
It is almost in the tail of parotid?
The lower part, yes.
Lower
It
part.
looks like Vardheim's tumor. Vardheim's tumor. Now see how deep is the flap you have seen. See this right on the parotid gland.
Right on
See
the
how thick this is known as SMAF, superficial musculo-aponeurotic fascia.
Yes.
Yes.
Yes. Superficial muscular aponeurotic fascia.
Flap, yes. So this should be thick. Now how long anteriorly you are supposed to go? That is most important. However good surgeon you are, you can end up damaging every branch of facial nerve. Now see, this is my end of parotid. Can you see?
Anterior end of parotid.
Can you
Yes.
see the plate, this muscle, masseter muscle?
Yes.
Now
Masseter
all these
muscle,
branches,
yes.
let me show you. All these branches crossing the parotid are running on the masseter. Can you see this?
Yes.
Can you see this?
Yes, 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 yes.
All these, see, number of, I call n number of branches of facial nerve, not 5 branches.
Okay.
All those are running so superficial on masseter. Can you see very clear or not?
Yes, yes.
See all
Very
those.
clear.
So if you keep raising the flap anteriorly on the masseter without realizing, you can end up ruining everything. Whatever good surgery you have done, patient will have a complete palsy. So and see, so important in flap raising. That's why it is the flap raising which is the first and the most important part. You can give all possible damage what you can give in a parotid in flap only. That's why I started from the beginning with this flap. Okay?
Okay.
Now this is our complete exposure. Can you see? And the incision, you know, was around this periauricular region with minimal visualization of the area. Okay?
Okay.
Is so far clear? So what we could achieve?
Very clear.
We could achieve the posterior branch preservation. See, this is at greater auricular. We could preserve all the facial nerve branches in the masseter. We could elevate a thick flap, and we could give a good cosmetically acceptable incision.
So you told 4 points, and you have shown all those 4 points.
Yes, that is most important. Incision is everything in parotid.
Yes.
All possible complication you can give in incision only.
Yes, right.
So what you can do in the institutes, you give incision yourself and ask your assistant to do further work. Incision is more important.
Okay.
Now, up. कहाँ गया वो? अनुपम, अनुपम. ये हो गया, कनेक्ट हो गया, ध्यान रखा कर. मैंने देखा. Hello?
Yes, sir.
Yes. Now the next part around which the entire surgery revolves. What is that? Facial nerve. Identification and preservation of the facial nerve. This is something all about parotid surgery. We all have been knowing for years. So now, the first thing, the identification. There are so many landmarks. You go to the literature, there are number of landmarks described for the identification of the main trunk of the facial nerve. We have tried all. Now I'll tell you, very, very practical. We take two landmarks in consideration, and we call it, we have given it a name, convergent approach. Means one landmark above, one landmark below, and will converge, and where these two landmarks converge actually would be the facial nerve. So what is my first landmark from above? Is the tragus pointer. See, this is the tragus. Can you see the tragus?
Yes.
And see, this is the medial end of the tragus, which is ending as a pointer.
Yes.
Can you see the pointer?
Yes.
See this triangular area. This
sharp triangular area facing inferior.
Yes. Let me show you for the sake of demo. See the triangular area.
You can
you see this? Can you see this pointer?
Slightly, you zoom in, zoom a bit and focus it. Zoom a bit, sir.
Okay.
Satish.
Okay. Zoom out.
Zoom in. Zoom in.
Okay, zoom in.
Good. Now a bit of focus. Sharpness is missing.
Yes, sir.
Better?
Yes.
Now see this triangular pointer. Can you see? This tragus is ending as a pointer. See this?
Very beautifully visible.
That is mobile. Okay? So my first landmark is from above, and I will take into consideration like my facial nerve trunk would be 1 centimeter below and 1 centimeter deep to this level.
Deep.
Okay?
Yes.
That will be first. Now my second landmark, which I am going to take into consideration, is going to be my digastric muscle. Digastric is a God's given natural landmark. See that? See, this is the anterior branch of the greater auricular. Can you see this?
Yes.
And this is the posterior one. See this? So here I will sacrifice the anterior branch to enter into the parotid.
Okay.
Not the posterior one. Posterior is precious. And I am giving you a wide exposure to show you my landmarks.
Yes, this is so nicely visible, the posterior belly.
I don't think this is posterior belly, madam.
Maybe
It is
it's less,
going to
like
be
deeper.
medial. This
Medial.
is, this is a same, sternomastoid.
Acha, it is
Yeah,
fibers of sternocleido.
yeah.
Maybe the direction is.
Yeah, the digastric would be coming deeper. Now see, after separating the sternomastoid, I will go deeper. Yeah. So digastric is anteromedial to the sternomastoid. We know it is a deeper structure. See this digastric?
Yes.
Yes.
Very clear?
Very clear, very clear.
See, this is coming.
Very clear.
This is a very, very important landmark. This is the nature's given landmark. We all know the stylomastoid foramen. Where is on this digastric muscle? You know, in the mastoid, we take a landmark into consideration, digastric ridge, where the digastric is inserted, follow anteriorly, and just anterosuperiorly is the facial canal.
Yes.
Now see the digastric. Now I will follow this digastric right up to the mastoid tip. This is going to be the mastoid tip.
Yes.
Now my facial now is going to be where this digastric goes onto the mastoid tip, immediately superior to it and deep to the anterior margin. Got my point?
Yes, sir.
Repeat it again.
Deep to it. See.
Okay.
What does it mean? If I run my artery here on the surface of the digastric, I cannot injure the facial nerve. That is deeper.
Yes. That is understood.
Similarly, I told this is the tragal cartilage and my facial nerve is 1 centimeter deeper to it. So if I run my cautery up to this level of the digastric and the, tragal cartilage, up to that level my facial nerve will be still 1 centimeter deeper.
Great. You're right.
So this is the convergence approach, sir?
Yeah, converge. See where these two landmarks meet, my facial nerve will come. I will not look for it. It will come there.
And
so
just
see,
to tell the viewers that this approach has been made by Satish Jain sir only.
Yeah, long back I have been advocating this. See now, the beauty is I have opened up like a book.
Yes, sir.
Otherwise, I have seen people working here looking for the facial nerve like digging the well.
Yes.
See now, why I have taken this advantage? Everything lateral to the digastric. See this digastric. This digastric. Everything lateral to the digastric and everything up to the level of the tragal pointer. I can work as my facial nerve is deeper. And here I have opened it like a book. See this.
Yes.
Okay. This is the tragal pointer. This is the digastric. At this level, you don't need to worry about. You don't need to, frighten yourself unnecessarily until this level that the facial may come. It cannot. It is still deeper. Now, I told you my facial nerve will be 1 centimeter below this. 1 centimeter below this here. And just above the insertion of the digastric at the same time. Now see, this is bipolar then. Converge from both sides, you will find. Find all. Some little bit of the oozing I can use my bipolar because it is quite superficial. No worries. Yes, you kar.
Satish?
Yes.
Can you do a bit of get a bit of washing done here so structures will become more clear?
Yeah. Wash karo. Yeah, I have zoomed in, so everything is looking bigger, you know.
Yes.
Facial now, but people are asking what is mass attachment, superior attachment, inferior attachment.
What?
Isthmus, aponeurosis.
Superficial muscular aponeurotic system.
Everywhere about the zygomatic posteriorly to see that is more useful when you do the facelift approaches.
Yes.
For us, it is of no use.
Satish.
Huh?
Hello, Satish.
Yeah.
This is a continuity of the aponeurosis between the occipital and frontalis muscle.
Yes, everywhere
when it
around.
is attached to the
Everywhere.
zygomatic, and from there it
above continuing with the in continuity with the temporalis fascia, superficial one.
Yes.
See now.
So it is a continuity of that.
Yeah. Now, so for the junior colleagues, until you find these two landmarks, this, your tragal pointer and facial now, until this depth, you can go like anything without worrying about the facial now. Now, see both the landmarks. Let me. Yes. Now, I said my facial is coming out of the foramen just above the attachment of the digastric. See, this is digastric. This is digastric.
Yes.
And where it is attached to above? Here. See, here it is attached to. Can you see? That is the end.
Yes.
That is the mastoid process. Okay?
Yes.
So my facial would be just superior to that. And I have already told it is
superior to the superior margin of the posterior belly of digastric.
Yeah, so I am separating this digastric behind, just keeping it behind. See this, I kept it behind. So that I can see at the anterior margin the facial nerve emerging out of the stylomastoid foramen. Okay?
Yes.
Any point of doubt, please?
No,
now
everything is quite clear.
This is, see the tragal pointer 1 centimeter below at this point where the digastric is ending, and 1 centimeter deeper.
Satish.
Yeah.
Satish, slight centering. This is slightly hidden. Yes. Take it a bit forward.
Forward? Okay.
Yes. Slightly. Yes, now. Now it is okay. Perfect.
See now, I am opening up the plane here. That is my tragal pointer, that is my digastric.
Very
at the anterior superior edge. See this?
Yes, sir.
At the facial nerve is a centimeter deeper.
Yes.
We can see it with you.
Yes, that is your facial nerve.
Yes, perfect. Every time it gives such a feeling of excitement and happiness to see the facial nerve.
See, that is your facial nerve.
Yes.
Yes.
Let me, and see, these are the vessels close to it.
There are always fine vessels associated with it.
Yeah, a lot of people consider them as landmark. Now, believe me, if you use these vessels as a landmark can be a good one, which should be easily identifiable. Identifying, keeping something as a landmark, which itself is difficult to identify, how can it serve as a good landmark?
Yeah. Right.
Now see the nerve below.
Yes. Very clear.
I will make it more clearer. See now, just above where the digastric inserted, just above and deep to the anterior border. Can you see?
Yes. Yes. Now show the distinct measurement from the this tragal pointer.
Yeah, both I am going to show. See the nerve main trunk.
Yes. Clearly seen, sir.
Very clear?
Yes.
Very clear.
Yeah, let me make it more clearer and then we'll see both our landmarks. So basically you have to work between these two landmarks to get the facial nerve, rather than going here and there. See the main trunk. See the main trunk? And
Good.
now it is dividing into. See this.
Brilliant.
Can you see,
Brilliant.
Ashish?
Yeah.
Beautiful.
Yeah.
I thought you are sleeping.
And very no, I'm watching. I'm just eating some ice cream.
Bipolar section. See, there are a lot of vessels in the vicinity.
Dr. Girish Umredkar from Bhilai is asking, in facial nerve anomaly, can nerve come more lateral and get damaged?
In facial nerve?
Anomaly,
Yeah.
nerve come appear more lateral and get damaged.
See, not an anomaly. Sometimes tumors below the facial nerve
Can
push it more medial. That's why I never do parotid without a MRI. We have seen this, you know.
Also in children also.
MRI will exactly tell you the extent of the disease because MRI gives details of the soft tissues. And it will tell you exactly the lesion, whether it is in the superficial or deep to facial nerve plane. See this facial nerve.
Yes.
Everything clear, the nerve, and let us go back to the landmarks which we took into consideration. See this. First of all, the digastric, number one. See this. See this. Where the digastric attached. See the end. This is the superior attachment of the digastric. Immediately above it and deep to it. See, this is coming from depth.
Yes.
Yeah.
See that?
Yes.
Very clear? Now see your tragal pointer. 1 centimeter below and 1 centimeter deep. What else you want?
Perfect.
Predictable and simple.
So this is
and replicable.
See, most of the many other times we make our life difficult ourselves.
This is simple because of the convergence approach.
Yes. You have to rely on landmarks which are reliable and see both sides. Always. We have done so many thousands of parotid, you know. It is at the same level. Very soon we are going to keep a case of malignancy of the parotid, but still the facial nerve intact and the facial nerve is involved. Now see, what a challenge.
So what are your plans for that? You will be showing the repair,
Yes, we may have to do
facial nerve is involved in the malignancy?
Yes, on MRI.
So we'll be doing the repair branches wise?
I will tell you the reason why. Because that is adenoid cystic carcinoma.
Okay.
Which has a
Satish?
high tendency for, perineural invasion. Adenoid cystic carcinoma, we all know, are notorious for their affinity for the nerves.
Yes, but I had one case, I could take it out and the facial nerve, even after radiotherapy, we could save the nerve and did a bit of,
Radiotherapy is different thing. Now see the nerve there in the view. Now my lesion is in the lower half. See this, the disease is there in the lower half. Can you see?
Yeah.
See now, the lesion is in the lower half. So I need not to dissect the upper branches of the facial nerve unnecessarily. Okay? So we will focus only in the lower part. Now see the movement. I push my artery just superficial to the nerve. Can you see the branches? And pulling the tissue up laterally, not the nerves. See, there should not be any traction on the nerves. This movement is most important. My traction is on what? The tissue superficial to it. Not on the nerve at all.
Yes, sir.
And this at the same time protect the nerve also, as I am staying superficial to it with this forceps.
What are the landmarks in very big tumors or the revision cases for the facial nerve? Dr. Ravi from Muscat.
Revisions are horrible. In parotid, because of so much of scarring, it depends upon what kind of surgery was done earlier, how extensive it was done. Sometime a very superficial parotidectomy was done earlier, then it doesn't affect. If a complete work is done earlier, then it is a disaster. Facial nerve, we have to have a proper consent because it actually becomes so difficult to separate.
Yes, yes. So much fibrosis is there
Fibrosis
that it is really
becomes
difficult.
adherent to the facial nerve. It becomes so adherent, you cannot preserve, yet preoperative normal. That is the only problem. Everything is affected, but symptomatically normal.
Yes, sir. Sir, Dr. Samir Joshi, who is an head of the Department of BJ Medical in Pune, he's asking, did you ever have a situation when you couldn't find the main trunk?
Touch wood, not. But yes, many a times we have planned retrograde.
So what is a retrograde dissection, sir?
Retrograde is looking for the branch, one of the branch, and follow it to the main trunk.
Rather than looking for at the stylomastoid, you look for the branches and then come towards the stylomastoid.
Like I gave you the indications, I told you. Like for example, in this patient, I saw the main trunk here. Leave it. Come here. I don't go to the main trunk and follow one of the branch. See this one of the branch?
Yes.
If I go back to the main trunk, that is called retrograde.
Yes, sir.
See this? You have to follow the branch. See this branch is going? And this will ultimately take me to the main trunk. Okay?
Yes, sir.
So like here the stylomastoid region was so clear. Now had I been having a case where the tumor was right in this region, how would I identify the facial nerve so easily? Then it would have been, the landmarks would have been changed, affected. The facial nerve could be deeper, superficial, I don't know, whatever. In that situation, it is better to go retrograde.
Okay.
Similarly, in this case also, we could go retrograde for the region of the case because it is limited to the lower pole.
Also, Satish, when you are doing crossover facial nerve repair, then also you have to look for the branches from that side.
Yeah, but in crossover, madam, see this. These are the branches going. See so many branches.
Yes.
I can see 10 branches here.
Yes.
Running towards anteriorly on the mesenteric surface. See this? Can you?
Yes, we
now,
can see.
As you go anterior to the where the mesentery ends, you will find 50.
Okay.
You will find 50. So now what I will take for the cross nerve graft? Not those, because there is extensive network. Even if I damage 2 branch here, take for the cross nerve, the rest of the branch are forming network there, so ultimately it is not going to affect the function.
Not going to cause any loss.
So you have to take proximal one rather than the distal one.
Okay. I understand.
What my
Just
point?
close to the anterior margin of the parotid.
So that will not affect the function.
Yes.
Sir, what suction tip do you recommend when working near the facial nerve?
Depending upon which area you are working.
Okay.
Depending, you are in the ear, working in the ear. At what area you are talking about?
At this area now.
This area, why need suction?
Any time will you use suction?
Yeah, sometime, but on the face here, like some bleeding or anything comes, if I use a suction, first I will put a gauge piece and I'll suck over the gauge piece.
Yes, gauze is more handy here.
Rather than directly sucking on the nerves in the bed.
Okay, sir.
That may injure the nerve. See, it is so richly vascularized. In parotid, most of the injuries are after identification, either due to traction or due to management of bleeding. See this, all the small branches. See this, let me increase the magnification. Can you see?
Yes, sir.
So many branches.
And every branch is to be saved very delicately and gently.
And you imagine the so-called head and neck surgeons doing it naked eye. How can one see?
Slightly zoom out the picture and show it, where you are working and how you are separating the parotid.
Yes. So now this is my lesion in the lower pole.
Yes,
You can see.
you have separated from. Okay.
Yeah, I have separated from the critical areas completely. See my nerves going anteriorly there, the marginal branch. Can you see?
So we would like to see the parotid duct also.
Parotid duct cannot be seen like this. Why? First of all, okay, let me tell you the reason first. The parotid duct, there are certain characteristics of this, peculiarities of this parotid gland. This superficial lobe, which is a, it's an imaginary, division between the deeper and superficial lobe. This is not anatomical division.
Yes.
So majority of the parotid is superficial part, 80%.
Okay. Yes.
And 80% of the saliva is formed by the deeper part. Got my point?
Okay. Yes.
The parotid gland, saliva is mostly produced by the deeper part. So when you do a superficial resection, you don't see the duct. Duct is deeper to the facial nerve branches. See, these are facial nerve branches. These are all facial nerve branches. Duct is deeper to facial nerve branches because it emerges from the deep part of the parotid. So
And
you will never see duct.
It is hidden beneath the buccal branches mostly.
Between sometimes there are multiple buccal branches, many a times. There are multiple branches, buccal branches, there are so many. So it is deep too. And the pathology like stones in the parotid are very challenging, I tell you. Nowadays with the
siloendoscopy or
with siloendoscopy you can remove only proximal duct stones. Proximal means towards the oral cavity.
Close to the duct.
But the bigger stones, see this now. The bigger stones you cannot remove through that, you will end up damaging the duct. But still we take the help of siloendoscopy. What you can do is, for the bigger stones, you have to go by the open approach. First of all, by this parotidectomy approach. Go anteriorly because you can palpate the stone now. The duct is otherwise, the normal duct is collapsed, very small. It is not, it is difficult to identify. But once it is stone, it is dilated, you can palpate also. And through the siloendoscopy you put there, you will find the trans-elimination. You can easily locate.
Yes, that makes it easier to identify.
Yeah, otherwise difficult sometimes to identify. Otherwise you have to use the intra-op USG.
So you give a smaller incision for that when you are doing open approach?
No, the same parotidectomy incision.
Okay.
See, I am taking the normal cuff of parotid around this tumor.
Yes, sir. Yes, that is very important.
See my all branches.
Beautiful.
See my all branches I have kept below it, and this is something, the vein now I am finally going to take.
Retroventricular vein this is, can we see that?
It's the posterior division. Posterior division, and that's it.
Many queries about retrograde dissection. Which nerve do we follow this is? It is safest nerve.
Any. You can use cervical branch, buccal branch, you can use mandibular, any. See, ultimately any branch you follow, it will take you. Now, depending upon where the tumor is. Like suppose this patient has a tumor in the inferior part, then while I will go for the frontal and zygomatic branch, I will choose one of the lower branch only. So depending upon the size of the tumor, I have to choose the branch accordingly. See now the branches in the lower pole.
Yes, sir. Yes.
So many. See this. Let me increase the magnification. How many are the branches? They are otherwise not visible. Naked eye you can't see all. See this? The network.
Yes, very clearly seen.
Network. See the network of branches. See this?
Yes, sir.
So many, hundreds of interconnecting branches. See this carefully. Yes. Hundreds of interconnecting branches. It's a network, pure pes and serinus.
Yes, sir.
So the bottom line is you have to use microscope if you really want to give good result in parotid, patient oriented, Otherwise,
So what is your say about palsy post-operative due to the traction of these nerves?
yeah. So, like Ashish mentioned in the beginning, facial nerve monitor. First of all, your surgical technique will decide how much you are injuring. You have
Yes,
to
sir.
be following the atraumatic, like I mentioned several times. And second is the facial nerve monitor. Any time the nerve is stressed too much, the monitor will warn you. Stop.
Usually it takes a few months to get normal level.
To recover.
Yeah, if it is a neuropraxia, it is recover. It depends upon what kind of injury you have given. That you cannot appreciate at the cellular level by seeing the nerve. See now, only we remove the lower part. We didn't even see the upper C division. Here it is. See that?
Yes.
And now we will reflect it back. So patient will not have any, ugly looking depression or anything in this region. Okay.
Yes.
Sometimes when you do a total parotidectomy with a huge tumor and you get a good depression here, then you may have to rotate all these muscles, any of these muscles, and put some free fat or something. Lot many ways to reconstruct that depression, and that is important. See, nowadays patients are more concerned with the cosmetic aspect rather than disease. Many patients.
So there's a question from Nigeria. Dr. Foster Orji is asking, what do you do in cases where the tumor is huge and hugging the pretragal sulcus with much bleeding during the dissection of facial nerve?
Yeah, the same way. You have to be careful. It may take little longer, but you have to define the planes. You have to find the planes. You have to work in the planes. Yeah, with the parotid, every case is not same. There are so difficult situations. And the most difficult is tumor adherent to facial nerve. And then according to the histology, you have to take a call. Now see, the most important thing I always emphasize, with your flap raising, don't go anterior to the parotid. Can you see?
Yes.
You can end up damaging all these nerves. The whole purpose will be defeated.
Beautiful, Satish. Absolutely brilliant.
So raise the flap anteriorly until the parotid anterior border. If you give it to your junior colleague and he raises flap, it doesn't stop.
Now Satish, show us the coaptation when we do.
Yeah.
For the cross nerve, up to where would you dissect? Because
yeah. That up to the zygomatic space, up to the buccal space. See this. You have to go further anteriorly. At the anterior border of this masseter, no, you will find the parotid duct and the zygomatic major muscle, and then the buccal space. At that space, there will be huge neuronal plexus.
Okay.
To find out everything there, this is just for visualization that there is a plexus. And then you have to choose either this or one another, two branches. Always use two branches. And divide your sural nerve into two branches to coapt them.
Okay.
Satish, which one do we pick? Which one shall we pick? The thinner one or the thicker one?
As thicker as possible, but not the distal one, proximal.
Okay.
Here. Because
so you make
if you damage this branch, if you damage this branch, buccal branch, go anteriorly, they'll have a lot of anastomosis. So that will regenerate. It will not leave any deformity. Okay?
Okay, let's go to the other one.
So the next is ready. That is a faciomessetric anastomosis. Though you have seen in the cadaver today. So nothing new. So what we'll do, we'll see the main trunk of the facial nerve. Follow the branches, upper trunk branches, define them, and then following the landmarks, that triangle.
Sir, many are asking a similar type of question. What precautions will you take if to remove a deep lobe tumor?
Precautions what?
To dissect, to remove a deep lobe tumor, what precautions will you take?
Deep lobe tumor. Deep lobe tumor are always challenging, and according to the size and the location.
Usually what
according to the size and location, according to the size and location. ये लाना इधर, ये आवाज नहीं आ रही.
You keep separating the branches and putting it in, we cut a
Let
long
me tell you
strip
protocol for the
gloves.
Let me tell you protocol
gloves
for the deep lobe
material.
tumors.
We take away the fingers of the glove, create a strip, and keep lifting the branches of the facial nerve into that, and keep separating the deep lobe from the facial nerve branches, and then remove it. So facial nerve branches are to be separated from deeper lobe, and we place a sleeve of facial this gloves which we wear and lift it up to separate the deep lobe. So we have to be careful, not causing much of the stretching.
Hello.
Satish sir? Yes
Hello?
sir. Yes sir.
यार वो ला दो ना, वॉइस इधर नहीं आ रही. तुम क्या संदीप कर क्या रहा है? Hello.
Yes sir.
So regarding the deep lobe tumors, first of all, according to the tumor size and location, you have to choose the approach. Many of the deep lobe tumors extend deep in the parapharyngeal space. And then you have to change your approach lower down to the transcervical approach. Otherwise, the regular staying in the parotid, you can do a superficial parotidectomy approach. Or many times you may have to divide one of the buccal branch to get the tumor out. So deep lobe tumors, you can identify pre-op, that is always better, because the chances of facial nerve injury are more in the deep lobe tumors. So that's why the imaging is very important. MRI can actually tell you 100% that where the tumor is going. आवाज इधर आए.
Do you keep drain post-operatively?
It is corrugated for a day or two. ये भाई.
दिख रहा है.
चल रहा है. Corrugated drain for a day or two. Anything else?
Sir, questions from there are a few questions from South Africa, Pakistan. They're asking, do you have any experience with the loop?
Loop? Never.
Instead of the microscope.
We are ENT surgeons. We are used to microscope. What is loop? Loop cannot, stand compared to microscope. Nowhere. These are the, the people are finding the ways to get away from microscope. Because they're not used to microscope.
I also feel that. You're right. And whereas microscope is one of the best equipment we have.
Yeah.
There are many questions regarding parotid surgery. I think that we will discuss in our next. There were so many questions regarding the parotid fistula, how we can treat it. That we can discuss
fistula,
next case.
Simple.
Parotid day. Yeah. Now questions on facial nerve only.
Facial nerve. So many questions. That's why we will take it next time.
Pressure dressing, injecting hypertonic saline, warm saline injection in the fistula, pressure dressing. All those things will result in healing.
How important is this facial nerve monitor in your practice? Means when you recommend to use it, or
it's always better. Always better to have.
Most importantly, Rajeev, it is after the procedure is over, because I use them for atresia surgery.
Yeah.
At the end of the drilling, at the end of the procedure, if you get a good impulse on your facial nerve monitor, you don't wait for the anesthesia to come out and see the smile. You sort of are assured.
So another use of this monitor is when we are repairing the branches on the face. Which branch is having the nerve impulse that can be saved, which branches which is not showing this can be repaired with the graft. So monitor can check it for us.
So what is the best radiological guide to find out facial nerve anatomy? Means any congenital anomaly, or how we can find it?
In atresia, I say?
Yeah, atresia.
Atresia, there is a very standard imaging protocol. And in fact, like Satish was talking about the distance from the round window, I use the round window as one of the landmarks. We have got 5 segment measurements. And really, we don't need to know the course beyond the incus. because our atresia repair restricts to mobilizing the ossicular chain.
Yes, yes.
So the round window and below, it does not really come in the way of our atresia repair. So anything, so long as you have an incus in the body of the incus, and then you have the round window telling you what is the distance posterior to the round window, I think that is
CT
enough.
also
So
guides
we are
us,
only doing CT.
Ashish.
We are only doing CT study, yes.
CT, yes, CT guides us.
Only the CT studies, that's what we do.
Yes, yes.
But we do use the facial nerve monitor in every case.
That is a must, I think. Even in implant is recommended nerve monitor in all the cases.
Yeah.
Dr. Sanjeev Golar is asking what lens are we using for this microscope?
What lens?
250. Huh?
Hello?
Satish, I believe
Hello?
it will be 250 or 300.
Hello? Can
Not
you hear
400
me?
for sure.
Can you hear me?
He has actually 300 mil lens.
I
Hello?
think
Can you
300
hear
could
me?
be.
Since I have
It is
250
easier for the assistant, I think. Then there is more place for the assistant, but we'll ask him that question.
Hello?
At my place, when he comes, he uses 250.
Okay, we'll ask.
He is very close actually. Sometimes.
Yeah.
Can you hear me?
Yeah.
Sir, what is the lens of the for the microscope that you're using?
I'm using Vario. So it is a varioscope, you know. So
No, lens. Focal lens.
But yeah, he's got the.
Yeah. So I was using over 400. You know, it
400.
was
Over 400,
varioscope, and
okay.
I was using highest so that I can show the minimal magnification.
Dr. Jeevan Vedi from Nagpur is asking what is the relation of saliva production with cut ends of parotid?
Saliva production with
Cut ends of parotid.
what is the?
It's about the salivary fistula only. Cut ends of the parotid.
Yeah,
Will they still keep secreting, which will not go into the
Yeah,
duct?
it gets fibrous. Cut end get fibrous. That's why sometimes the fistulas form, which ultimately get fibrous with pressure dressing.
Where are you?
Yeah, we are starting next one.
Okay.
So this is a young lady who had undergone a transtemporal surgery. You know. Hello.
Yeah.
Yes.
Yeah, there.
Hello.
Yes, sir.
Hello.
Yes, sir, we can hear you.
हेलो एक बार बताऊं कुछ नहीं सुन पाता कुछ समझ नहीं सुनो इसको कवर करना है इसको
Hello, we can hear you. I think he's not knowing that we can hear him.
Hello.
Yes, sir.
Hello.
Yes, sir.
Yeah. Am I audible?
Yes, very much.
Connect karo. So this was a patient whose some lateral skull base surgery was done. Some transtemporal surgery was also done. And now she came with a facial palsy, grade 6. So we don't have a proximal end. So the plan is very simple. Faciomessetric. She was not ready for the cross nerve. इसको क्लीन तो कर यार तेरे पड़ेगी पहले hello
Yes, sir.
yeah are you getting the microscopic picture
When was the surgery done?
a month back
Okay. So, what is
Are
the
you getting
grade
the
of
picture?
facial palsy?
are you getting the picture
6 is hello.
hello
Yes,
The complete palsy. Yeah.
Dr. Rashi, so there's a question for you. Sanjeev Golar from Nagpur is asking, in atresia, the medial wall is bony and the ossicles are intact. How you approach?
In atresia, the medial wall is
Bony and ossicles, with the bony wall intact and, and the ossicles
so
intact.
that's the surgery is all about drilling away that atretic plate. The entire
Gila de Goch. Gila. Hello. Hello.
sorry.
Hello. मोटा प्लास्टर लगा
Hello.
राकेश यार hopeless.
Yes, sir.
Hello.
Yes, sir.
Am I audible?
Yes, very much.
Yeah, you were asking something that time I couldn't.
No, that question was to me about atresia.
Okay.
Yeah. So it's always the malleus which is engulfed in the atretic plate. So you have to drill around the malleus and mobilize it. That's all. It's not.
What about the recurrence? Does it again become stenosed or what?
We have a very different technique now. We don't make we don't actually line the canal with skin, free skin. The take of a free skin graft with the in atresia is very, very poor, less than 20%. Okay. So our technique is very different. We use the skin from the deformity and suck it inside.
Okay.
So then there is no restenosis. Okay. So we have the skin from the deformity, we apply a vacuum and it gets sucked in. And we have the measurements on the CT scan, typically about 24 millimeters. If it can go in, then...
Hello.
Great. Then someday we'll see
it's a very new technique. Someday, hopefully, we'll show it to you.
Yes.
Hello.
Yes, sir.
I have little modified incision and everything different for the regions I tell you. See, this some transtemporal surgery is done. You know, I don't want to go behind, and for that matter, we don't need to go because I just have to find out the facial nerve here, and then we'll go anteriorly. There is something was done earlier. I don't know.
So there's a question from Iran. Dr. Abdullah is asking, during this parted surgery, if there is bleeding near the facial nerve, will you use an adrenaline soaked? Is there any contraindication using adrenaline soaked gauze?
As such, there is no contraindication for that matter. So there is no contraindication, but adrenaline swab we use sometimes in the depth in the temporal bone somewhere. But
he's asking about the parotid.
Parotid, no adrenaline. I'll use bipolar around if required. I can use harmonic scalpel. We keep ready.
Dr. Vijay Jadhav from Virar is asking about the lens of microscope. It's 400, as sir said.
What?
The lens of the microscope, it's 400, as you said.
No, it's varioscope. It's not fixed. I keep changing.
Okay.
Vario microscope, they have it means adjustable focal length.
Yes. See the name Vario. It has a varioscope.
But otherwise, we since most of us have 400 and 250, so 400 is I think enough. Both 400 we use for laryngoscopy and laryngeal surgery, so we can use same one for this thing. So most comfortable is 300, where distance is less, adjustable length.
And see my incision, I am taking it up. We have shaped this area, so this will be hidden under the
hairline.
Yes.
Okay, hello. Now the first important thing is to identify the facial nerve.
Yes.
I am not worried about lower exposure much because you don't have to do anything with the lower trunk.
Yes, yes.
You have to just focus on the main trunk. Only on the main trunk and the upper division, of course.
So after this good surgery, how much recovery you expect after 6 months or 1 year?
The recovery starts in 3 to 4 months.
Yeah, means after 6 months or 1 year, how much you expect?
Yeah, quite good, quite good. You know, my best recovery I find is a grade 3.
Oh, good.
The next two cases are actually small cases. The one is a DLI transaction under local anesthesia. And another is a static slings for an old man.
Can parotid surgery be done under local anesthesia? That's a question from Chennai, sir.
Generally, we don't do. I've never done. A lot of papers I have seen, yes. But see the kind of exposure you need, the repeated hemostasis, so many things. Doing under local is a big task. But I don't deny. I don't know. That is the level of the zygomatic arch.
That of the previous case here?
Pardon?
No. So what incision did you take here?
He modified it a bit, he said, because it didn't go more posteriorly. It doesn't need to go inferiorly.
Okay.
See now what I am palpating again and again. This is my zygomatic arch here. That is my zygomatic arch. This is my condyle here. And see, this is my triangle going to be.
Yes, sir.
What are you doing?
I'm just, see, I have not gone below onto the sternemastoid. So I'm just looking at this parotid tissue here, how deep I am. Just superficial. Because anteriorly here is the masseter starting from here. Just here. See the branches.
Yes, yes.
Can you see the branches?
So many want to know the setting of your monopolar cautery that you're using.
Minimal, not very high.
First of all, he has a Valley Lab. It is important to know the make also. You cannot have any cautery of any make. You have to have really high-class cauteries.
Yeah,
when you do this. Satish?
Cautery has to be very good. See, most of the time I use it as spray. See this?
This is a spray mode.
Okay.
Being a head and neck, I have a habit of using this, you know, monopolar more and more.
The tungsten carbide, not tungsten, what is that? Colorado tip, I think it's a very, very elegant tip.
Yes, yes. I have seen you using a lot.
I just use that for everything.
Yeah. I have seen you a couple of times. You use a lot. I use that in the nose sometime. Now, with this not a regular approach, the first task is identification of the main trunk, you know.
Yes.
So I'll go by my
Tragal pointer.
Tragal pointer now. Tragus is gone because of this cul-de-sac closure is done. See this?
Yes, sir, right.
Tragus is gone.
Yes.
No. Bipolar. So I want to find one of the branch first. In parotid, one good branch you find, you can trace the main trunk and trace everything. You know. See everywhere some tumor. See here. See
Yes,
some.
yes.
It was. So everything is. You're not on a normal situation anywhere. Vascularity, everything aberrant. But still we'll find the main trunk. No issues. Bleeding more than usual. चल माफ कर मेरे को दे चल section.
This is what he was saying. Suction over the gauze.
Yes. Point.
Suction on the gauze is safer. Can you see?
Yeah, we can see.
Yes.
See the nerve branches?
Yeah.
See the main trunk of the facial.
Yes.
Coming out from here. That is the main trunk. See this?
Yes.
Difficult to find.
Finding in these abnormal situations is always difficult. Now we have a facial nerve in view.
Yes.
See this?
Yeah, we can.
See the further branches going anteriorly. Can you see very clear?
Yes.
Yeah.
And this is the main trunk. So first task was to identify the normal nerve.
Is it a little too slender than normal?
Little.
The main trunk, yeah.
Yeah, sometimes it is. Yellow. Yeah, see this now.
Now, the main trunk is.
Now that is the, yeah, okay.
Now,
Robust.
Yeah, now.
Yes,
So it bifurcated much earlier.
Yeah. Yes. So now I'm going towards the tip.
If you compare the rate of recovery compared to hypoglossal, did you find mesenteric nerve earlier recovery?
Yes, yes, much earlier. See, the
He said
anastomosis
no.
is so close.
Close, the fascicular arrangement is said, and the electrical power that goes through for 3 reasons.
See this, the main. I can bring it any time, okay? When I find the mesenteric, I will rotate it, okay? Now I've got it. Now.
I don't think Satish has done a hypoglossal in the last 7 years. I think somewhere he mentioned that. He's given up.
Totally stopped.
Yeah.
So much morbidity around actually. Main thing is.
Hypoglossal, the post-op is bad. Mesenteric, you know, supplies to the most powerful muscle of the face.
Okay.
Masseter. The motor supply is very, very robust. Short, sorry. Yeah. Yes. See the upper division?
Yeah.
Okay.
0.16 centimeters anterior to the tragal anterior margin and 1.06 centimeters below the anterior margin of the zygomatic arch.
Section कर ले.
Did you whisper something, Madhuri?
Yes. Hello?
Yeah.
Hello, can you hear me?
Yeah, I can hear you.
Okay, Ashish. It just was talking about 2 more landmarks for identifying the masseter nerve. One, it is 3.16 centimeters anterior to the anterior tragal margin and 1.06 centimeters below the inferior margin of the zygomatic arch. So that along with subzygomatic triangle, yes, two types of landmarks are there.
Yeah. Okay.
Yes.
Roughly you can say 1 centimeter below the zygoma.
Inferior margin of the
and
zygoma.
3 centimeters in front of the tragus, then
Yes,
it's okay.
roughly.
Yes.
We see these are the landmarks which are difficult to take into consideration. Who is going to
measure?
Yeah.
Many are requesting you to say once again the details of this patient.
Okay. This patient has undergone a transtemporal surgery for some tumor and has a grade 6 palsy. Okay.
Since how long?
Almost a month. Now see, this is upper division.
Yes, sir.
And this is the frontal branch or the temporal branch, you can say. See how superficial it becomes. See, as it goes into the superficial fascia. You see this?
I have damaged it once taking a TP flaps.
Yes.
Oh, yes, it is very close to your TP
low
flap.
hairline case. Yeah.
Now, the most important here is this branch. That is the most important I wanted to see. See this zygomatic?
Yes.
That is most important. And we have to preserve this. See this zygomatic. Madam, your triangle.
Yes, subzygomatic triangle. This is the inferior line of that triangle.
This triangle was initially described by a surgeon from Thailand, you know.
Yes.
And he published a huge series on this.
Suddenly, this technique has emerged over last, 7-8 years only. Before that, they were not, starting, they were only joining it to the buccal or the zygomatic branch only. Then slowly people started doing, like you also showed that.
See the ease with the hypoglossal. The problem with this technique is the difficulty in identifying the masseter and going so deep. Ease with the hypoglossal is, had this been a hypoglossal anastomosis, I would have been through by now.
Yes, you're right.
That is so fast.
Yes.
So difficult.
Because the incision line is also same. We could have, it had been faster, but this is perfect technique. This is the perfect branch.
And you
this
see,
is perfect now.
See, there's so many branches. Who says there are 5 branches of facial nerve? Ashish? See, n number of branches here.
Yeah.
Yes.
As you go distal, there are more and more branches. These are not small nerves. It's very good branches.
Very thick nerve. Yeah, very.
Now this is my level of the zygoma. I can see here. Palpate here. All the time I was palpating. Entire thing is deep to these nerves, So we have to create the space to go deeper.
Separate and mobilize them, get them out of your surgical.
Yeah.
And it is almost as deep as the thickness of the masseter muscle, so quite deep.
Yeah, quite deep.
Yeah, he said it's to the
between
lateral
the middle and the
border of
deeper part.
pterygoid.
Between the middle and the deeper part of the masseter muscle.
Yes, it enters the muscle from that side.
Now,
And the glistening fibers of the masseter muscles at times, literally, they look like the nerve only, mimic that. But because it is quite deep, so that way we come to know that they are quite flat, whereas they don't give the look of a nerve. But still we can confuse it while dissecting. So this dissection Dr. Satish is doing is in the direction of masseter nerve, separating the fibers of the...
I am in the masseter muscle now.
Yes.
Yeah.
That is my zygomatic arch level, which I am defining.
Inferior margin.
This superior.
Which is the superior margin? Okay.
Yeah, this is zygomatic arch. Superiorly.
Oh, yes, I mean inferior margin of the zygomatic arch.
Inferior margin of the zygomatic arch. But here is superior limit.
That is the superior limit. So you will feel the sigmoid notch also in between to see where.
Yes, then only I will.
Between the coronoid and the condyle.
Yes. This is my condyle.
Yes.
This one. That is my condyle.
Perfect.
And see, this area is not free of vascularity.
Yes, too much vascular.
This muscle is literally vascular. Every time you have to be careful. Now I am on to the muscle.
Yes, you're working through the muscle fibers. We can see.
Yeah, I am enlarging my axis.
Almost 1 centimeter deep to the outermost fibers of the muscle.
Yes.
So what is your plan of action in this
So just
surgery?
we'll take out the muscle and suture to the facial.
Suture it, finish.
The masseteric nerve. He'll get the masseteric and he'll do the anastomosis of the masseteric nerve with the main trunk of the facial.
So what he showed in the this cadaver dissection today, similar.
Now,
And so what about the post-operative physiotherapy that you were talking about?
Yes,
Will you tell
yes.
us?
These patients require, these masseteric one require less as compared to the others. But yes,
they're asked to, do action together. First, we do both actions together, bite and smile. Okay. Slowly, both things happen through masseter nerve. Then we tell over the months to segregate the two actions. So slowly, the patient is made to learn how to segregate bite from the smile. So that way, slowly over the month of, almost 3-4 months to 1 to 2 years it takes.
See now my landmarks now. Can you see the zygomatic arch?
Yes. Yes.
And here I can feel my mandibular condyle. See this?
Yes. Yes.
So now I will go in this angle like this.
Yes.
In the deeper plane.
So when they have to clench their teeth when they want to smile, because that's when the
yes. Slowly, but this because there are other muscles of mastication are there, so it takes very less time for the patient to develop and segregate. Whereas in hypoglossal nerve, it is quite difficult at times. You have to push on palate to get the facial nerve action.
Hypoglossal
Slightly
is more
difficult than that in the masseter.
Okay. See now I am going to the depth of this muscle.
Yes. Can we take it on a higher magnification, Satish?
Yes.
One.
Yes.
Yes, very good. Now,
more.
Better. So still the glistening fibers have not appeared, Satish.
Yeah? No. That is still in the depth.
Still, it is in the depth. Yes. Now they are appearing.
Yeah.
Dr. Sandeep Naidu is asking a question to Dr. Ashish Bhunkar. Dissection of parotid is easier in normal parotid or diseased?
Normal.
Who is asking?
I don't do parotid. The master of parotid is also Ashim. 15 or 17 years back, he used to do it under microscope. I don't do parotid surgery. Sandeep?
No. And I can see my nerve coming into the picture very soon.
The masseter artery is also along with the nerve.
See, this is some vein. Yeah, retractor. Now I can see retractor. So इधर कर दो यार. You can push the microscope. Yes. Yeah. Retractor. एक retractor ना छोटा on this side.
It is always more deeper than you imagine. Always in all the cases.
Yes, it's very deep.
Very deep.
More than a centimeter, sometimes 1.5 centimeter.
Yes.
Heady.
See the nerve.
Yep. Beautiful.
Amazing. See this?
Yes.
I will get a full length now.
Yes, good, thick, and
yes,
nicely visible.
This is the nerve. See this now?
Yes.
See, if you have a proper landmarks all around, see how much time I was giving to the landmarks. See
yes, when you were identifying the nerve.
See my all facial nerve branches are retracted. See this?
Yeah.
See this?
That's why it was important to mobilize them. Identify, mobilize.
Yes. And see, I showed you the zygomatic arch bone, bare bone. How could reach? See all these branches above. Yeah, these are the branches going up. See this? Frontal. So separating that, go deep to the zygomatic arch, your one of the landmark. Similarly, this was your landmark for the condyle.
Condyle, yeah.
And no branch is coming in the way. See this?
Satish?
Yeah.
Another thing can be done if the maximum length is needed. You can, shift the zygomatic nerve above and start dissecting from below also to extract the maximum length. Can that be done?
You cannot lengthen the zygomatic. It will be gone. That is the most important nerve, madam. Zygomatic is most important. See what a superb nerve it is.
Centric, slight centering is not.
Yeah.
Yes, much better. Focus.
Focus.
Focus depth.
Is there like a branch there?
Yes, small branch.
Any preoperative steroids or anything do you give to these patients?
No. See this now.
Yes, lovely.
Beautiful. No, it's not pre-op paramita, it's post-op steroids.
Yeah, but someone's asking about pre-op as well.
Oh, no.
Jhaku bula le. Jhaku. See now. So according to the length needed, I can go more and more anterior and get the nerve length. Okay. So now before that, I will bring my facial now. So see the field is good.
Yes, sir.
Yes.
And it is very, very deep. Now this is our facial, Let's see how much of the length we need. I didn't cut the facial here earlier. I told you when we bring the mesenteric, we'll get. Yes.
As far deep as the possible with the facial nerve, because even few millimeters of tightness or tension can cause, lesser good results.
Yes.
So as far deep into the stylomastoid foramen as possible.
Scissors. How's the picture?
Yeah, wonderful.
I think that lens is also again needs to be.
Length is very important because any tension and we will lose the chance of improving on the facial nerve.
Now, good?
Good.
Facial.
No. This is correct, yeah.
Okay.
Don't put patli.
You decided where to cut it?
Yeah, at maximum. I am not going inside the temporal bone, otherwise I can get extra length. See that branch? That branch comes there. Yeah. हटा कोई बात नहीं आने दे इसको उठा नाव को उठा.
What I do is I take a silk thread and measure the distance how much is required between the two nerves.
उठा इसको.
But usually it suffices.
कट गई. छोड़ दे. See this now?
Yep.
This is the length we have got. Bipolar there. Bipolar. छोड़ दे. See, this is the, What is this? Retromandibular.
Retromandibular vein. Yes.
No? And this is a little small cervical branch going along this. I can take this.
Sacrifice it. You have to mobilize the trunk.
Yes, I don't think it carries any value.
Yes, this step is important because many a times you don't get the length unless until you cut this branch.
This is to get additional one. You can get.
Yes.
You can mobilize from the temporal bone, no?
You know, Satish, it
Anytime
causes
you can
stretching
mobilize from the temporal bone. But here you
Yes.
cannot. That's
Yes.
why. See?
So now almost 1 centimeter.
See, this is
length
my
has been
mesenteric
extra.
below. See, this is mesenteric below.
Yes,
Oh,
sir.
yeah.
Yes. Yes, sir.
Yeah,
See
very,
the
very
facial.
clear.
See this? So simple anastomosis would be.
Yes, sir.
This is why I brought the facial. Had I not got the enough length of the facial, I would have
Further
mobilized more
mobilize the
mesenteric.
mesenteric.
Yes. So I told you how much to mobilize mesenteric depends upon how much the length you get. See now.
Good,
This
good
will
length,
be-
good
this,
enough.
This will be tension-free anastomosis.
Yes, yes.
Absolutely.
See the epinurium and see the fibers.
Yeah, super, super.
Very beautifully visible.
Zoom in little bit if possible. If possible.
Pardon?
Zoom in.
Zoom in.
He will do it when he's suturing. He will show it anyway.
Yeah. That is.
See that?
And
Super,
suturing
super.
this nerve is not also an easy task. It needs training.
Yes.
Using a 8-0.
Yes.
8-0, no, Satish? What do you use?
8-0 nylon.
8-0 monofilament, yes.
Chalo. When I'm, suturing the ansa, it is 10-0. Such a thin, See the nerve below?
Yes, beautiful.
And see the nerve here. It's reaching right there.
Yeah. You can do an end to side without cutting it.
No. Yeah. इसको यूं नहीं छोड़ो यूं पकड़ो Madhuri madam,
Yes, sir.
I hope next time you'd be doing mesenteric.
हाँ मैं कर रही हूँ सतीश तुमसे ही सीखा था और फिर वो डाके बहुत बढ़िया रिजल्ट्स हैं. They are giving results in almost 6-7 months. I could get the first twitch. They're really good results.
So there's a question. Once you do a translabyrinthine acoustic neuroma excision, if the proximal part of the nerve is not accessible, would you consider this procedure at the same time of the primary surgery?
Yes, same. That is ideal.
That is ideal. Yes, you're right.
ऊंचा करो ना बोला ना ऊंचा होने वाली LA don't do anything, I will do. बुला ले बस उसको खाली. Yeah, see now I will cut the desired length from the depth. See, mesenteric artery is running just deep to it. This is the vein here and artery is deep to this nerve. See this?
Yes, sir.
सेकंड होता है
कुछ रख नीचे
नहीं कितने रख लिया था
पेट पर नीचे रखो
अरे बाप रे
नीचे रखो lot of people use glue also.
Yes.
And it works, but here if you
But
can
I think you put 1 or 2 sutures, huh?
Yeah.
No? That will be because the depth difference is there. It is quite deep and this is superficial. Any displacement can cause,
diameter also. I think it's the
little difference.
Yeah.
But these axons in the masseter have a very powerful impulse.
They are the elephants, yeah.
See this diameter here and see the diameter and the depth is good.
Satish, what do you have to say about the spatial orientation of the fibers out of brainstem? Do you feel there is some specific spatial orientation of the nerve fibers in the facial nerve for specific muscles?
I tell you. I know at one place I read at the second genu of the facial nerve, vertical segment begins where? You know, the anterolateral fibers, anterolateral means towards the middle ear.
No, in the tympanic part you're telling?
No, mastoid, beginning of the mastoid part.
Okay.
They represent the forehead.
Yes.
And the zygomatic fibers, the anteromedial represent the lower lip.
This suturing is a piece of art, okay, folks? Please watch.
Yes.
Very difficult. You can't even see the needle. You keep searching.
No issues. It will.
You really need both the hands equal control.
And another thing is, Satish, you are doing epineurium to epineurium or perineurium to perineurium?
Epineurium,
what is your take?
Epineurium.
Epineurium to epineurium.
So always the epineurial, suturing is best.
They say when it is fresh cut, you do epineurium to epineurium. But if it is a very old fibrosis is there, then the epineurium gets thickened. So strip it away and do the perineurium to perineurium suturing. In chronic old cases where the fibrosis is there. In fresh cases, it is epineurium.
Are you not supposed to cut and make it a fresh edge? You sort of
already fresh.
Both are fresh.
This one is fresh, but when it's also when it's old, you are supposed to refresh it. And in that case,
because at times nerve fibers have reduced in size and it is thickened epineurium. So we may not be approximating the fibers nicely. So either cut it nicely, expose the ends, see the nerve fibers and then do the suturing.
So ma'am, you were saying in which cases will you strip off the epineurium?
When it is an old case, this is a fresh case. Fresh cutting, we know the fibers are all fresh. But wherever there is an old, like any disease, there is a fibrosis of the nerve fiber, we have cut the ends. Then we must strip back the epineurium to see what thickness, density of the nerve fibers are there. So perineurium to perineurium seems better for that because epineurium might have got thickened and we may not be approximating the fibers nicely.
Okay.
Overall, epineurial anastomosis is always better.
Best,
See, under microscope 80.
I have done 2 hands-on courses for this, for neurovascular anastomosis.
I know you went to Bangalore once.
Bangalore, yeah.
Kar isko ghuma.
And one I did at my own place.
Did that
because they have the clip, the
you?
vascular clip they have, Satish. I don't know what they call it. It's for the vein, without suturing, there's a sort of a clip.
For the
it's a fancy device where you bring the 2 ends of the vein.
For nerves or what?
No, not for the nerve, for the veins.
Those are the bulldog clips.
No, not bulldog clips. You apply the bulldog clips, but instead of suturing, there is I forget the name. So the 2 ends come together and they get sealed off. There's a very fancy device which brings them and they sort of fold up. They come together like this, and they sort of a clip goes around it. Very easy. Takes 5 minutes actually.
Really
no
good?
suturing required.
Is it really good?
It's very fast.
No. Did you use in your practice?
You will do it for the vein to save on time.
But did you use any time in your practice?
Not in my practice. I practiced it in the workshop.
So on the nerve or vein?
Vein.
Okay.
It's a vascular clip.
You've not tried on the nerve?
No, nerve you can't do it. It's just to get the lumen.
Okay.
So you have to evert the lumen. Evert it. There are 2 ends. You evert them, this end, and then you bring them together. And there's a clip that goes around it.
Okay, invert and then pressing both the ends on.
That's it. Yeah.
Will you put any fascia around it or anything around it?
Yeah, I sometimes use PRF, the pelvic ridge fibrin. If you want, I can show you 5 minutes additional.
In this case, maybe not needed because the sutures are so nice.
Yeah.
So when you're not sure about whether the sutures will hold.
See now the anastomosis?
Yeah, wonderful.
Yes, sir, it's beautiful.
Yeah, I will put one more. I'm not happy yet.
So we can put some soft tissue beneath the this anastomosis for as to be used as bed for vascularity.
So I'm not changing this natural bed, you know.
On
Okay,
the
it is there.
contrary, what happens is that if you try to interpose avascular soft tissue like a fascia or something, you're spending more time for the blood vessels to start coming.
Yes.
No, yes, I understand. I was talking that this muscle or the parotid tissue around it, vascular part only, not the free graft for the bed, only the surrounding tissue to give it a bed on which it sits nicely and gets the vascularity as well.
Dr. Umesh Torne from Nasik is asking how late we can do this masseteric facial nerve anastomosis. I think he is asking
The test. How much we can wait?
Yeah, how much we can.
How late means it should not be beyond 2
I
years.
mean, he's asking till how long can we do this technique? This is what Paramita he's asking.
Up to 2 years. Is
2 years.
2.5 years.
Yeah.
And there is a question from Nepal. While doing suturing, do you make 45-degree cut on both the ends of approximation?
Yeah, you can increase, you mean to say. Approximation. The question is, you can increase the opposing surfaces.
The surface area by an oblique cut.
By doing the oblique cut, Paramita, what we do is we are making maximum facial nerve fibers to face the surface.
Okay.
So that way anastomosis becomes better. So they always say cut it in a bevel shape so that maximum surface area is there for approximation.
It sounds very nice, as you can tell here.
Rohan Pandey is asking what...
Can you see the epineurium?
Yes.
Explain about cross graft in this case.
What is the?
Cross graft.
Cross graft, yeah, definite advantage. See, had I been doing a cross graft to this, what I would do? Just a minute. Had I been doing a cross graft, I would be doing end to side anastomosis to this, facial nerve.
Or what we can do is end to side with zygomatic or buccal only, because we want the natural smile only, na?
Yeah.
I'm sorry, I didn't understand, but it's okay.
See, this will give me complete covering of the perineum.
Yes.
To prevent the external loss. Yes. Now, see the complete anastomosis now.
Yes.
Can you?
How's the picture there? How's the picture there, madam?
Yes, थोड़ा और zoom करो सतीश, अच्छा दिखेगा उसको पास.
Let him finish his knot. Let him finish.
Okay. So we don't want to disturb because once thread is lost, suture is lost, you feel really.
Gone. It is, see now, secure from all around.
Yes, 3 sutures.
3 sutures. Hey, more don't pull. Cut this. This is too big. No, मेरे को this No.
Since both the nerve thickness is a bit different, one is very thick and one is very not so much. How much regeneration do you expect?
Very good. No issues because epineurium to epineurium it accommodates.
Yes.
This
mesenteric,
this mesenteric is so powerful. Input. See this now. See this now.
Fabulous, Satish.
See,
Brilliant.
Ashish all around. I have put 4 sutures, you know.
Yes.
All around you can see now.
Yeah.
Very good.
So it should
Clapping,
work.
clapping.
Absolutely. Too good.
Round of applause from.
So.
Masterful, absolutely masterful.
Amazing, sir.
So for this patient, I am quite sure she will do well with this anastomosis. Now question was adding on the cross nerve graft. What it would do, this mesenteric will give him smile, the power. See, so stable anastomosis now, even if I mobilize. See this?
Yeah.
It doesn't go anywhere because I have put 4 sutures. See this now?
Yes.
Everything, see? See this?
Yes.
See this? Mobilize all
superb.
around. So, cross
No
nerve
stretch,
graft.
it's all.
Yeah, boss, next 2 cases will finish in no time because one is DLI resection, another is, you know, the sling.
So
And
do you believe in tapping the anastomosis with fascia or something?
with it?
No.
Will you wrap the anastomosis with fascia?
Not really. I wrap nowadays in the platelet-rich fibrin, PRF. PRF, what you can do, draw the patient's blood. We have a centrifuge in the theater. We centrifuge the blood at a RPM of 700 for 3 minutes. And so only RBC, they settle down, the rest of the thing form a thick fibrin plug. It's a thick fibrin plug. Between 2 glass surfaces, we sandwich that and it becomes a membrane. So that contains the entire fibrin, fibrinogen, platelet, leukocytes and platelet having the growth factors. They are always good in, recovery. Secondly, all these patients we give nimodipine for at least 6 weeks. Nimodipine has been known to improve the neuronal regeneration. Then we give all these patients N-acetylcysteine.
Nimodipine.
Nimodipine is a calcium channel blocker.
Okay.
Yeah, it works very well, like it works in subarachnoid hemorrhage.
Yes,
Then we give all these patients N-acetylcysteine for 6 weeks. N-acetylcysteine is a good antioxidant, prevents neuronal degeneration and works well. It's all evidence-based, proven.
What about the post-operative difficulty in chewing and etc.? But since we have
Satish, sorry. So also please elaborate on if you were to do a cross nerve, what would be the plan?
Yes, that was left.
Yeah, at this in the 1-stage plan, what I would do, I would harvest a sural nerve. At the same time, go to the opposite side. I would choose 2 branches, the buccal and the zygomatic plexus branches. 2 branches, the sural would divide into 2 halves and would suture these 2 branches.
So
and the
coaptation on the normal side with 2 branches of the normal side.
Yes, and then through the tunnel in the vestibule, in the superior vestibular tunnel, I would bring it to the left side and would do an end-to side anastomosis on the facial.
With which segment now?
Facial after the coaptation.
Same.
The main trunk that you sutured just a little bit proximal.
Main trunk. Just an epidural window and anastomosis.
Okay.
Without taking the fibers.
So you would need a long length. So you would have actually put the cross nerve. You have parked it at the tragus in the first.
So what would it do? The masseter would give the tone and the power to this facial muscles very soon, in 3-4 months, and in 1 year's time when the cross nerve fibers completely innervate, the spontaneity will improve.
Okay.
You mean you would have done these to the main facial trunk, the distal end of the cross nerve graft you would have sutured now only?
Yes, first stage.
All in one stage.
Yeah. Now still you have an option. But that will be too late for the patient. That's what I was saying. Suppose now we wait for 1 year. We wait for 1 year and some part of the facial expression is not improved, like the angle or eye, whatever, single part. Now you bring a cross nerve, it will be too late. Then you have to resort to other procedures, like we had shown so many for different areas.
In such cases, Satish, hello, Satish.
Yeah.
In such cases, usually what I do is I put the gold implant as well, because it is going to take some long time. If eye is not closing, that can be done for, till the
Because you can always take back the gold if it starts working.
Take back the gold.
Now
yes,
what you
of
can
course,
do,
yes.
you can use the cartilage and do a lateral tarsal plate excision. That is much simpler, cost free, and absolutely risk free. Gold like gold, there is no question of extrusion, no question of unsightly bulge on the lid. You can use a thin cartilage, and you can use two cartilages, one on the tarsal and one on the levator aponeurosis above. So that gives enough pressure like gold. At the same time, lateral tarsal plate excision, so that will reduce the palpebral aperture, the scleral show and the corneal show. So, it works very well. Why unnecessarily waste money in gold?
So any chance of neural granuloma around the graft site?
Traumatic neuroma.
Not really. It doesn't.
It doesn't, because you have all the fibers meeting, so the chance of traumatic disrupting.
Neuroma forms when there is non-specific growth going on against a scar tissue. There is no scar tissue, so no chance of forming the neuroma.
Okay.
And those are the problems.
What do you expect in post-op cases, post-operative period, means regarding, since that muscle is gone, so regarding chewing, any problem?
Not really. Not really. I tell you, yes, your question is valid about the donor side morbidity of the masseter.
Yes.
This masseter is supplied first of all by this nerve which we have taken quite distal. Before that, from the origin till it gives a lot of other fibers to the masseter. So masseter is not denervated, and partially it is innervated by the temporal nerves as well. So there is,
and also,
we have never seen any donor side morbidity as far as the masseter.
And also there are medial and lateral pterygoid muscles. They're all muscles of mastication. So this is just a part of the whole lot of muscles. So it does not give any problem. I have not seen it.
Whoever starts doing this mesenteric enhancement would never think of hypoglossal. That I can guarantee. The kind of result and the spontaneity, you get almost close to spontaneous with the masseter.
Yes, right.
It has been proven with a lot of blood flow studies, MRI studies, and so many things. Their cortical representation is so overlapping, and this masseter is already used in smile, so you don't have to train much.
Yes, this is a natural action of the masseter muscle to add on to the smile. So that is a natural function of that muscle.
So what are the doses of N-acetylcysteine and nimodipine?
N-acetylcysteine 600 milligram a day, BD 600 milligram twice a day, and nimodipine we give 30 milligram 5 times a day. Nimodipine is an antihypertensive, but 30 milligram in so divided dosage is very, very safe. Unless somebody, an elderly cardiac patient having a contraindication to calcium blood, that's
unless until cardiac
those
problem
patients we don't do. Those patients we don't do such procedure. These are for
and when you recommend physiotherapy in these cases after anastomosis?
Radiotherapy. Physiotherapy immediately after 7 days will start. Something like we give some electrical stimulation and all those things. And in 3 months' time, when the the function starts, that requires an intensive physiotherapy by means of, because we have to train these patients by learning the facial expression by biting or by means of clenching the teeth to begin with, because the masseter is a function of clenching the teeth. So strong muscle for that, and they learn very fast.
Satish?
Yeah.
I read it in the literature that giving this artificial stimulation by TENS can actually cause more chances of skin kinesis. So these days they've stopped, using it for the stimulation. They say the physiotherapy, manual physiotherapy is more favorable.
Yeah, there was some publication, but see, this synkinesis issue was earlier with the hypoglossal. Hypoglossal means synkinesis is inevitable. You cannot stop.
That was inevitable. You're right.
So that was with hypoglossal.
The marvelous demonstration, sir. It was amazing. Dr. Bharti M from Mysore has also commented you as a craftsman.
Oh, madam has been so kind. You know, madam has been our secretary of the association and she's an amazing head and neck surgeon.
Yes.
You're very fine, very few amongst ladies
Yes,
will
he is
find
a-
dedicated head and neck surgeon.
Yes.
Madam, Farida madam, they are all top head and neck surgeons. So our next case is ready. I tell you, the small case DLI. So first I will show the initial picture of the lip. Then I will show after xylocaine, and then I will do DLI. Okay?
Is it fast?
Yes. And the next.
Not fast, I mean quick.
Yeah. And next case will take immediately.
Because my wife is threatening not to leave me, but she's going to have an affair now. If I
And the next also is a small case sling. So we'll keep the facial atta ready for next. Induce the next one also. Facial atta ready. And then we'll put a sling faster. Sling is a very good operation for elderly people. Yes.
Yes.
Yes, you were asking something?
So, sir, I am getting some comments for Ashish, Dr. Ashish Bhumkar as well. People are enjoying his sense of humor along with your
Oh, really? Okay.
But he is not in
I
the
thought
form.
you're asking me to shut up.
You have not seen in the form.
He is the best, one of the best orator of country.
Yes, I agree.
And I'm observant. I'm watching the jewelry that she's wearing. So enthusiastic. She's at home, but Parinita is wearing her pearl jewelry, and I really admire the way she really dresses up like in a very formal way.
Always dressed formally for these workshops.
Ashim and Ashish are brothers, you know. We may be different school, but our heart is same.
We are, yeah.
We'll live together, eat together, and we'll die together. Believe me.
Yes.
So the case is ready and external camera.
Next week is Strapist Carnival is there.
Yeah. We will hopefully make it very, very interesting. There will be a lot of conversations though, because there's a lot to be discussed. Besides,
Yes.
I think minimum 2 surgeries Satish is going to do. So
he's planning for 4.
वो पहन लाना. अरे camera on करो.
Even today, the main points for discussion actually, because so many things were there, so many.
Oh yeah, the electrophysiology was brilliant and
Light. Actually, we should have planned the dissection full day.
No, it's okay. This correlating, no, I think this was good.
Light on karo.
Especially this, I think the Macetric 2-7 is going to become, I think most ENTs will pick it up.
This is something I want everybody to do.
Yeah, I think so. It's very easily possible. There's no reason not to do it. And really some youngsters can make an entire career on facial nerve. There's so much more.
Yes.
You know, I went to TISA, 40 Botoxes in a day she's doing. All this DLIs and all, taka-tak, 5 minutes. Yeah.
Ashish, can you see the picture?
Yeah, beautifully. Very nice.
Dear, दांत दिखाओ. See this?
Yeah.
Because of the opposite side unopposed action. Can you see this?
Yeah.
This is pulling the lip to the opposite side down and the
downwards,
the teeth show is so much. You know?
Yeah.
Everything. And now I will put again you show again. See this?
Yes.
Now where is the DLI? I told you this is the modulus, okay? And from here to here is depressor anguli oris, okay?
Yes.
This is superficial. Under this, this I will show like this.
It's interesting, Satish, your people have shaved only half of his beard.
See this? See this? This is the area marked by DLI until the lower border of the mandible. And it goes into the lip. It doesn't go into the gingivobuccal sulcus. See, from here it ascends in the lip. Okay?
Yes. Okay.
So now my local anesthesia, this is on this side, this is paralyzed side. Now we'll put local on the opposite side.
there is a very interesting way I look at the muscles of facial expression is by asking a question, how do fish smile? Or do they even smile? So the fish do not have the muscles of facial expression. The muscles of facial expression evolved much later. Satish, whenever you are ready, please interrupt, okay?
Yeah. Please.
So they came, so there is an ancestral platysma. Therefore, the muscles of the face are innervated by the 7th nerve, whereas mastication is by 5. And the muscle started coming up from the neck upwards. The differentiation. Yeah. You inject it?
A little bit. I will inject little more. There.
It's something to think about. Yeah.
Yeah, I injected a little bit.
Yeah.
Slightly superiorly you need.
So you just have to go, somebody asked, so you have to just go within the bulk of the muscle and just inject. And you can inject in 2-3 points. Yes. That's what she does. She does this test, then she does Botox for 2 or 3 sittings, and then she will do what Satish is. But
and
that's
then DLI.
Yeah, but DLI, going straight to DLI makes sense.
मुँह खोलो, दांत दिखाओ.
It's very, very rewarding. This is also something which you can do.
See, this is because of the swelling of the local.
Yes.
You know, otherwise it has improved immediately.
Yes. It has improved.
E karo beta. Yeah.
Still we can wait for some time.
Not aamat karo.
Yeah, this is because of the local. This is fullness because of the local.
Yeah.
See this lip has gone up because of the local. Otherwise, मुँह खोलो, दांत दिखाओ, मुँह खोलो.
No, better.
Yeah. It's in the one line only now. It's not getting pulled down.
दांत दिखाओ.
Downward movement has gone away.
Yes. So we'll do a complete DLI. See, incomplete DLI means the persistent problem.
Yeah.
So this was for the test. Now where to inject for the resection? Inside. For the resection we will inject inside. Okay? See the local coming inside?
Yes.
But still I will inject a little bit more.
Somebody is not wearing the gloves. Please tell them to wear.
Yeah.
Risky.
What? You want whiskey?
Risky.
Risky.
End of the day, whiskey.
So now we are all set. We are all set for DLI resection. वो ले लिया?
Many people joined little bit late. One question is very much in their mind, is doubt that what about the protocols for post-operative, post-traumatic facial palsy, where the nerve is intact radiologically, but have some hematoma over there, or but means anatomically nerve is intact, but how much you will wait when you will go for the you can say decompression, whether you go for decompression or not.
What is the status of the nerve? Paralyzed?
Yeah, paralyzed, of course.
And when after how long after the injury?
Means suppose
He's
the patient
asking.
comes to you, suppose patient comes to you post-traumatic after 5 days, 10 days, and radiologically nothing
comes
is
to
there.
you, comes to you is a different thing.
Good is there.
See, the most important thing is, when did facial paralysis happen?
Immediate.
After the injury. Immediate.
Yeah, immediate.
Immediate. Okay, and it's been 10 days now.
Yeah,
So
10 days,
best
1 week,
is
10 days
the patient has come after 10 days, best ENOG done, electroneuronography. That will tell you. Get electroneuronography, and first of all, CT scan is not 100% sensitive to identify microfractures.
Yes.
So
And
don't rely on
suppose it
CT
happens
scan
after
much.
sometimes 1 day, 12 hours, 24 hours or 48 hours, then it will be worse swelling.
Now the most important
Rajeev?
thing, are you getting the picture?
Yeah, getting.
Yes.
The most
Rajeev?
important thing is,
Yes, yes.
Okay. Let him tell.
yeah, see, section kar. एक जन और पकड़, इधर आओ, उधर आओ. The most important thing is where to make the incision. See, mind it, this is mandible, and our muscle is going in the lip. Muscle is going in the lip. This muscle evodes the lower lip. It brings the lower lip down. It pulls the lower lip laterally. Three functions of this muscle. And this comes into the lip. As it arises from the mandible, ascends superficially in the lip and merges with the orbicularis oris. Now, this is the vermilion border, and see, this is the orbicularis oris. You are not supposed to resect the orbicularis oris to compromise the oral competence. So
that's why you are going from the mucosal side.
Yes, that's why section. First of all, stay a centimeter away from the gingivobuccal sulcus. At the same time, avoid going into the lip. If I go here, I will ruin everything. Got my point?
Yes, yes.
You are not supposed to go in the orbicularis oris. So
we have to go into the depth.
Yes, 1 centimeter away section up to the midline. See this? Yeah, this is DLI. See this muscle fiber? Can you see?
Yeah.
Yes, yes.
Can you see very clear?
Very clear.
This is DLI. Now, as you go in the depth, because I told you, it ascends laterally. So now, once the lip part is denervated, I will go in the depth and divide towards the mandibular part as well. See now.
It is a bit dark, Satish. We are unable to see.
Now, see this?
Better.
Better?
Better. Very good.
See now, I am dissecting this mandibular part as well, completely now. Can you see? These are the fibers ascending. These are DLI. Try to understand.
Wait. Yes.
And now, from where the mandible they were coming, I have completely see the mandibular surface.
Yes.
Totally separated.
Completely done. Procedure done. Hemostasis a little bit. Only one tool required is a monopolar cautery. That's it. See this? Complete segregation. Leave it. Now, we will suture this. That's it. See, this is done under local anesthesia with no issues. Mukh kholo. Daant dikhao.
Zoom out.
Zoom out.
See this minimal now. Daant dikhao. See this?
Yeah.
Unsightly look, the earlier it was going like this completely. See that? Mukh kholo. See now it is much better. See this? Hello?
Yeah.
Yes, we can see.
That unsightliness of the lip at the rest and the opening the mouth, where because of the unopposed DLI, it was going to the opposite side, everted, down, everything is taken care of. So
and the lifting of the upper lip on the affected side can be done with the help of a slings.
Yes.
That will balance the two,
yes.
The upper lip.
Yes, it is done.
Beautiful. It's just that the Indian patients are usually not willing to allow you to touch on the normal side. It's a bit of a challenge. It needs counseling, and therefore that Xylocare injection test, it helps. They get convinced that, if we weaken this, they are looking better.
Hello?
Man of the match case of the day.
Yeah, that is the next case, and believe me, that is most interesting. Again, a very simple situation.
Even this one was the man of the match case. I would say it's short and fast.
Yeah, fast.
Short and sweet.
So the next case is an elderly man who had, somebody asked about the malignant otitis externa. That patient had a skull base osteomyelitis, which is now totally recovered, doing well, and had a grade 6 palsy for long. So, what we are going to do in that? See the slings. There are variety of slings one can think of. We will be using different slings for him to give him semi-dynamic, not only static suspension, semi-dynamic suspension. So I will tell you. ये पिक्चर जा रहा है? नहीं, जा रहा है. इधर मेरे पीछे आके लो. नो दिखाओ, इधर इधर दिखाओ, दूसरा बनाता हूँ. See, these are the eyes and oral commissure. So for the slings to work, we have to give him slings for many regions. Number one, his ally is paralyzed, that's why he has a nasal blockage. So we'll put a sling from ella to the temporal region to pull it. Then we'll put a three-prong sling, prong.
Yes.
From the upper lip, lower lip and angle to the temporal region. Okay? Then we'll make some sublabial groove. At this point we'll try to. Okay? And fourth and the most important is a semi-dynamic. And what we'll do, this is midline, this is the same side, this is the modulus. One sling from here, inside from midline to this, and another thing around it, and that will be pulled and stays to the mandibular periosteum below and laterally. So that will give him a semi-dynamic sling over sling. This horizontal and this is vertical. So this face will look quite normal in resting as well as in dynamic condition. This will not look lax, flaccid kind of a face. Though it will not give spontaneous smile, but it will give him a very good appearance. So there are variety of slings, being used for facial, but this is the best one. So this is a semi-dynamic rehabilitation, and this is for elderly people where you cannot do massive procedures like gracilis and all, because of in elderly we don't do this free flap, and procedure like masseter, even the muscles are not very strong. So this is the best option for them, give them a good quality of life. Any questions?
Rajeev, chai kisko pila rahe ho?
मेरे लिए. And in 5 minutes time we are starting this and finish very fast.
Okay.
Any meantime we can take questions.
Would you worry about the mental nerve? How to avoid it?
Yes, mental nerve runs in the midline between the mandible and the lip at the middle region. So generally you don't go there. We don't do anything to it. Why to go there?
Okay.
Fast.
Facial atta has been harvested, Satish?
No, harvesting first. The other team will be harvesting the facial atta.
Acha.
And will not take time.
So you will create slings, multiple slings, and then use them.
Yes, multiple
And
semi-dynamic.
Satish, superiorly you put it around this lower end is understood that it is put around the lip or angle of mouth. Superiorly you put it around the temporalis, tendon, muscle, fascia.
Above the zygomatic arch and superficial temporal fascia.
Satish, would you consider a brow lift in these cases? Because in these cases, the brow is totally flaccid and collapsed.
Yeah. What?
For that, they do superior.
Eyebrow lift.
I didn't get. Can you repeat?
Eyebrow lift.
Eyebrow.
Yeah.
Then you have to do a brow lifting procedure.
Brow lifting procedure.
That's a very interesting. I show you.
इसी में दिखाओ semi-lunar cut जो कर रहे हैं उसी picture में.
हाँ? Which one?
Same picture में भी दिखा सकते हैं.
इसमें दिखा देता हूँ. So the eyebrow lift is I forgot to show on the cadaver. That's why I told you several procedures are left. This eyebrow becomes flaccid.
Yes.
So the procedure is brow lift and it improves the appearance like anything. So what we do, you give multiple 4 or 5, 1 or 2 millimeter size cuts with a knife over the brow. 4 or 5, okay? Then pass your suture through it pass your suture through it, 4 or 5 suture to the hairline, to the level of the hairline.
Yeah.
Okay? 4 or 5 sutures, then pass through a titanium plate, the sutures. Pass through a titanium plate, fix the titanium plate in the bone, calvarium bone, and suture them, pull these sutures and make a tight knots over there. So this will keep them pulled and the knots will be remaining in place with the titanium plate and the brow will remain lifted. So 4 or 5 suture will lift the brow uniformly. This is brow lift. And it gives a good appearance.
I think that's very important because the collapse of the brow, that flaccidity of the brow looks very unsightly.
Yes,
so this is a very good procedure.
Satish? Hello, Satish?
Yes, madam.
There is another procedure when we cut out a semilunar sleeve of the skin above the brow.
Yeah, tightening. That is tightening.
Tightening.
Yeah, but
yes. That is also done.
That may give asymmetry. Sometimes you look from front, no? That may give asymmetry. Okay. That is something like you make remove this kind of a skin and suture it.
Yes.
Suture it.
Yes.
Tightening. So this brow lift is ideal. A lot of people do it endoscopic now. Brow lift. So they go through the eyelid. They go through the eyelid incision and go with the endoscope up. But this small incision here in the brow are never visible. So it is quite good a procedure.
So what about in children? How will you do the facial nerve reanimation in children? There's a question from Nigeria.
Children are best if, depending upon the the duration of palsy and the cause, you have to take a call. Duration of palsy
almost
will
similar as the adults. Almost similar as the
adults.
Children
have good results.
Yes. And what about the vertical portion of facial nerve? Suppose it get damaged, then which graft would you recommend? And any difference in suturing of that graft? Vertical portion.
You can't suture in the temporal bone. The tissue glue you can use. That is equally good. Graft, ideally sural nerve. If you can bring, otherwise this greater auricular, but that is inferior. Sural nerve is amazing.
And vertical part, Rajiv, is good because it has got a fallopian canal as bed. So it is, Satish is right. We can even put glue works equally good as the suture because there is a bed there, bony bed there for the nerve.
Never use nectacryl. Cyanoacrylate is contraindicated. It should be tissue glue. That cyanoacrylate starts or gives intense fibrotic reaction.
So that is Baxter glue we use usually.
Same like for CSF and the 2 component.
Yes, CSF wali.
So with like this patient DLI, young patient, their appearance improve like anything, because this movement of the lip going to the completely to the opposite side makes them, limit them going
from smiling, expression.
In the social function and all. This looks so bad.
Any role in Bell's palsy, role of this methylcobalamin and other, any evidence-based methylcobalamin use of, because we use all, and in fact everyone use methylcobalamin in these cases for months or weeks. So how it works and is it really effective or
placebo?
Yes, totally placebo because things are happening at the site of injury and this cobalamin is not going to serve any purpose there. If scarring is happening, it is not going to help. It is just a neurotonic and a placebo effect.
Yeah, just to give the patient something is taking and getting.
Yes, keep them busy till this procedure is decided. Because scarring is a big issue at the site of injury and we don't know. It starts building after the 30th day of the injury. So, neurotonic is not going to help them.
We have almost 7,000 right now.
Oh, really? So now we are starting in a minute's time. Hello.
Yes.
Rajiv, just I think there's some technology to do surveys, online. Moaz Tarabichi, he conducts on his that thing. We should try to incorporate that. Some questions and some opinions. Maybe we can start taking. People,
but I think since we have library in front of us.
If you are tech savvy, I'll connect you with Moaz. I think he and Mustafa. So they have.
You can do. You can try in Stepis Carnival.
No, Stepis, whichever. I mean, whenever you can. So there are some instant surveys, very friendly for the audience to reply.
You can do online voting also, like which tech. So many questions are there.
Yeah.
Online voting option is there, but just because so we get disturbance in between, that's why.
Okay, we are not doing it. Okay. No, silently. This can be a data, not to interfere. This can be a data which can come. So we can improve upon our next. If it's on the same topic, you want to do something else.
Yes.
So Ashish.
Yeah.
My sling, the most important sling, the lower I don't think will be required. The upper two slings will be appropriate for him.
Sure.
I'll show you the video. The pre-op video. कहाँ है रे? Pre-op है? उसका अजय के पास था. Give my phone. I will show you. Can you show through my phone? So the procedure will not take more than 10 minutes.
What about the protocol for herpes zoster post herpes zoster as well facial palsy after 2-3 months? What is the protocol? When you recover?
See, neuritis, if it doesn't improve, there is the same protocol you have to follow. Most of the time it improves with antiviral, steroids, antibiotics and all that. And after 5-6 months doesn't improve, get EMG. Is any possibility if you find? If not, then like any other facial palsy. Discharge हो गया? So I will show this,
Dr. Kumar Raja from Andhra is asking how about using a fat lift for inducing fibrosis around the future?
What? Left lip? Kya? What?
Fat means you putting the fat around the future line.
Fat around the?
Fat around the sutures or that nerve sutures
to induce fibrosis.
More fibrosis.
Fat around the nerve sutures.
There are those threads with those.
After the nerve anastomosis, coaptation ke baad, to increase the strength.
Threads.
We use a vascular bed rather than a fascia round. We will try to use that for the vascularity and to avoid the fibrosis.
Yeah, vascular bed is always good.
Yeah, always.
Yeah. I'm showing you the video. Anyway, can you show this? Are you getting the picture?
Yeah, we're getting up.
The mobile picture, are you getting?
Yes.
Yeah. Yes, getting. Beautiful.
Can you see this, old man?
Yeah.
See this? Again. See the flaccid, entire face is flaccid. This is completely drooping. I'm going to the opposite side, and this sling with taking the lip above will solve the issue. So I may not use the lower sling. I saw the video just now.
The lower sling does not appear to be necessary.
Yes, the upper sling is very important, and because of this the ala is collapsed. So we'll put a sling to the ala also to bring it laterally. So that will open up the nose as well and the lips, and it will give him a very good picture on rest as well as on movement, but it will not give spontaneous smile. This is static slings. Jaldi. Local.
You must be getting so many cases of facial palsy, traumatic facial palsy, maybe post-surgery. What is the most common cause you found in your practice since so many years? Surgical mistakes, you can say, iatrogenic, you can say.
Yeah, iatrogenic is common.
The commonest site is as the second genu.
The site and cause. What was the primary cause, if you can get it?
Generally, people are trying an inside-out technique. At the second genu is where it gets injured the most. And in my experience, this is the kind of thing that I've seen.
What Rajeev? There are two different situations. If it is canal wall down or canal wall up. In canal wall up cases, when they are looking for antrum, many times they don't find the antrum and start drilling a bit below. And that way they enter into the vertical part of fallopian canal as well as the posterior or lateral semicircular canal. So maximum injuries happen there. Whereas in canal wall down, as he is telling, inside out mastectomy, they just injure while drilling there, they just injure the tympanic portion as well as the second genu. And there they can also injure the dura because the burr goes in an uncontrolled manner. The facial nerve goes as well as there is a tegment defect also. So in canal wall down, it starts from there, and canal wall up, they go from behind and injure mostly the vertical part and the second genu.
So we are all set. The facial atta is being harvested. And वो strip बना लेना मेरे को बता दे छोटी छोटी सब size.
Did you put drain in that case? That facial and mesenteric anastomosis?
No. Just a dressing. Simple dressing. There was hardly any bleeding. So it is all set. So my message to everyone: facial nerve is something which is a very important issue for ENTs, which is a very neglected issue by neuro people. Neurologists, neurosurgeons, practically they don't understand the science of facial nerve because it is not their subject for that matter. And ENTs, many of them are not working on facial nerve. Believe me, this is a huge subject. This in itself is a complete science, full subject, and a lot of work going on this subject. And a lot of new procedures are coming up, new diagnostics. And for future, this is an amazing subject.
Let me tell you, the guy, there's a top man in Beverly Hills, and for him, the cross nerve with the free gracilis, how much does he charge? $90,000 US.
Yes. Because this is a cosmetic aspect as well.
Big ticket surgery.
This is a cosmetic aspect as well.
Dr. Sunil Savdani from SMS, Satish, you are total package. Proud of you.
He has been my teacher, very favorite teacher.
Yes.
Thank you, sir. I learned my lot of otology practice and tips and tricks in otology during my residency from him. He's amazing, very meticulous.
The truth is nobody believes when you say no, you learn from somebody. You keep praising us and anybody and everybody. No offense meant to that person, of course.
No, sir is very close to me. Believe me.
Sir is very. Rajeev Pachauri.
I did not mean him. He just keeps saying I learned so much, and I don't know from where he has learned what.
Yes.
Microscope.
It is all organic for him.
Ready?
Rajeev Pachauri is saying mesmerizing since morning. You have to stay till last.
Rajeev is also from SMS.
I am worried about my marriage. I'm not worried about it.
Voice. Hello. Yes.
Are you getting picture?
Yeah, we're getting microscopic picture.
Okay, microscopic picture of the face.
Yeah, zoom out a little bit.
Yeah, that is the
zoom out.
Lowest magnification. Zoom out kar isse kar. Yeah.
But it is okay.
Yeah.
When you make the position, things will become clear.
Yeah, because with the 400 something. I will focus at different times when I change the position. चौड़ी ले बड़ी और बड़ी लेना मैं काट लूँगा तो चौड़ी ले लंबी और बड़ी. So now my first incision, give me a good scissors, long knife pottery fast. I have to make pockets. So my upper end of the fixation of the slings is going to be the temporal region here. See, and the tunnel I'll make will always be in the SMAF, not deep to the SMAF. That is important so that you don't damage the facial nerve branches, for that matter.
Okay. Yes.
See this? Now my scissors. Long scissors. Give me a good long scissors. See now. Can you?
Yes.
Tooth forceps. Now the area, see this. I am in the suction rack. Plane of the SMF here. And I have to make a long tunnel. इधर ध्यान रखे. छोड़. Give me good scissors. देखो. लंबी.
In that case, we tested with the lidocaine. For this, do we have any test just to assess whether this will work or not?
No. This is not dynamic or something.
Semi-dynamic it is.
Hello.
See
you
now
just
where
have
I
to
reach.
know which axis, which angle it's going to go.
See, I am at the modulus now. Can you see?
Yeah.
I am at the modulus now. Okay?
Satish?
Yes.
Satish, just a minute, I want to talk to you.
Right.
Dr. Vijendra, the great otologist, has called up just to tell that he is watching your program since morning and he is being mesmerized. He wanted me to pass this on to you. That he has learned so much. He is really enjoying every bit of it. He wanted to convey to you, but because he cannot talk to you, so he conveyed it to me.
Oh, thank you,
He is
sir.
passing on his thanks. He is a great
man.
surgeon himself.
Yeah, no, we all know he is greatest of all.
Greatest of all, yes. And he is telling, pass it on to Satish, that I have been mesmerized since morning. Sitting, it is a great day. Sitting and observing him, watching him.
We have seen many of his facial nerve cases.
I am blessed, sir, to have you with us watching. And sir, we would like to have your more input. Anything you want to contribute. See, I made 2 incisions at the vermilion border. Can you see?
Yes. Yeah. Centralize, please. Centralize.
Yes.
Now it's good.
Yeah. Give me scissors. And now I will make the pockets here as well. Right at the vermilion border, I will go towards the modulus.
One more message from Ravi from Oman. He is saying it day of webinar, they are not working. They have stopped working on the day of, since morning they all are with the mobile and the laptop. And being Sunday, the working day over there, even they are not working. Oman, Ravi Shankar, you know.
Either. Thank you, sir. Oman, I have many good friends, very anti-surgeon there. I have been there many a times.
Yeah, last was
they are from India, many of them, and very good friends.
Ravi.
Dr. Jagdish Nayak, Ravi is your class fellow.
Yeah.
See now, I made a pocket coming to the modulus. Can you see this all the way?
Yes.
Now see what I am going to do. Artery, long artery. Give me the sling. Chodi wali. Yeah, see, this is my one sling. This is facial atta.
Yeah.
And I will make into strips here.
Satish?
Yes, madam.
Can I pass on another big compliment to you? So it is Dr. Morwani called up. He says he is watching since morning. He is unable to connect. Dr. Majumdar is passing on his compliment. He says, tell Satish he is the Sushruta of the modern medicine. They are
Majumdar sir is
passing
probably the
on
senior most
compliments.
TNT in our
Really
country.
proud of you. Yes, this is proud for our
See now,
countrymen.
these two slings, thank you sir, are going to go there, and this I will suture to the modulus.
Okay.
And this will go here and come. See now how it will pull. Give me the artery. So now we'll just pull this is all through the SMAF layer, nowhere else.
Yes. Superficial muscular aponeurotic system.
छोड़ उसको, छोड़ निकाल. Now what I will do, उधर रखना, रख उधर.
Satish, one thing is there, I have seen, they get loosened up after 6 months. They're not very effective when you watch these patients after
Not
6 months
really.
to 1
The
year.
facial aja sticks well. See,
Zoom
these
out
are.
little bit, if
This
possible.
is something not like I am connecting with any nerve or anything.
Satish, please zoom out. Zoom out little bit.
Yeah. Idhar se down.
So
Yeah,
TISA is working on a bionic face. They are looking at implanting some electrodes in the muscles at strategic points.
See, boss.
They are hoping that through a Bluetooth sort of a technology.
See, boss, what I am doing.
Yes.
This part is being pulled through this tunnel. Okay.
Okay.
And now we'll first suture these to the orbicularis oculi. These two strips here. Inside. See this? No. Remove this. Yes. See, two tunnels, separate tunnels. Can you see?
Yeah.
Yeah. Now we'll suture it to the inside. Where is that? Yeah, inside. See this orbicularis oculi, oris, and this tunnel, this fascia will be sutured. And then the suture will take along with the modulus as well.
That's fine.
इसको इधर से भी निकाल. Yeah. One more. Yeah. Yes. Needle. Yeah. And see, the needle will pass through the modulus as well.
Centralize, please. Centralize.
Yeah. See my pull.
Okay.
Modulus. See now, this will pull the muscle. And one more suture. I'll show you. This deep suture is very important. Tooth. Now, this is to the modulus. Give me the other needle, long needle.
We are suturing the upper sling to the modulus.
Yes. Already suture to the
Orbicularis oculi oris.
So this will be stable, you know. Just 2 minutes time and it will be over. Yes, now.
So you were telling about horizontal and vertical slings.
Yeah, that is for the lower lip. I don't think it is required in this patient.
Okay.
That is for the lower lip, madam. If it is a complete flaccid lower lip paralysis, if it is.
Okay.
His angle was a big issue. It was not so flaccid. You saw the video.
Okay. Okay.
Now, this was to the upper part. And this, see, this, once we suture this vermilion border, it doesn't leave any scar. Okay?
Scar is not there.
Yeah, not at all. Not at all. No. Now, this, the lower one, the same way. Because it should bring the lower lip, upper lip and the commissure together. Then only it will be effective.
So, upper and lower sling, both are first suture to the orbicularis oris and then at the same time both are suture to the modulus.
Modulus.
And see, the patient will have immediate improvement because we'll tighten this right now.
Slightly you over tighten it, huh?
Yes, little bit. Now this part is done. Now see the angle of mouth. The control is in my hand. Can you see?
Yes.
And this control is uniform. The upper lip, lower lip and the modulus. Can you see the nasolabial fold forming?
Yes.
Sometimes. Can you see this? For people who have a completely effaced nasolabial fold, what you can do? You make a small incision and take from below the subdermal sutures and pull it to give a deepening of the suture line. Okay? See now the dimple.
Centralized.
Yeah. See the dimple now. Can you see
Yes,
the dimple now?
Sir, what is the suture material that you've used, sir?
PDX.
Okay.
PDX. You can use Vicryl also, but PDX. The best.
PDX stays for long, 100 days, so it is more stable than that.
See now, it is being pulled over here. See now, depending upon, see the dimple I have given. Can you see?
Yeah.
Yes.
So now the face will not be flaccid. See this? And after
this is overcorrection. Yes.
Overcorrection, little overcorrection. And we'll take around this, once more around this suture, completely around to the depth of the muscle. Once more. So that
you are suturing it to the temporalis muscle and fascia.
Yes, fascia. Over the zygoma. We'll take another one and the excess we will throw. So this way, see now, the flaccid palsy, the lip, it was so flaccidly paralyzed, it will give this a tone. Got my point?
Yes.
This upper lip I was pulling, see this upper lip has opened up this nasolabial also. Sometime otherwise you have to put a separate strip into the, the sesamoid cartilage in the LI here to pull this. Okay?
Yes, sir.
This upper lip.
Multiple slings can be there.
This upper lip has opened this space as well. See now.
For a few days, they look like they are constantly smiling. Even if they are angry, they are still smiling.
Yes, it happens.
No, it is because the mouth is not closed. Because of the endotracheal tube. Because of the endotracheal tube now, it looks like. See now? But it will not be a flaccid. In an elderly person, it is very well appreciated. They do very well.
Brilliant.
Super.
What is the post-op means or follow-up means?
Now, more slings if required. More slings where you can put what I was telling. One at the nasolabial fold, this thing, the LR cartilage here. Right from here, one sling from here to here. Put in the sesamoid cartilage, take into suture and pull it laterally, and it is already pulled by the upper lip. So I didn't put. Second is for the eye.
This much suffices.
Yeah, this eye had a good closure if you saw the video. So I didn't do anything to the eye. See this? It had a good closure. Sometimes
So,
this
Satish,
lid
I
is
want to
drooping.
know.
You can put another sling to the medial canthus here. Yes?
Okay, Satish, have you stopped using gold implant? You're only doing cartilage?
Yes, yes.
Okay.
Almost. He just told me yesterday.
And what I was saying for the lower lip, the semi-dynamic sling, we make 3 openings at vermilion border. One here, one angle here, and one in the modulus. And put a horizontal 1 centimeter wide, the fascia lata sutured at all 3 places. Then another fascia around the first fascia, pull like a pulley and suture to the angle of mandible. So that gives a dynamic, semi-dynamic pulley.
Okay. So the other end of the vertical sling, where does it go? And other end of the loop, where does it go?
Yeah. So now finally we will suture. This is good tightening. Can you see?
Yeah.
And we'll suture finally, and that will be over. So
what is the long-term outcome in these cases?
Huh? What?
Long-term outcome after
it's
6
good.
months, 2 years?
The fascia is stable. It's not going to leave the place. So it remains good. The tone on the side of the face remains good. Their appearance at the time of rest looks almost normal. Difficult to appreciate. And that is what the sling can do. There are a variety of other slings available you can do, but this is the simplest one. And we have given a good nasolabial fold as well. Any other question, please?
You give steroid post-operatively in this case?
No. Why do you give steroid?
Nothing to do.
Nothing. We
No
just
nerve is there, nothing is there, just a tissue. You can give carboron coat rather.
We just made a tunnel in the superficial musculo-epineuritic fascia and pull through these multiple sutures around the angle of the mouth, taking both the orbicularis above and below and the modulus. So 3 anchoring sutures to the muscles and pull tightly little over to the zygomatic. We could have added according to the need to the the lateral ala, to the lower eyelid, upper eyelid, wherever you can give tightening, you can, and the lower slings for the lower drooping, which was not required.
You want to come? For time?
Paramita, any questions?
No, sir, no questions. I think you have explained everything in detail, and all points you have covered, sir. You have shown us something.
Nobody did expect that it will run for so many hours.
See you on Thursday. See you on Thursday, 4 p.m. for the live surgery. On Sunday, next Sunday is a big event. That is stapes, full day stapes. With lot of discussions on each and every aspect of atherosclerosis, stapes surgery, advances, variety of situations, variety of difficult situations by the masters. Amazing it is going to be, I believe. Stapes.
Let's see. Okay.
So it was a marvelous demonstration, sir, today.
Thank you.
Enjoyed every bit of it.
And big thanks to Madhuri madam for being with us.
Thank you.
How much knowledgeable
Thank you
she
to
is.
Madhuri madam.
We can end it with your smile, Madhuri. We began with Paramita's smile, or maybe a wink, or maybe your orbiculars oculi you can use.
Thank
Perfectly fine.
Great madam.
Orbicularis
Great Ashish and Ashwin.
No, oculi. Akhiyon se goli mare.
Oh yes.
Varman is there.
Yes, sir.
Mr. Varman is there. I think.
Yeah. For 9 hours surgery, marathon surgery. I mean, actually, I was
nine and a half hours.
Yeah, my colleagues also that we need to learn a lot from Dr. Satish Jain and the entire team.
Just send message to your staff all over the country.
Yeah, the dedication really, it's something which is amazing. I mean, on behalf of Sun Pharma Care Division, my sincerest thanks from my bottom of the heart. I mean, very thanks to Dr. Satish, Dr. Madhuri Mehta, who has been given lots of comments, and also Dr. Bumkar.
Yes. Dr. Asim Desai also.
and Dr. Ashim Desai, as well as Dr. Rajeev Pachauri, and as usual, Dr. Pamita.
Thank you, Rajeev boss. Thank you, Paramita. Rajeev boss. Ashim and Ashish.
Thank you so much.
Thank you, boss. Satish, Sakshat Saraswati. Amazing, amazing, absolutely amazing.
Always.
Yes,
So nice to have you.
Brilliance is only matched by your humility.
Doctor, I will just like to say a last thing that Dr. Pratibha Mane from Thane, she has written for you. We are all so blessed to be born in the era of Dr. Satish Jain. He is a university by himself. AOI must facilitate a sir with an award of Master of ENT or a Superstar of ENT title. Such
He is beyond that. He is beyond that now.
He's beyond that now.
Such an humble human being, an epitome of an ideal teacher. May the Almighty bless him with lots of happiness and good health.
Thank you all.
We can call for the day now. Thank you, Ashish boss.
Thank
Dr.
you.
Ashim
See
boss.
you Thursday, 4 p.m.
Bye, Manjari. Bye, buddy. Ashim. Thank you,
Once
Mr.
again, sir.
Rajeev.
Thank you, sir. Dr. Satish, sir. Thank you very
Thank
much.
you all.
On behalf of Sun Pharma.
Bye.
Bye.
Bye.